Hi, as we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as the President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry because he knows the details, nuances, and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visit so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
I'm a periodontist. A periodontist is someone who is a gum specialist. As we all know, teeth are held in the mouth because of the strong gums. And if the gums are not strong, the teeth will tend to fall off. In India, a lot of people suffer from gum diseases. Almost 80% of the adult population has some form of gum disease or the other. One of the points regarding gum disease is that it is entirely preventable. So if you visit a dentist regularly and get all the regular checkups and treatment done, you can have a teeth that will last for a lifetime. You need not wear any false teeth or dentures, and you can chew happily ever after and have a well balanced diet. The key to it is that you must have good oral hygiene practices, clean your teeth regularly, and visit a dentist and do all the treatment that is recommended by a dentist.
Now, we have our branch is periodontology, and basically it deals with the structure which is called as periodontium, which in common terms, which means the structures which support the teeth. Now, a structure which supports the teeth means that if tooth has to remain in oral cavity, the structure have to be in a healthy state. Now, we always, as you know, concentrate on treatments like orthodontics, that is treatment of malocclusion, root canal treatments. We have FPDs, RPDs, replacement of all these missing teeth, which gets concentrated too much. But if we go to the background of this and we realize that can we have an orthodontic treatment without a healthy periodontium? After all, movement of teeth is just based on bone and periodontal ligament, which is a part of periodontium. Have you asked any endodontist would they do a root canal treatment in a mobile tooth? They will not, because after they see an X-ray and they see the extent of caries, the next thing which they see is the amount of support which is present. Take a tooth to them which is mobile, and the thing they will ask is whether the prognosis is good or not, whether we should do a root canal or not. So that means if you have to have a successful root canal treatment, the baseline is a healthy periodontium. You give RPDs, you give FPDs. Can you give a FPD on a tooth where the adjacent teeth are mobile? No. Can you give a RPD when you have the adjacent teeth mobile? No. So that means even in your prosthodontic treatment, the baseline for a healthy prosthodontic replacement is you have to have a healthy periodontium of the adjacent teeth. The fact that the basic principle of FPD, the Antes law, is not given in any prosthodontic terms, it is given in periodontal terms. It says the periodontal area of the supporting structure should be whatever it is. So that means the baseline of dentistry is the healthy periodontium. So whole dentistry treatment revolves around if you have a healthy periodontium. You cannot do any treatment in any department if the periodontium is unhealthy. So that means if periodontium has to be healthy, the branch periodontology has to be surviving, and dentistry just cannot survive without periodontology.
Good morning everyone, this is Dr. Vishakha Grover. I am a periodontist by profession. Periodontist is a dentist who specializes in the care of gums around your teeth. In our country, gum diseases occupy the major proportion of oral health problems. Almost 90 to 95% in every 100 people are suffering from gum diseases. The worst part of these problems is that these are very silent or do not causing any signs at the early stage. Only in advanced stages, the patient may suffer from some pain, bleeding, or some unsightly appearance of the teeth. Recent research has highlighted that consistent inflammation in oral cavity may lead to other body problems also, for example, cardiovascular diseases or diabetes.
Good morning, Dr. George. Do you need any help? Dr. George, you there?
Good morning. Good morning. Can you hear me?
Yes,
Yes.
now we can hear you, sir.
Yes. Yes.
Good morning,
Can you hear me
George.
also?
Gopal here.
Hi, Gopal.
How are you? George, can a small help? Can you just go on to your name and instead of GP, can you just rename it as George Pelacos so that the viewers, they know? Because otherwise they will just see it as GP. You have to just go to your, on the top, on the right, on the... You just go on to your name and instead of GP, can you just rename it as George Pelacos so that the viewers, they know? Because otherwise they will just... No, you just have to rename yourself. Just you have to go to the right screen on top, and then there's some 3 dots.
Gopal, everybody's talking together. I hear 10 voices.
So you just have to rename yourself. Just you have to go to the right screen on top, and then there's some 3 dots.
Wait. Gopal, everybody's talking together. I hear 10 voices.
So you just have to rename yourself.
Okay. I have to rename myself.
And then there's some 3 dots.
Wait. Gopal, everybody's talking together. I hear 10 voices. Okay. I have to rename myself. Wait. Everybody's talking together. I hear 10 voices.
Thank you so much, sir. Thank you so much, sir.
Can you hear me?
Yes, sir.
Yes.
Yes, sir.
Good. Good morning to everyone.
Good morning.
Good morning.
Can you hear me?
Yes, sir.
Yes, sir.
Good. Good morning to everyone.
Still echo is there.
There is echo.
From, I think from Dr. George's mic itself. If you're logged on to any other platform, you have to put it on mute. I'll check mine also.
Is it coming from me? Do I need to change something?
No, have you logged in just from one device? You're logged
Yes,
in
of
just from
course.
one device. Yeah, then
Yes.
fine. Then it's not from your side. It must be from someone else.
Is it coming from me? Can you still hear me?
Yes, now it's fine.
Yes, sir. Loud and
I
clear.
think your colleague was right. I was also in the main auditorium. Apologies for that. My mistake, my bad.
Okay.
At least sorted. That's the important thing. Yeah.
Yes.
Good. Let me just try and how do we go back on the? Yep, there we are.
Yes.
Can I share my screen with you actually?
No, not now. After we
Not now,
introduce,
not now.
after
Okay.
we introduce,
Let me know.
I will
Okay,
let you
okay.
know to share the screen the time you share your screen.
Sure,
Just
sure.
a minute to go, sir. No problem.
You were absolutely right. It was me. I was logged in at the same time. Good. Much better. Much better.
Yes, Jilu, 9 o'clock. Let's go.
Good morning, one and all. Today we are going to start our new wonderful session with our chairpersons, Dr. Gopalakrishnan and Dr. Neeraj Deshpande. Dr. Gopalakrishnan did his entire dentistry, BDS and MDS in periodontology at Raja Muthaiya Dental College and Hospital, Annamalai, monitored by the famous dental surgeon and dean, late Dr. B. Srinivasan. Dr. Gopalakrishnan has completed his PhD at Thammasat University, Thailand, mentored under the global luminary in periodontal plastic surgery, Dr. P.D. Miller, and is the first life member of the Indian Society of Periodontology to have an international PhD. Dr. Gopalakrishnan is currently working as the Dean, Professor and Head, Department of Periodontology at Dr. D.Y. Patil Dental College and Hospital. Dr. Gopalakrishnan is the Indian ambassador and an international member of the American Academy of Periodontology since 19 years. He is the board member and Indian ambassador of the International Society of Periodontal Plastic Surgeons, USA, and has lectured at the society's annual meetings. Sir has received the Dean of the Year Award at the Indian Health Professional Awards in March 2021. Dr. Gopalakrishnan has held positions of Executive Committee member of the Indian Society of Periodontology, and currently he has served as an office bearer of the Indian Society of Periodontology as a scientific program convener of the society from 2018 to 19. He has held faculty appointments at leading prestigious institutions in India and abroad. He has several publications to his credit in leading national and international journals. Dr. Gopalakrishnan is also the editorial board and peer reviewing committee of leading journals. Coming to Professor Dr. Neeraj Deshpande. Dr. Neeraj Deshpande is an outstanding academician and an astute clinician in the specialty of periodontology, working as professor in Department of Periodontology, K.M. Shah Dental College, Sumandeep Vidyapith, Vadodara. He has more than 15 years of clinical and academic experience. He has completed his master's in dentistry from prestigious Manipal College of Dental Sciences, Manipal. He has done MBA in hospital administration and postgraduate diploma in medical law and ethics from National Law University, Bangalore. He has been awarded PhD in education from Navacharna University in 2020. He has won various awards and accolades for his clinical work, academic excellence, and research. He has lectured extensively at various national and international levels. He has more than 70 publications in national and international journals to his credit. He is an active member of various professional bodies and currently serving as the treasurer of the Indian Society of Periodontology. He is on editorial and review board of various national and international journals. Over to you.
Thank you. Thank you very much.
Thank you. Thank you. Well, good morning, one and all. It's my proud privilege. Before I go, I would like to thank the organizing committee of 19th ISP PG convention to give a chance for me to chair this prestigious session. So greetings to all office members and the organizing committee and everyone, all the viewers. It's my proud privilege to introduce my good friend, Dr. George Pelekos. Dr. George Pelekos, for those, he has already been here and lectured at our Indian Society of Periodontology annual convention in March 2015. For people who have heard him, it is a treat to hear him again. And for people who do not know him, I would like to give a brief introduction of Dr. George Pelekos. Dr. George Pelekos, after completion of his studies in medical faculty of Marasek University in Czech Republic, he was awarded the degree of Doctor of Medicine with an MSc in the area of oral pathology. Then he joined the Hellenic War Navy for more than 2 years, serving as a principal physician and oral surgeon in different naval dental bases and hospitals. He spent the next 2 years as a private practitioner in practices limited to periodontology in Athens, Greece. The year 2004, he moved to England, where he worked as an associate dentist for the National Health System. Later in 2006, he began his training in a full-time program and completed his specialization degree in periodontology at the prestigious Eastman Dental School in London. He was accredited as a certified periodontist a few months later by the European Federation of Periodontology. The year after, he was registered as a specialist in periodontology with the General Dental Council in the UK. After his graduation, he continued to work at the Eastman, initially as a research assistant, later as a senior critical teacher, and in 2013, he was appointed as a honorary lecturer. At the same time, he maintained a busy private practice limited to periodontics and implants in London and in south of England. George has been lecturing worldwide and is a member of several scientific organizations, namely the ITI IADR. He's also holding a membership with the Royal College of Surgeons, Glasgow, and he serves as a trainer for the College of Dental Surgeons in Hong Kong. Early in 2014, he was appointed as a clinical assistant professor in periodontology at the Dental Faculty of Hong Kong University. Since then, he published a good number of research papers in reputable international peer-reviewed journals, and he completed recently his PhD in Tohoku University from Japan. Areas of interest in research include clinical periodontology, periimplantitis, probiotics, periodontal medicine, evidence-based analysis. Currently, he is the director at the periodontology postgraduate program in Hong Kong University, and that is the only program outside Europe that is accredited by the European Federation of Periodontology. If you go on, the list is huge to tell about Dr. Georgios Pelekos, and more than an academician, researcher, and a great clinician, he's a wonderful human being. Thank you, Dr. George, for accepting our invitation once again, and I'm sure your lecture will be a treat for everyone out here. Thank you, and the podium is yours here, George.
Dear friend, Gopal, thank you for that. And it's very difficult to say no to you whenever you need some help. So it's very nice to be back for all the postgraduate convention 6 years after. And allow me actually, because I have 1 hour, what I'm going to talk about today, and I think it's a good maybe topic, although quite broad for our future colleagues and the current colleagues, of course, is the management of the extraction socket in the periodontal patient. And that it's a little bit controversy, because usually we're talking about prevention of teeth. I think that the periodontal patient is another special chapter, even when it comes to implants. The majority, I think, should be treated by periodontists, because periodontal treatment should incorporate it in implant treatment. Otherwise, it's going to end up as a disaster. We will see some cases. And I hope to put everything from what we know since our undergraduate years to what we know now and what we may find out in the future. I apologize, because I have 1 hour. I made the choice that I'm going to run like a rabbit. So please bear with me and keep notes. If something is not clear, I'll come back at the end of the lecture. Dear Gopal, if there is, you are okay with that? I mean, you let me know when you want me to start.
Yeah, you can. Please go ahead.
Actually, you have to disable then the screen sharing, because I have to share my screen.
I think it's already disabled. Can you just try share?
Disable participant screen sharing. Sorry for that.
Technical team, can you just allow Dr.
Yes,
George?
I'm good. Thank you. Just let me know if you can see.
Yes, we can see.
Very good. All righty. So let's, as we said, let's start immediately. And we're going to talk basically about something which is missing teeth. Remember, missing teeth is just the finding. Something is basically missing. What we're going to try to see here is that, is it important, why it's missing, and how we're going to interpret that on implant terms treatment-wise, okay? So, and why, as a periodontist, I think we should look into it a little bit more in details, because the pictures here, which is obviously something you all know from health to disease, already shows you what is the problem. Before you will extract or you lose the teeth, you have already lost hard and soft tissue. So in relation to an extraction of a conventional colleague, caries, subgingival caries, fractures, all the other things, this is already a compromised battlefield. And a bit of a fast travel, a little bit on the evidence. I would definitely recommend that you will read from the classical studies that start from Atwood in '63. Schropp is a very classical one in 2003, and quite recent. Well, it's not recent, it's almost 30 years now. Farina and Trompelli had a paper in relation to changes that follow an extraction, and we know that 3 to 6 months is really a period of ongoing changes. These changes now, you have to remember, they can be associated with intrinsic and extrinsic factors, locations in the mouth, full clearance, one tooth, neighboring teeth, smoking, medical health. Every part of these factors plays a role, and there are a lot that you can read about. And I will close that slide very fast by maybe recommending from my team in Hong Kong, Niklaus Lang, a few years back, had a systematic review on re-entry studies. Re-entry studies are studies that, we are opening the post-extraction socket and we do measurements. So they actually reported a 29 to 63 horizontal bone loss and an 11 to 22% vertical. I think the numbers are actually capturing what we just said. There are so many factors responsible on what will the final outcome will be, that the range or what you should expect, sometimes it is very, very challenging and broad. Of course, you will read thick biotype, buccal bone of more than 2 millimeters, and several other things that they can actually lead to a less resorbed or compromised situations. But how many times in your life you will have that as a periodontist? I'm afraid not many. Usually, if this happens, we maintain teeth and we don't lose them. You know where I'm heading with that, right? And there are actually, back even in '88, a classical paper by Catwood and Howell, that also same jaw, different areas have different patterns of resorption. They have a particular way of, dimensionally, of resorption. And here you can compare anterior with posterior maxilla. But again, if you look the schemes that they use, somebody will say that this actually is pretty good socket with a good bone buccally. So again, I'm not sure if this captures or includes what we're dealing with in everyday periodontology. I'm not going to go into that. I just wanted to remind you that also healing stages of the extraction sockets are very important. How, the blood clots and then the granulation tissue and fibrous tissue and calcification. So I would definitely recommend to all my dear MDS to have a very good knowledge of that. Because when you know what happens in time, then you can do extrapolations or modify your approach. So as you can see, up to 10 weeks where mineral tissue in the original socket is reinforced is actually like 2.5 months, which is quite important. Now, why do I highlight the first 2.5 months? Because from the extraction, the day of the extraction, the next 2 months are very, very important. And in several treatment protocols we're going to discuss, you will see why I think that this is a very, very important period. Again, I highlight simply the day of the extraction, what's going to happen the next 8 to 10 weeks. And you can see here, these are major stages in the healing of extraction socket. And let's start with the ideal thing, which unfortunately is not going to be your bread and butter in periodontology, except if you turn to the black side and you become what we call implantologist. I hope not. But anyway, every now and then you may come across a case like that. Remember, you need a thick soft tissue biotype, availability of really bone dimensions, which are usually thicker than 1 millimeter. You can read actually the Morton paper of the 2013 and the Kahn papers. You will see where I'm heading it. I'm heading it actually in cases like this one. It's obvious, I don't have to convince you that there is no periodontitis. I'm not sure about gingivitis, but definitely there are no periodontal issues for this patient rather than a bad luck and a bad accident. So here, only here, I would probably discuss that an immediate placement, which is again a treatment immediately after extraction, is something that a lot of your friends, prosthodontists or general dentists, find extremely attractive and very, nice for the patient and so on. I just mentioned before, allow me to go back, that there are several things you need to have. And here I forgot, obviously, to say no acute infection and no chronic infection. And chronic infection would be translated as presence of periodontal disease. Okay, so going back to that, and I'm not going to waste your time because we're not going to talk about immediate, but it would be wrong and a foul from my side not to mention it. Because yes, in some cases, it could really be the treatment of choice. But then we're going in our case that things are done a little bit differently, and for many reasons, I think periodontitis patients are a contraindication for immediate placements. So let's see the other options in relation to extractions and what shall we do next. A paper that came across to me was from the Switzerland group of Jung and Christoph Hammerle and Daniel Thoma about alveolar ridge preservation in the aesthetic zone. And basically, my question, as you can see on my slide, is, are we talking about preservation? Because in my mind, preservation is I'm holding to what I have. I don't want to lose more, or I want to lose as less as possible. Where reconstruction is I build, I expand, and so on. So what I got out of this presentation was that we have a soft tissue preservation for 6 to 8 weeks, which means basically that, you know, if you want to have good quality soft tissue to whatever you're going to do, you need to wait 6 to 8 weeks, the so-called early approach for a GBR or for an immediate placement with GBR and so on. My problem in that is, as I just mentioned to you, 8 weeks, a lot of things can happen in a socket, in an extraction socket, and I'm afraid we don't know what's the speed of this destruction in a periodontal patient. Number two, as you can see, the 4 to 6 month, the delayed one, where obviously, you know, most of the soft tissue, the hard tissue is also the changes have been completed, or you can take it even further than that. But as you can see, those 3 approaches for me is not immediate extraction management. The one you're waiting for the soft tissue, the other you're waiting soft tissue and most of the hard tissue, and the other is like super long and delayed approach where everything is completed healing-wise. And what do I mean by that? Let's go in a periodontal patient that I'm going to try and make sense. Somebody will say, okay, that could be a good case for an immediate. Obviously, because I know that the patient has perio and it took some time to stabilize it. There is a retained root that failed endodontically several times. Thin buccal bone, as I will show you later on the CBCT, blah, 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 immediate extraction as traumatic as possible. And here is another approach. That's what I was actually talking about, preserving what I have. And here actually is, I don't want to lose anything and obviously minimize invention for the future. And this is a case which is not ideal, and you will see why preservation approaches have been criticized. Anyway, this is one of the protocols. You see the extraction, you see some xenografts placed carefully because most of the walls, all the 4 walls are basically in place with a very thin buccal wall. And then you see a soft tissue FGG from the free gingival graft modified as a plug, which later, you know, becomes fibrin. And somebody will say pretty good results. It doesn't seem that we lost a lot. Don't forget that we live in the era of prosthetic-driven implant dentistry. We place the implants in a position that is as close to a perfect restorative plan. And that compromises also the positioning if you are really like just to follow bone. And what do I mean by that? I think that this result is pretty successful. During implant placement, although we chose a tapered implant to avoid some problems on the most apical part, proper placement in the maxilla, as I just mentioned, can have issues like this one. So you can see a typical fenestration that happens in a lot of anterior implants, especially in perio patients, that obviously requires an additional augmentation. Why I'm showing that case? Because one of the biggest criticisms you will read in papers for the ridge preservation or socket preservation, this is tomato, but we can talk about it, is that you may need additional augmentation procedures. In 2021, I believe now we don't call that GBR, but mostly a contour augmentation. Nevertheless, the highlight sentence that I want you to keep in your mind is that they reduce the need for massive or very aggressive grafting, like blocks and stuff like that. And I think that, as I mentioned before, the periodontal patient will definitely benefit from less aggressive cases. Let's see another case, which is not periodontal per se, but is going to make you think what I just said. If you want to have a more delayed approach, what is happening? So this is a case that actually it doesn't take for you to, initially it was referred for a crown lengthening, an aesthetic crown lengthening and an improvement on smile based on the laterals, chronically injured teeth that they were endodontically treated and so on. The problem here is, although we plan, one of my team, for crown lengthening, missed somehow a deficiency on the bone and obviously pocketing in that central. So during the crown lengthen surgery, which anyway was needed for that lateral, exposed, a vertical fracture on the 1-1. So despite, finishing the surgery, there was a root fracture that later needed to be completed as an extraction, some extension cantilever bridge to modulate a little bit the soft tissue. And here the approach of the operator was, I'm gonna go a few weeks later once the soft tissue is healed, and I'm gonna do a guided bone regeneration approach. And you can see even that 7 weeks later, allow me to jump back. I'm sorry if this is not the best, but I think you can all appreciate the condition of the bone the day of the surgery, which was, as I said, followed by extraction, and 6 to 7 weeks later, thanks God, there is still continuity. I'm start talking now about a term that obviously all of you are familiar with, which is called continuity, which means that the bone defect can hug, if I may be a little bit of humor, engage, support mechanically and protectively whatever material and bone grafts you're gonna use. And allows you maybe to overbulk it a little bit. So this is, now we're going obviously not in a preservation, but an augmentation procedure, a double technique, layer technique with a resorbable membrane, so on. You can see it healed, nothing really much here. I don't wanna waste your time. This is not the topic of today, customized impression, etc. But you got the idea of how it's working. So talking about that, now I'm going to jump or reverse a little bit, and I apologize in advance if I'm driving you a little bit crazy with forward, backward. But as you can read, the life, unfortunately, is not based on perfect case selection, but periodontal patients is a different reality. And what do I mean by that? Very, very briefly? This is a very important slide, dear colleagues. Tooth loss due to periodontitis results in severely deficient ridges in terms of residual width, height, volume, and implant placement. This is my very good friend, my boss, and one of the most influential figures I met in perio, Professor Tonetti. That's a very good paper that you can read. In other words, simplistic translation, don't translate strictly and dryly what you read about the evidence on extraction to your periodontal patient. I will elaborate a bit more. Complex invasive procedures have invasiveness, are more expensive, more technically sensitive, with more complications. And that is coming from the big Chapasco, OMFS surgeon, master in extraoral grafting and vertical augmentation. So we should put a lot of attention in his work. Another paper I would recommend. And obviously, what is the evidence-based knowledge we have from the same group of Hammerle and Mauricio Araujo? You all know those people, demonstrated around 4 millimeters and 1.5 or a bit less of bone loss after extraction in an assisting healing that goes just by the simple blood clot thing. Again, this should make you think how many of these teeth were lost due to periodontitis in order to really be able to translate and use what we know in our periodontitis patients. And then you will find only one study in 2010 for Giuliani Rasperini and Massimo Simeon that they showed that actually in 8 control periodontal sites, the ongoing buccal reed dimension was up to 6 millimeters. And as you know, in perio, 2 millimeters equals to 2 kilometers for other professionals. And a slide just to capture what I'm just trying to tell you very briefly. And I'm sure that on a daily basis, you dealt with that, a failing molar or a premolar and so on. What would happen in natural extractions here? You can see the thickness of the bones, the configuration. So you can kind of predict what is about to follow. And obviously that makes your life even harder when you know that very close to where you need to restore missing teeth, I'm afraid mostly with implant means in 2021, anatomical landmarks like the mental foramen, the sinus, and we can go on and on, but this is like the, the main points that you don't want to end up having to do massive augmentations or modify the future implant sites. Okay, maybe we, as dentists, we think that a 9-month lateral window closed approach is a very common one. But in reality, if we could avoid it to a close sinus approach or even less, the invasiveness, I think, benefits overall our patients, which usually have a lot of treatment history due to periodontitis, or hopefully they do. So I'm gonna allow me again to suggest probably a paper that was recently published from my group here in Hong Kong with one of my PhD students and my friend and boss, Prof. Tonetti, which actually talks about feasibility and needs for simultaneously or stage augmentation in very hopeless or already exfoliated first molars due to perio. And please don't stay on the conclusion. I think it's quite a nice paper to read, but you can understand that when we did the planning in these upper first molars, it was a big challenge for rehabilitation. A lot needed sinus lift, horizontal augmentations, and so on. So we already know that, for example, the first implant, the first molar site for a periodontist that lost a tooth due to severe perio is gonna be an issue. Okay, and I think this is the first evidence I can drop in the table. And very briefly, again, this is not strictly my topic. As you know, the periodontitis, except everything else, you need to treat it. If you believe, I'm sure I'm addressing periodontists, so apologies for that, but it's a good chance for me to remind to people that you cannot treat periodontitis by extracting teeth simply and inserting implants. There are too many common risk factors, patient attitudes, host responses, and several things that they don't go away just by removing teeth. Several papers I can recommend to you when you have to defend the impact of periodontitis in implant treatment. And classic consensus reports shows you that even in treated patients, because of the host response that never goes away, I believe, implants will always be in a higher risk for problems and biological complications. I won't spend time to remind you what needs to be done before we consider implants in a periodontitis patients. I'm sure you are pretty good in that. So yes, let me just stop here, take one breath, and continue now to what is the main point of what I'm telling you. So let's imagine this patient that already is having periodontal treatment for coplasties. We did several things, but we have a 4-4, a lower first premolar, increased mobility, circumferential attachment loss, close to the mental, and so on. So during the extraction, as you can see on the top picture here, there is still, despite the severe destruction, you can see my 5 millimeters let me call it intra-socket, if I may say, space here. And you can see also a friendly configuration, friendly, if I may call it, regarding, as I said before, continuity and so on. So I don't know, it's difficult to talk, with a really 100% certainty. This is at the end of the day, just an extraction, but I believe that 8 weeks later, the thing wouldn't be as friendly as it is now, and I would be even closer to the mental foramen in order to do some advanced GBRs and so on. So the choice of treatment here, this is actually an alveolar ridge preservation or socket preservation, but because of missing wall and a compromised socket, there is a flap without vertical incisions, filled with a xenograft and a membrane, as you can see. And obviously, I'm not telling you any big science here. We know what's going to be the the compromise, if I may say, soft tissue. How do you think that a post-extraction socket will have full closure? It's impossible, right? Even if you release the whole vestibule, there will be some exposure. But if your wound is stabilized, all the materials are properly protected, then I think the suturing doesn't look nice, but gives you an idea of what I'm talking about. And yes, then 4 months later, I like what I see. For me as a periodontist, that's how I would like, to have my post-extraction areas. I'm not showing you anything again big. I'm just showing you a pretty good preserved and slightly reconstructed site and a straightforward 8mm 4.1 tissue level implant, which is quite common in perio. And there was a bridge work on the anterior, but this is not of interest to what we're talking. On a similar base, on the same token, is not only a premolar. As you know, we will read a lot, and I will give you some more evidence in relation to what happens in upper molars. This is a molar that unfortunately is failing. You can see the palatal root, despite previous treatment and already attachment loss of several millimeters. Let's look surgically. There are still, areas in the socket of 5 to 6 millimeters that for me are very important from which aspect. If I maintain that, at least I can place an implant with a small closed sinus approach, a Summers technique, which again, for me personally, and my patients, I believe so far, is less invasive and more well accepted from the patients, and with smaller time needed to complete it. Okay, so you can see reconstructions here. We graphed it a little bit, the distal of the 5 also, but nevertheless, you can see again, it doesn't look nice. We have to actually do a little bit of periostal releasing incisions. As my students say, it doesn't really look attractive, but when you come to 4 months later, you don't want to have a completely palatal wall missing. It's very difficult to do good GBR palatally because, as you know, palatal tissues don't move coronally. So I think proactively talking, I'm pretty happy in a post-extraction 4 months after in a situation like that. And the story goes on, another upper premolar, again, presence of perio and a vertical fracture that sometimes you think I may not be able to take that atraumatically without, because it's quite deeply broken. Nevertheless, again, very briefly to show you, and somebody will say, come on, this is a very wide ridge. That's true, you are right. But look how thin the bone is buccally, and if this would resorb, then again, either I will have to place my implants quite palatally or do some GBR at the same time. Maybe it's not the ideal case, but I chose to show it to you, again, for 2 reasons. You can see again the exposed membrane, not a full closure. And here, because the operator is again a member of my team, maybe over augmented or over bulk a little bit the ridge, you can see that 4.5 months later, on the most superficial level, there were some remnants of xenografts that were removed very, very easily, implants placed in good positions, no further augmentations. Happy for some simple metal occlusal crowns. Pretty okay with me, if you know what I mean. And soft tissues, sorry, I don't know if you could see it. Pretty nice, thickness-wise, nothing much. Because we should also take into consideration what happened to the soft tissues. And so far, the evidence shows that APP, amine preservation, can have a positive impact also on the thickness of soft tissue. And don't think that this is just me talking. These things come with some evidence. So very good paper from Jeffrey Garcia in 2017 that he looked into the exposure, because I just told you that I have exposure. I have exposures when I'm having this technique and so on. So yes, of course, the exposure is there, but maybe all periodontists been bred in times that EPTFE and non-resorbable membranes, either periodontal regeneration or later in guided bone regeneration, were exposed. They were getting infected. They need to be removed. Very unpleasant and very stressful clinical situation. But in reality, that systematic review shows that, however, most of the problems becomes apparent in EPTF, in non-resorbable stiff membranes. So resorbable may be actually a bit more friendly, and we should look a bit more into them. And a more old paper from 2003 was also looking on the influence of exposure in GTR and GBR, and apparently when the membrane was exposed in bone regeneration rather than periodontal regeneration, the impact was even worse. But this is now 20 years back. I think we should look very carefully at our materials and our evidence. So my old boss and my old team from London back in 2013, 8 years before, they wrote the first systematic review on alveolar ridge preservation, which actually you can see that there can be a limitation on the resorption, but you cannot eliminate it completely by APR, meaning you're going to lose something. Histologically, what they found from some studies back there is that when you put a xenograft inside, in reality is you have a combination of natural bone with a xenograft. So per se, a pristine socket compared to an augmented socket had less natural bone. I'm not telling you anything big, right? Because the one is obviously with a lack of any grafting material, the other is a mixture that developed during the healing period. Later, then an Italian team also looked in this with a multi-center prospective case control study, good team of good Italian clinicians, and they found actually that the maxillary molar, and you will get more information as periodontists today for the maxillary molars, is suggested that actually less sinus lift windows, less horizontal augmentation can actually preserve and reduce the overall need for augmentations in the future. That's a good study to read also. And a Korean team that did quite a lot in that found actually that it can again reduce definitely grafting and sinus lift. And simplicity or complexity of treatment can be kept low in cases that the ridge has been preserved. And in those studies, just to let you know, they used molars that they had more than 50% bone loss and usually furcation involvement. So somebody would say is that it's not the molars that they are completely destroyed, terminal periodontitis, exfoliating. But this gives you a good sense of what's happening. What I'm worried is that people based in this concept, when they have molars with 50%, they will extract and give implants. Remember, teeth, even with reduced periodontium, that they have good outcome, treatment outcomes can be maintained. So this is further information. That's not the first line of defense, if I may say. And then you can read also from Troiano, a paper, a systematic review, sorry, the date is wrong, obviously, that he found that bone grafting in the extraction sockets can, again, limit, but not save the post-extraction changes in its environment. Now, somebody will ask, okay, so it's the same thing, I'm just taking out the tooth, I fill some material in the socket and suture it or put some membrane or some FGG. So the surgical technique, for sure it plays role. But because I'm talking to postgraduate mostly, if I could simplify it, I would say that if your socket is completely undisturbed, you could go without raising a flap, if you know what I mean. But unfortunately, most of the perio cases, if you will do that, you need to raise the flap, clean very carefully. You have missing walls. You need to reconstruct properly your membranes. So it's a bit more demanding and challenging. And this Spanish group published a very nice paper almost 10 years ago that you can see that significant positive effect of a flap surgery was observed. I suppose because most of the sites have some compromised buccal or palatal or whatever wall missing, not an ideal 4-wall socket. And so on, another paper that shows you that actually at the end of the day, I want to know if my implants are going to have the same survival rate. According to Mark Nevins and his group, even if you do a ridge preservation, GBR, or even delay approach, the overall outcome is comparable. So it's actually up to your case. But again, here it doesn't justify if it's periodontal or non-periodontal patients. The same group that I mentioned a few slides before, my boss from London a few years back, 2013, then in 2000, I believe recently, 19 or 6 or 7 years later, they done again a systematic review. And this time they didn't look so much into histological changes, but they found that there is no superior impact of GBR, socket filler, or etc., but definitely bone dimensional preservation, bone formation, keratinized tissues, and patient complications are things that you have to take into consideration. And you can read, I left that for the end, that a significant reduction in the vertical bone dimension change is found when compared to an assisting bone healing. So I think you can look into the studies that they included, and there is some very interesting findings. And again, that the same group, as I told you, from Korea, had a retrospective study that we're going to see the results a little bit later. And I will start with a case. And this is a case of a patient we'll be treating in my clinics with some of my MD master students, bruxism with some localized perio. Believe it or not, from 2005 to 2016, with some open flap debridements and some conventional other treatments, the tooth survived. But then the day came that there was a root fracture and that tooth had to go. And I think the CBCT shows you that already palatally, the destruction is pretty bad, because palatal root was the one that really gave us the trouble. And you can make some extrapolations, what will happen in an assisting healing and complicate my life. I'm not saying again that this is the only way to move, but you will see why I chose it here. And again, some pictures from the CBCT. I don't think I want to really, you can see thin bone around the palatal root in different sections, tends to even go down. But nevertheless, you can see very clearly what happened, an extraction as a small flap raised, closure, and obviously 2 weeks after, some fibrin with some exposed fibroguide. And then another group of friends from Switzerland, Kai Fischer is a very good surgeon, actually is talking now openly about open healing. Can we call it open healing? Yes, it's open healing. And basically your collagen membranes, if they are stable mechanically and well protected, not by soft tissue, but by mechanical means, it shouldn't be such a big problem, because hydrolysis is going to dissolve gradually the next 4 months what you place there. And I want you just to see post-op. And I think that all of you can of course criticize some voids. We discussed that we are going to have a mixture of the graft and the natural bone and so on. But I think 4 months later, I really like what I see. And very briefly, you can see what we had post-op. Now, if some of you will ask me why 4 months at least, Dr. George, I will show you a paper from Wen and from the Homley Wong in States, in Michigan, that showed you that at least in 4 months, you get a decent level of combination of the xenograft with a natural bone. Not the best ever evidence, but I think this is where I would start from. And again, you see the same case 4 or 5 months later during implant placement, not fully regenerated those buccal aspect, but definitely much better than it looked the day of the extraction, and an implant placed without major problems. Again, you can see the final results. So the study I just mentioned actually is the study, this retrospective study that concluded that ridge preservation can be clinical beneficial for minimizing the invasiveness in implant surgery, right? When sinus augmentation is expected in the maxilla. That's another case, because when you are not in a position to do this, then you will have as periodontist to go for a delayed approach. This, the extraction or the exfoliation already took place. And that just to prove what I'm trying to tell you, that is technically much more demanding. You have to do tenting screws, the cortications, already is more complicated as a procedure, large granules of xenografts and so on. And 6 months later, yes, an improvement on the contour, you can see very clearly. And although I'm happy, I will place my implant, but I think I'm always preferring what I find when I graft immediately, despite the fact that my soft tissue is not the best. But as I just told you, sometimes we are too late, and you need to keep in mind that then the only way is a delayed approach with a stage augmentation, which is not what I'm planning to talk about today. And to close, for you that you are a bit more young and you are thinking, you dream wild, if I may say, please keep a small basket when people are talking for immediate placement in periodontal patients. If it happens, it has to be a periodontal patient that still has a lot of bony and soft tissue to give you. Here you can see a quadrant 4. You can see actually a temporary prosthesis and some hopeless premolars with attachment loss and severe mobility and malocclusion and so on. And you can see a walks-up in a 3D model, very detailed planning to what will be placed, digital planning, and you can see the truth. The truth is that despite massive attachment loss, even now for a periodontal patient, he has a ridge that can accommodate an immediate placement. We already did a lot of non-surgical treatment, so we didn't have an infectious or an infected, let's say, surgical site, but still, who is going to do non-surgical and so severe treatment when you're going to extract teeth? If you do it, keep that in mind. You can see immediate placement and grafting. So I don't say that it cannot happen, but it's not the cup of tea, let's say. And in order to close, that's my last case for today, dear friends, is just a case to show you maybe where I think that what I just talked, it's a must, or it's a very, very good approach. So you see a patient that has already an implant placed, and we have a failing premolar. Is it the progression of perio? Is it an endoperio? It doesn't matter. This 5 is hopeless and needs to go. And here you can see on a CBCT analysis, except the dimensions that they are critical to be preserved, I think you can enjoy, I don't know if it's the right word, enjoy, but you can see the thickness of the buccal and palatal bone, and I think you can estimate what is going to happen. The dental peak, as we call it, is going to resorb even on the adjacent implant, so I'm also concerned what will happen due to post-extraction changes to the implant. So here, I think you can see the post-preservation, CBCT 4 months later, planning, and you can see it actually. Sorry, I couldn't find the original pictures. This is again one of my team, so it's a little bit of PDF. I hope you can see clearly. The message is exposure of membrane and assisted healing. Here, actually, you can see also a little bit of exfoliation of bios in the soft tissue. I hope you can see that despite the poor quality of the picture. 5 months later, you can see 4 or 5 months later, the implant site, placement. And I think that concludes what I wanted to say. I hope I didn't run late and you will have some time for questions. So I'm sending you best wishes and be strong in difficult year. All of you. And from my team in Hong Kong, I personally want to thank Gopal and all the Society of Perio in India for a second time invitation. It's a privilege to be here. Good luck to all of you. Thank you.
Thank you very much, George, for a wonderful, and as rightly said by Dr. Gopal, that it was indeed a treat watching you. With a variety of cases, you have really impressively put across the points what you wanted in the management of complicated periodontitis cases. And there are like a few questions. First of all, initial part, you have said that first 2 months are crucial for. Can you just elaborate on that aspect? Like,
would you mind, dear, to repeat the last? I didn't hear the last part of your question.
The initial part you have mentioned that first 2 months after extraction are very crucial. Yeah,
very correctly. Let me elaborate. Thank you so much. It means that you got exactly what I'm trying to say, and I'm very happy for that. So I showed you a little bit with some cases, you know, what is happening the first supposedly 4 months of the extraction. Then we went strictly on the biology, and we see that the most of the things that happens bony-wise, not soft tissue-wise, are actually up to 8 weeks, 8 to 10 weeks, which is not basically 4 months, but is the critical period that everybody's saying, okay, I need 8 weeks to get proper soft tissue. Yes, my friend, then in 8 weeks, you're gonna get a proper soft tissue. But in the 8 weeks, that was my point, you're gonna lose some critical, especially thin buccal bone, that you can extrapolate that in a severe periodontitis patient, that is gonna leave you with a more compromised situation. And I'm afraid that when you're gonna go back 8 weeks later, in some cases, despite a soft tissue improvement, you would lose that little extra bony bridges, or I think you can maybe, I could choose that case with a lower premolar that I showed you a residual socket of 5 millimeters or an upper palatal. I believe that in 8 weeks, this is the price you have to pay. Good, better soft tissue, but then you are not talking about preservation anymore, but you are talking most about GBR, you know, augmentation, pins, stabilization, because you lost that little, may I call it holder, my friend?
Okay.
Does it make sense?
Yeah. The second question is that which is the graft material you'll prefer in such kind of cases, especially you have shown the molar areas where there is
Yes.
extensive bone loss.
Absolutely. Initially, to be honest with you, I was working, you know that in perio, I usually don't have a lot to harvest. I mean, harvesting from the patient himself is, yeah, it's a kind of a dream, let's say. It's already gone. So I have any way to deal with xenografts, which I find quite okay, let's say. And recently, I find the tendency that when they are incorporated in a small collagen sponge, like the Bios collagen, they can preserve volume a little bit easier. What I don't like with the Bios collagen, sorry, I'm not supporting any company. I'm just saying the materials I'm using. I'm sure there are different companies with different, names. I don't like the over compaction. When you have small particles, you know how you place it, and you don't press it like amalgam, because the socket needs some space for the blood and for new angiogenesis. So in reality, I like small granules xenografts. to answer your question.
Yeah. One more last question. You have shown some of the cases wherein there was a deficient soft tissue, and the guided tissue regeneration membrane was exposed in some cases. So to get the good soft tissue outcome, was any of these cases required a second soft tissue surgery later on?
Excellent question also. Now, this is, where the eye is getting a little bit fooled, because honestly, I showed you, actually the first week is usually absolutely okay. The second week, when I personally prefer to remove my sutures, I start see a combination of fibrin and membrane, and I say that because a lot of colleagues rinse very, very thoroughly. Don't disturb fibrin. What you should check is that there is no redness, no discomfort, not signs of active infection, no suppuration, of course.
Right.
All these, if are okay, and your flap is not, sorry for my English, flabby, but it maintains its stability, let it heal. In 4 weeks, which is actually a month from the extraction, you will see actually that the soft tissue is pretty okay, quite thick, and slightly keratinized. Then you can do your palazzi, etc. But I didn't have so far to go back for an FGG or any other kind of soft tissue augmentation.
Fine. Dr. Gopal has a question, I suppose.
Thank you for your questions, dear colleague.
Yeah, Dr. Gopal.
Hi, George.
Gopi? Yes, Gopal, I can hear you.
You just said that, I just wanted to know, you already answered. I just said that I just wanted to ask whether you used alloderm or any acellular dermal matrix in your cases.
As you understand, now we're talking, me and you, a bit more on a friendly discussion, and I forget that we've been watched by I don't know, probably I don't know how many of our future colleagues. So I have to go a little bit anecdotal or a little bit non-evidence based. There are cases that I didn't show today that exactly because of what we just discussed with a colleague, with Niraj, is the soft tissue is extremely thin, extremely, non-keratinized. And in order to avoid future grafting, I didn't use a collagen membrane as a barrier, but I used not an alloderm, pardon me, but a collagen matrix, if you know what I mean. I don't want to use an mucograft. There are several replacements in order to thicken a little bit the tissues, which worked a little bit, but it's still not the natural, nice keratinized tissue that I usually get. But, in posterior areas, it will be okay.
Since the viewers here, there are postgraduate students, on one hand we say that, we need to avoid the second tissue, second site of surgery. And on the other side, we say, on the other side, we say we should see the patient comfort. So it's more of, going into academics and balancing with the clinics. So I thought that you might have used alloderm or mucograft. So that's the reason
I haven't, because it's not very popular in Hong Kong, to be honest with you. Patients, for their own reasons, are not. I don't have any problem with alloderm. I use it quite a lot and extensively in UK. But actually, allow me 1 minute, very fast. Thank you, Gopal, my friend. Very good point. What is your point? How I extrapolate your point? If I do a conventional GBR, I showed several. I place my implant, my BIOS and my membrane. I finished, okay, it integrated, perfect. But then I want to do an FGG or some soft tissue augmentation. I don't know any periodontist that he really feels comfortable in reflecting a flap where he put his GBR. There is a tendency that you will find particles and so on. As you can see from all of the cases, and I have many more to show you. Another thing that I like in this technique is that usually you saw the implant surgeries. Most of the implant surgeries was quite pristine bone, no granules, etc. In that case, I'm not so uncomfortable in worst case scenario to go 3 months or 4 months, or during second stage, if I have to do a second stage, and add a little bit of a free gingival graft to facilitate maintenance and patient comfort. So I don't highly, recommend it in my slides, but I think based on your point, that's another maybe benefit. And there's going to be a lot of papers coming that ridge preservation actually improves at the end of the day the soft tissue thickness and outcomes, but we need to wait a little bit for that.
Thank you, Dr. George. Over to you, Dr. Neeraj.
Yeah, thank you very much, George. It was wonderful listening to you. And management of extraction sockets and placement of implants in periodontitis patient is indeed a challenge. And I'm definitely sure that today's lecture, our budding periodontist and our postgraduate students have many take-home messages. And this today's message, what you have put across, will go a long way in their clinical practice. And I would like to thank 19th ISP PG Convention Organizing Committee for giving me and Dr. Gopal chance to chair today's session and to interact with George. It was wonderful having you here. And we'll really look forward to have you in India physically in some time future. Definitely.
I'm sure that life will not go forever like that. I promise you, that's my second time. The third one will be in person to enjoy your hospitality, friendship, and to discuss. The screen is okay, but it's nothing close to the real thing. I had a great time last time in India. Be healthy, take care of yourselves, and looking forward to see you. If there is any questions or any other problems, Gopal can always email me with questions, etc. Feel free retrospectively to come back with more questions. Thank you very much again.
Thank you very much.
Thank you.
Take care. Have a great day.
Have a great day.
Sir, it was really an informative session on management of extraction socket in periodontitis patient, and the presentation epitomized everything in a beautiful way, and it was beyond excellent. On behalf of the Indian Society of Periodontology, we express our sincere gratitude and pleasure in thanking Dr. Gopalakrishnan and Dr. Dheeraj Deshpande for chairing this session in an excellent and interesting way with scientific evidences and enlightening us with your experiences and knowledge. Thank you, sir.
Take care, all of you.
Thank you.
Take care. Stay safe.
Please start next session.
Warm regards and a happy Sunday morning to one and all. We welcome you to the next session of the day. Let me introduce the moderator of this session, exactly my point, your take, Dr. Anirban Chatterjee. Dr. Anirban Chatterjee has completed his BDS from Bapuji Dental College in 1993 and PG in Periodontics in 1996 from the same prestigious institution. He did his PhD and fellowship in implantology, New York in 2013. Dr. Anirban is the current president of Global Outreach Medical Health Association of Periodontology, Bangalore branch. Presently, Dr. Anirban Chatterjee is the president-elect of Indian Society of Periodontology. Aside from all these accomplishments, he has given more than 100 lectures in both national and international platforms. Once again, I am privileged to introduce the moderator, Dr. Anirban Chatterjee. Over to you, sir.
Thank you, Dr. Hemlata, and thank you, the 19th ISP, for giving me opportunity to moderate a wonderful session, the third one on everyone. So today, being the third point, exactly my point, we are going to place. There will be so many interactions, so many viewpoints of different people all around the world regarding certain things. Today, we are going to discuss something about success of dental implants in periodontally compromised patients. Is it real or is it overrated? So, might be a lot of people will differ with me, but that's exactly the point what we are going to discuss. Is it overrated or is it real? So, we have today with us two of most wanted or the most knowledgeable people in our perio. One of them who has been doing a lot of work regarding implants, both rather, and one of them being Dr. Sharat Shetty, a dear colleague, and other one is Dr. Sandeep, another dear colleague of mine. So today they are going to point out whether is it a real fact that in periodontally compromised patients, as just now George spoke, it is really complicated to do in a periodontally compromised patient, the implant placement, as George put out. But my views are different. Even Sharat's is different and Sandeep's is different. So we are going to collaborate between among us and make this as one of the most interesting point, that whatever it is, whether we can place an implant in a compromised patient or periodontally compromised patient or not. Is it sustainable? Is it not sustainable? So let us come up with our first speaker, Dr. Sharat Kumar Shetty, who is professor at present in D.Y. Patil Dental College, Pune, has completed his BDS and MDS from prestigious Government Dental College, Bangalore, was a gold medalist during his PG time from Raju HS, and he has passed his one of the very privileged person to have done his a DNB from Government of India. A DNB, very few periodontists are there in our country who has done DNB, and if I am not wrong, I think he is the first periodontist who has completed his DNB. Then he has done his PhD, and from the Rocky Mountain Tissue Bank, he is working with the STEM Culture Tissue Bank in his own institute, which is a prestigious institute, and he is the editor of Journal of ISOI, that is Indian Society of Oral Implantology editor, consultant periodontist, has many publications, and a wonderful speaker. So I bring to you Dr. Sharat, who is going to speak for the success, like periodontally compromised patients, we are able to put it or not. So over to you, Dr. Sharat.
Thank you, sir. Thank you so much for the kind introduction. Let me share my screen. My screen is visible, sir?
No, not yet.
Now it is visible?
Yeah, yeah. You can make it into slide show mode. Yeah.
Okay, sir.
That's good.
So, good morning, everybody. I welcome all of you for this third program of exactly my point, your take. Again, thank you, Dr. Anirban sir, for the kind introduction. Even I welcome my co-panelist, Dr. Sandeep Lavande. First of all, I would like to thank COC 19 PG Convention for giving me an opportunity to be the part of this beautiful event. And my topic is the success of dental implants in periodontally compromised patients. I am talking about the whether it is possible. Yes, I'm talking about its real. And this is the institute from where I come. That is Dr. Deva Patil Dental College and Hospital, Pimpri, Pune. And to start with, let us see, because a lot of first year PG students are there. So let us see what is periodontal disease and what is the scope of a periodontist in today's era. And according to the study by Casabon, NJ et al., which was published in 2014, they say like the periodontal disease is the, just give me 1 minute. Periodontal disease is the one of the sixth most prevalent global disease, and they say like approximately 10% of the people are suffering from the periodontitis. That means that much scope is there. You know, whenever there is a periodontitis patient comes to us, whatever the best possible treatment we do, depending on their maintenance over a period of time, they are going to lose the tooth or the teeth. That's why those teeth may require the replacement in the form of dental implants. So this is a case of periodontitis. Just to be quickly, we'll see there is all the clinical features of periodontitis are there. This is the three-dimensional CBCT scan, 3D reconstructed image. You can see a lot of bone loss is there. And as Georgios Palakos told, like just now, some of these sites may be ideally indicated for the grafting and implant, otherwise they may fail. That part we will discuss subsequently. This is how the severe periodontitis case looks like. Now, whether to place the implants in these type of patients, definitely with the implants, we can improve the quality of the life. But most of the literature currently available are probably they are against. But here I'll try to, what you can try to say like it is possible and it is real. And this is a case again, our lower anterior is treated with the implants. Already there is slight amount of peri-implantitis. That is not because of the periodontitis, the other reasons I'll show you later. And the molar missing, beautiful molar that was 4-6 which was removed, or now this is a good amount of bone is there. It's an ideal candidate for the implant. Again, you can see here the CBCT scan of the upper left side. Three teeth are missing from the premolars. Molars is missing, probably guided implant surgery, and this is the sinus dimensions given. So again, coming back to my topic, again, I'm repeatedly putting up this question because there are a lot of you have in your mind like the implants in periodontally compromised patients or the periodontitis patients with a few teeth missing, implant may not work. That is your, if it is in your mind, we'll be giving a solution for that. So when I started searching articles, I came across many articles. My good friend Dr. Sandeep, he'll be discussing about all these authors and their outcomes. I'm not going to go in detail. And this all of them showed like in their studies that with the periodontitis patients, chance of implant success is less. That's what they told. But I will disagree with these all articles in my subsequent presentation. And now you can see like why it happens actually, because now the entire presentation what we are seeing or what we are discussing about the partially edentulous mouth, the reason for edentulism is the periodontitis and loss of the tooth because of the periodontitis. This study they say like the implant failure rates are 3.8, 5.7 and 4.71 for the healthy patients, more periodontitis, and the aggressive patients. Anyhow, this will keep it aside. Why they feel the implants in perio patients fails? Because see, suppose there's a 4-6 is missing, I have placed an implant, there's a 4-7, 4-5 and other teeth are there. What they say, there is a chance of possible bacterial translocation, and the bacteria around the natural tooth, periodontopathic bacteria, will get settled in the peri-implant sulcus and they lead to the peri-implantitis. That is there most of the studies put forward. Now see what are the reasons for peri-implantitis and what are the reasons for the periodontal disease. This is very important for us to understand. Implant can be done successfully in perio patients. On your left hand side, you can see these are all the possible reasons for the periodontal disease, but these disease cannot, all these factors leads to the periodontitis and ultimate tooth loss. And when the patient come to us with the periodontal history and some teeth lost, the poor oral hygiene will be there. As George Pelacos already mentioned, the host response we cannot change. Smoking is there, periodontal disease is there. Some of these risk factors are there. Now at this junction, I would like to ask you all of the question. If there is a poor oral hygiene, if there is a smoking, if there is a diabetes, if there is a genetic factor, is it a stress? Even the periodont, even natural teeth are not going to stay back. Do you feel our implants are going to stay back? Definitely no. From that point of view, in those patients, we should not go for the implants. And I want to make a one statement at this junction is, if you feel like your patient is not an ideal candidate for implant, we should not do the implants. There are varieties of replacements in the form of the cast partial dentures, removable partial dentures, or the wall flush are there. We can go ahead and do that. We know like this is a contraindication for an implant or there is a risk factor. If you go ahead and place an implant in those patients, over a period of time, implant is going to fail or it may not be successful. Then we cannot come back and blame like patient had a periodontitis, so implant is lost. We cannot say like that. These factors has to be considered. All the readers, all the PG students, whenever you read an article saying where implant fails after in the periodontitis patients, please kindly go through and see whether all these factors they have considered in them or not. Now, at this particular junction of my presentation, I would like to say, what do you mean implant success? In my practice or in good clinical practice, we consider the implant contraindications, risk factors, we exclude them, and then we start doing the implants. Then we'll start explaining our patients, what do you mean by the successful implants? There are n number of literatures are available where the implant success is proved. They have put up different criteria. You can say more than, I can say 20 to maybe 10 to 20 criteria are put up by different authors at different journals or at the different parts of the world. This is one of the accepted criteria where the early implant success, immediate, intermediate implant success, and long-term implant success. This is what I have come across in one of the article introduction. Early implant success, they say 1 to 3 years, means you have done an implant in a periodontally compromised, in a periodontal patient, maybe few teeth replaced. If it is lasting for 1 to 3 years, it is early implant success. If it is lasting more than 7 years, that is called as long-term implant success. Now, when I was going through the literature, the maximum articles, there was a lot of confusion saying whether it is survival rate or the success rate. At this junction, I would like to make clear to all my under PG students and all the participants, what do you mean by implant success? What do you mean by implant survival? And what do you mean by implant failure? Again, with this, there are a lot of literatures are there. Usually you can see the implant quality life science by Mish was the first to be published. And this is one of the beautiful article which I have come across, that is in the implant consensus survival by the International Congress of Oral Implantologists in the PISA consensus conference. Please all of you go back and read. It was published in the Implant Dentistry Journal in 2008. And it's around 8-page article. I have taken only one table from this. I would like to spend some time on this. So whenever I do an implant, and these are the parameters I put so that whether my implant is successful, whether it's satisfactory survival, compromised survival, or the failure. Because when you are reading the articles, either you go back and see what the author has told about the success and survival, or you can refer this beautiful article. When we call it a successful implant, that means the optimal health. That means less than 2 mm of radiographic bone loss from initial surgery. Please remember, my dear students, it is not the 1 year, 2 year, 3 year. At any given moment of time, you see from the implant shoulder to the crest of the alveolar bone, if that distance is less than 2 mm, then we call it the radiographic bone loss is less than 2 mm, then it is a successful implant. Then we come to survival, means implant is in the mouth. Maybe it is in the function, may not be in the function. It may be surviving up to the patient satisfaction, but it is in the mouth where we say satisfactory survival. That means I have placed an implant if there is a 2 to 4 of the radiographic bone loss is there from initial surgery, then we call it as a satisfactory survival. Again, the compromised survival, that means more than 4 of the bone is lost, or half of the length, what they call the implant body. And here the probing depth criteria they have added more than 7 Failure means more than half of the length of the implant bone is lost, no longer the tooth is in mouth. And also they have considered one more important, sometimes the implants are placed, they are in wrong position, they are in the mouth, but they are not contributing to any function. Those implants are also considered as failed implants. Again, success less than 2 of bone loss, satisfactory 2 to 4 of radiographic bone loss, compromised survival more than 4 of bone loss, and less than half of the implant body, more than 7 of the periodontal probing depth. Failure means more than half of the implant body, the bone is lost. I hope this is very clear. So with this criteria, I went through some of the studies, and mainly Bain CA and Shaw et al. And they told like the implant survival is definitely there with the in the periodontitis patients. Okay. Now this is one of the important article I expect all my postgraduate students to go back and read. And whenever we want to evaluate the patient's success, instead of taking up some uh, case reports or some case studies or randomized control trials and collecting and instead of making systematic review, along with that, if you have an opportunity to evaluate a prospective study, that is the best one. Prospective means I have placed the implant today. I'm going to evaluate this particular number of patients over a period of say the 5 year, 10 year longitudinally. At the end of that time period, I will see what happens. This is one of the greatest evidence I have got for my help for today to defend like its reality, it works. That the 10-year prospective study conducted by Mario Ruccozzi et al. And published in the Clinical Oral Implants Research Journal 2010. What are the type of the patient they have selected? Periodontally healthy patients and periodontally compromised patients. That is the treated patients, but they are periodontally compromised. And the most important criteria they have included is the in relation to addition to supportive periodontal therapy. So 3 parts they have taken: healthy group, periodontitis patients where perio treatment is done, and but there are moderate periodontitis and severe periodontitis cases, and also supportive periodontal therapy in the form of cumulative, interceptive, supportive therapy, CAST. The protocol was followed. They have taken 112 partially edentulous patients. I told when I'm talking, it's with respect to perio patients with the edentulous mouth. And this is a patient criteria: periodontal healthy patients, moderate PCP, they have included a probing depth of 5 to 7 severe PCP, they have included probing depth above 7 And all these patients underwent the proper periodontal therapy, the phase 1, patient education, motivation, oralizing instructions, phase 1, re-evaluation, wherever surgery is required done, the grafting is done, everything is done. The totally the periodontal disease is reduced or eliminated at this point junction. Inclusion criteria: plaque score less than 25% and full mouth bleeding score less than 25%. And these patients were asked to come for the regular follow-up. Tailor-made follow-up appointment was designed for them. 10 years later, the clinical measurements were repeated and radiographic bone level was recorded. And what the result says, you can see here, 96.6% is survival for the healthy, 92.8% for the moderate, 90% for the severe periodontitis patients, where some part of their teeth were replaced by doing implants. Means at the end of 10 years, they are saying the success rate is 90%. And the majorly, the success was contributed for the plaque maintenance or the success indirectly for your supportive periodontal therapy. So what conclusion in this prospective 10-year follow-up study of uh, patients or 120 plus patient was that the underlying value of SPT in enhancing the long-term outcome of implant therapy, particularly in subjects affected periodontitis, in order to control reinfection. As I told in my beginning statement, most of the implants in the periodontitis, in the perio patients, fails because of the reinfection of the sites. That can only be controlled by strict individual tailor-made SPT or CAST protocols. This is one of the clinical case where you can see the patient visited me with this particular finding just to substantiate my outcome in that previous study. There are a lot of plaque here. inflammation is there, even some amount of bone loss is also there. This is before the CST protocol. When I start cleaning this, there are a lot of spaces open up. You can see from the palatal side. Actually, this is a perio patient. The periodontal health is not good. Lower anterior compromised. Patient wanted implant. That's why doctor done the implant. That should not be the criteria here. And as I told, the follow-up protocol or the SPT or CST protocol not only applicable for implants. See around 30-year follow-up of the natural teeth with the 250 perio patients, periodontal patients, 30-year follow-up, where they say excellent plaque control took part in maintenance program revealed only 9 teeth were lost due to progressive periodontitis. That means key to success here is likely the maintenance of excellent plaque control and regular professional supportive care in natural teeth. Same should be applicable to our implants. So the first take home message from this presentation is, if your patients are able to maintain a good oral hygiene status with the minimal plaque, then they are a potential candidates to go for the implants, provided if other factors are under control. Otherwise, please don't do the implants. Otherwise, ultimately we blame the failure of the implant to the periodontitis, which is not correct. And this is one of the case. You can see even with the SPT how the results is the 2010 patient we started until 2019. I have the follow-up. There is not even, we have not done a surgery, only lateral incisor required, the root canal and simple wire splint was done at that time. Okay. Now, if the patient is not maintaining, what happens? 2014, 8th Jan, this is how after my complete SRP and splinting of the lower anteriors, again no surgery, not required. Patient didn't turn up for another 2 years, almost close to 2 year, 3 months. You can see what is happening. Again, I did SRP. Again, in February 2020, he reported 5th February, just before the last year's lockdown. This was the status. That means if your patient is not maintaining a good oral hygiene, your natural teeth are not going to stay. And believe me, implants will never going to stay. So the take home message, strict good plaque control means you can go ahead and place in the implants in those patients, provided all other protocols are fulfilled. And this is again the lateral view of the same patient, right lateral view before, right lateral view, all these things. So first take home message, good plaque control, go ahead and place the implant with all other criteria in place. The second study which I want to present for all of you is the implant survival in periodontally compromised patients, where one stage versus two stage. Now we are going to do the implant, that is for sure, in perio patients. Whether you want to do a one stage implant or you want to do a two stage implant. For a beginners, one stage means the implant is fixture is inserted in the bone. On top of that, the healing collar will be attached same day. Two stage means I'll do the implant, bury the implant in the soft tissue. After few months down the line, I'm going to do the second stage surgery, attach the healing collar, and then give the crown. So what the study says, it was done by the Bela et al. In the year 2004. So since it was a previous article, but in the chronology, I have taken this just to make you people understand. Once the implant works, let us see whether to go for one stage or the two stage. And the 10-year result survival says 97% for two stage implant compared to 78% for one stage. But 5-year results are highly encouraging, 97 and 94%. The possible reasons, what they were told is like, whenever you do a one stage implant, there is a healing collar is placed and the sulcus is not yet formed. That's the ingress of bacteria and maybe some amount of bone loss. That's what they're defending their outcome. Okay. And if possible, in the case of periodontitis patients, go for a one stage wherever, but preferred is the two stage because to get all these criteria fulfilled. Next, let us see whether to do an immediate implant or the conventional implant. This is again is the question. Now we know implant can be done. We are now clear one stage or two stage. One stage versus two stage at the 10-year down the line, two stage give better results. At the end of 5 years, two stage and versus one stage, there is no difference. Now let us see immediate and the conventional periodontally compromised patients. This is a clinic, Adnan Clinic et al. In 2018, he has published this, and average follow-up period was 27 months. He says 97.6% for the immediate implants, 98.6% for the non-immediate implants. They say like both the options works, but we have to decide according to our what you call it as an existing knowledge and take the call. Depending on the clinical situation, we can plan accordingly. Next comes, probably some of you may see in the case of peri-implantitis, because of the bone loss has happened, implant threads are exposed, patient come to us when it becomes very difficult for us to use our plastic curettes or the Teflon coated curettes and maintain these areas because of the rough surface or the your threaded implants. So by taking that into consideration, this was a Quirin and M et al. Published an article where they compared the machined, moderate, and the rough implants. They told like moderate implants gave a greater bone to implant contact. We all want a good osseointegration, good success of our implants. You know, like the rough surface implants or your surface coated implant, they give a better osseointegration and the biointegration, and that helps for success of implants. But Anton Dank et al. In 2019, this is one of the latest article which I have for my today's presentation. They compared the surface roughnesses in different type of implants, and they this was systematic review basically, and they told like there is not much difference between the different implant surface roughness, but they have not made a conclusive statement, but they have told like there is some data are lacking, and the samples what they got heterogeneity and variability in the study designs and lack of reporting in the confounding factors, because it is not a conclusive evidence. But they say there is not much difference between whether you go for the smooth surface implant or a threaded with the implants or the rough surface implants. So you can see, I don't know what design of implant this is, whatever you can see here at the similar case. And these are the few points, additional point. I told plaque control is very important. I told you can go either with the single stage or the two stage. Two stage is better. If everything is favorable, you can go for the immediate implants. With respect to surface roughness, the take-home message evidence is not yet clear, because the systematic review, they are not able to come to conclusion about whether it should be used or should not be used. Few other points from my clinical experience with the some of the literatures what I want to present here. I'm not getting a lot of systematic review or meta-analysis. They say whenever there is any bone is lost, see, when we remove the tooth in advanced periodontitis cases, in advanced periodontitis cases, almost 8 to 10 mm of the bone is already lost. With that much amount of the bone loss, it becomes difficult for us to place the implant in three-dimensionally. Because of that, we tend to place a inappropriate dimensions of the implants. You can see here, this is not my work. You can see, I don't know what type of implants. These are the single piece implants, inappropriate diameters. They are not one to be done. We end up doing like this. Okay. So you should be careful in those situations. Probably in those patients, if they want to go implant, do it properly with all the augmentations, etc. Okay, now comes is regarding the prosthesis design. I was gone through a lot of literatures. Never they discussed about the design of the prosthesis. This is a full mouth rehabilitation. Teeth are lost because of the periodontitis. I am giving you two clinical scenarios. Scenario one, RP1 situation where all the teeth are in the ceramic in the upper arch, fixed teeth. In the lower arch, there with the some part of the pink ceramic. I'm not going to go in detail about RP1, RP2, or FP1, FP2 clinical situations. Now, if you come back and see here in the second situation, because the teeth crown looks too long, because the teeth are lost because of the perio problem, and there is no acrylic component is given, and almost all are the fixed prosthesis here. Now, almost you can see everywhere the gingiva are swollen up. You can see the lower anteriors. These are the signs of the peri-implant because the crown is too big, non-maintainable areas. So, because whenever we lose the teeth, the distance of the height of the crown increases. When it is coming from such a down from the bone, the contour increases, difficulty becomes for the patient to maintain. Again, going back to first slide, patients are not able to maintain, or implants are going to fail. And now, when these type of significant bone loss are there, you can see if you want to really place an implant here, where your implant shoulder will come almost at the tip of the apex of this tooth, the crown, such a huge crown, you feel that this patient will be able to maintain this. Whether these type of cases should be selected for implant itself is a question mark. Another possible reasons for the peri-implantitis, which as a periodontist and each and every implantologist should take care, is this excess cement. Otherwise, we lose the bone. And if there is an adjacent tooth, even there is a periodontitis, controlled periodontitis, we may blame this situation for the perio instead of going for the blame on the cements. Now, the nature of prosthetic attachment, whether you want to screw retained or a cement retained, take home message in periodontally compromised patients, whenever you want to do an implant, now it is a trend also, try to go for the screw retained prosthesis, try to avoid cements so that it helps us to reduce the peri-implantitis and improve the life. Okay, this one statement all of us should know. If the patient has struggled to maintain adequate plaque control with their natural dentition, will they perform better than complex long span or full arch implant bridges? Definitely no. Implants will fail, so the planning should be good. What should be done? So if you are coming across, again, there is no literature evidence is present, dear students, like comparison of full mouth implant, like with the what you call a ceramic full denture in the form of over dentures or the hybrid. You can see this. It becomes very difficult here for the patient to maintain on the left hand side. On the right hand side, the patient can maintain. In both the scenarios, patient lost the implant, patient lost natural dentition because of the periodontitis. Again, we are not improving the status of the patient. Again, we are putting the patient into the scenario of peri-implantitis. We should not go for that. Ideally, in your left hand side, if the prosthetic design was best, then probably the entire implant would have been successful. Anyhow, that we will discuss if we have a time.
Dr. Sharath,
Yes,
I
sir.
think
Done,
you
sir.
can.
Last 2 minutes.
Yeah.
And now, perio treatment or implant, because again, for the decision making, when we come across this situation like this, usually we go and place the implant. That should not be the case, because if you see here, the entire label bone is lost. So whether first the priority should be given for the natural tooth, and you can see we do the augmentations, same tooth, the membrane, and then the PRF, all those things. Yesterday it was covered in 2 situations. We can come to conclusion like this. Same type of restoration, dentition, and the gingiva. Is it possible to give us by doing implant? May not be possible. May not be possible. And this is the radiographic evidence. Next one, implant of the bridge. Sometimes patients say they want to go for the implant. Yes, if it is possible, if you have skill, we can go ahead. You can see this case. There's a ridge defect which you have come across. This has to be managed by doing the soft tissue graft, Quantic, and we have to create the soft tissue site. This is a site now. Now you can open the flap and do the grafting and then place the ideal length and width of the implant, and then this implant will survive definitely like any other natural tooth. That's how we cannot blame anything for the periodontitis. Last part is the keratinized tissue an issue. As a periodontist, all of us should take care of this, because literature says no, it is not an issue, but definitely it has to be considered. You can see on left hand side the good band of tissue, right hand side no band. Those are going to fail over a period of time. There are different methods by which you can apply. This is how we can get a good band of tissues. Again, the patient, he can lose the teeth because of periodontitis. We are going to give an overdenture. This particular slide I have put, you can see on top of our healing abutment, the plaque and calculus, you can see the still patients are not maintaining, as George Palakos already mentioned. These factors has to be considered in our perio practice with the implants. So in summary, patients with a history of periodontitis will come to us seeking dental implants, but implants, please remember, the implants will never fail. The human body that fails to respond to microbial challenge without causing bone loss. And at the end, I would like to say all of you, the what is efficacy versus effectiveness. If you take efficacy, most of you say, no, implant is not indicated in periodontitis patients. But if you take the effectiveness, which all the clinicians we should consider, definitely the implant is going to work in the clinical settings. So at the end, whether we should place an implant in the periodontitis patients, treated periodontitis patients or not, definitely answer is yes. With the regular maintenance, with the we can maximize the implant success. Thank you very much.
Thank you, Dr. Sharath. It was wonderfully placed that we can go for a implant, barring few certain things. But I just wanted to put in a few things from your study.
Yes, sir.
There is you have shown a study by in ISOI, because with the Carl Mesh and Homle Wong.
Yes, sir.
Isn't it? Carl Mesh and Homle was one of the thing. So I have one more systemic review by Homle Wong, Effect of History of 2013. It was released, 14 rather, and it was a 10 years effective. He also says there is no difference between a healthy periodontitis cases of implant in survival rate and between periodontitis and non-periodontitis patient.
Yes,
but
sir.
yes, he also mentions, in particularly, as you had mentioned, that there will be slight amount of more of marginal bone loss in a periodontitis case where you have placed the implant. Okay, so that is what the Homle Wong says. And I want to add one more point in your whatever study you have put in of Rico. You have put in the part 1 of the study. Am I right? Rico.
Yes.
So he has done the part 2 of this, part 2 study, which was published in 2011. So his same thing, he comes up with a conclusion of about 1,123 study. So what he also prospectively he tells is that it's not a no for a periodontally compromised patient as such, but only thing is systemically maintenance is very important in this case. Maintenance is one of the very part 2 he also tells a clinical result that the approach of multiple preventive thing has to be done, and we should not think that extracting a periodontally compromised patient tooth and placing implant will give you a better result. It's also not a right thing, which I think Sandeep will agree on that part of it, that you need not think that ultimate result, as you are also mentioned, Dr. Sharath, that even Rico also tells in part 2, that we should not think that extraction of the tooth, as you've shown the case, we need to place the implant and it will function better. We have to take all the things into consideration. So I think that was a wonderful presentation for your and you have given all the justification.
Thank you so
much. Yeah, so we go for the second speaker of today's thing, who will be Dr. Sandeep Lawande, and he will be speaking on against whether it is successful or not to place a predominantly plant. Dr. Sandeep has completed his BDS from Government Dental College and MDS from SDM Dental College in 2002. He is presently working as a professor in Department of Periodontics in the prestigious Government Dental College, Goa, and he has finished his Academia of Laser from Vienna, has many publications in a PubMed Index journal, has authored 2 books, one in English and Konkani exclusive on general populations, and he has a National Award for Dental Health, and he is recognized undergraduate and postgraduate teacher in various universities. So over to you, Dr. Sandeep. What is your views of this success, is there or not?
Thank you, Anirban sir, for the introduction, and very good morning to all. Am I audible?
Yeah, you're audible.
Okay, I'll share my screen.
Yeah, please. Kindly make it a full
visible
screen. Yeah, it's visible. Make it a full screen, please.
Okay.
Yeah.
Okay, thank you. Okay, good morning, everyone, and I'll be speaking on the success of dental implants in periodontally compromised patients, real or overrated. Thank you, Dr. Sharath, for covering the real part, and I'll be speaking on the overrated part. This overrated statement or the word should not be taken in a pessimistic way. This is just another way of looking at it. So what are periodontally compromised patients? Periodontally compromised patients are a group of patients with history of periodontal disease, okay, but there is no active periodontal disease at the time of implant placement. Now, these patients, that is patients with history of periodontal disease, they represent a unique group of potential candidates for dental implant therapy. Now, the outcome of any implant treatment may be evaluated as implant survival as well as implant success, as Dr. Sharath has already mentioned about this. Now, what is implant survival? Implant survival refers to the presence of an implant with or without complications, whereas implant success refers to the presence of an implant in absence of complications, either of biologic or technical type. Okay. So evidence, they say, is better for implant survival than implant success. Now, success rates and survival rates of implants, they are well documented in a number of studies, that is controlled clinical studies and systematic reviews and meta-analysis. As we know that as per the evidence pyramid, this is the best form of or the strongest form of evidence. So evidence from all the systematic reviews and meta-analysis, they indicate that some factors are there which negatively affect the implant outcomes. Now, which are these factors? Now, the most important factor is history of periodontal disease. Then there are others like smoking, systemic diseases, including uncontrolled diabetes mellitus or poorly controlled diabetes mellitus, and the poor periodontal maintenance. So now that brings to the question, does history of periodontal disease compromise implant success rate? Okay, let's see with the help of systematic reviews. Now, the first one we'll evaluate is the systematic review by Girassi et al. In 2018, which evaluated the parameters of implant success in patients with history of periodontal disease. Now, as per this review, which was studied from 2004 to 2014, all the articles during this period were evaluated, and the final selection was done for 4 studies with population being 1,945, out of which PCPs were 1640. PCP, as you know, is periodontally compromised patients, and these were followed for a minimum of 5 years. Now, most of the systematic reviews, as they say, and even Dr. Sharath has mentioned, like what has been found is like 1 to 5 years, there's a follow-up. There is hardly any difference in the success rates. So the actual success rate or the actual success starts after evaluating for minimum of 5 years. That is a long term when we say, when it is when we evaluate it for more than 5 years, that is maybe more than 7 years. So this systematic review concluded that the history of periodontitis is not a contraindication to implant placement, but the rate of implant success depends on the severity and form of periodontitis. So therefore, the decision making of implant therapy in patients with history of periodontal disease must necessarily include a rigorous program of supportive periodontal therapy for long-term implant stability. So there's another one coming up, another systematic review and meta-analysis by Raman Oskait in 2014, which determined if there is a relationship between history of periodontitis and dental implant success and survival rates. So this review was done with studies from 2002 to 2012, and this was followed up for at least 5 years. So now in these, there were 19 studies which were finally selected, which included 3,814 patients, out of which 2,343 were having history of periodontal disease. Now, this is just to show you, if you compare it, you can see the implant survival rate in periodontitis patients is much lesser than as compared to implant survival rate in non-periodontitis patients. So what did they conclude? They concluded that patients with history of periodontitis had lower success rate, that is higher incidence of marginal bone loss as well as periimplantitis when compared with non-periodontitis patients. So now we'll see more of this, why it is becoming like this. Now the microbiota associated with periimplant diseases is similar to that for periodontitis. So as we know, as these periodontal pathogens, they have the tendency to colonize following implant placement, and this can happen within a very short period of time. Now these periodontal pathogens, they also have the ability to translocate in from periodontal disease sites to the peri-implant sulcus. So now this results in having a deep residual periodontal pockets, which are, that is, these pockets are usually more than 5 millimeters or more than 6 millimeters, and they are the ones which act as niches or bacterial reservoir for infections for adjacent dental implants. So this results in a higher risk for patients who are periodontally compromised or patients with history of periodontitis are exposed to a higher risk of periimplantitis and implant loss. So this is a very important study by Lee et al. In 2012 relating residual periodontal pockets as a risk indicator for periimplantitis in patients treated for periodontitis. Then another aspect we need to know is the marginal bone loss. Now, in various systematic reviews, when marginal bone loss was analyzed, what has been observed is a statistically significant difference between the periodontally compromised patients and periodontally healthy patients. Now, the reason could be, or this could be associated with the influence of the host, which plays an important role in the inflammatory process, and this may be significant in patients with history of periodontal disease. Another aspect is also local factors which may play a role, such as the reduced quantity of bone prior to extraction, which may be related to periodontal disease. Also, we need to know that when the teeth are extracted due to periodontal reasons, we can expect a lot of bone or considerable amount of bone, which is already reduced in the natural teeth. Plus, as Dr. Sharath also spoke about the prosthetic rehabilitation. So when we have to rehabilitate these patients, now what we realize is there is a very less bone support available. And then for a proper prosthetic design, we need to expose the surface of the implant or we need to have an exposed implant surface for a proper prosthetic crown or a bridge. So this further reduces the implant support, and this further poses greater risk for an implant failure. So these points also should have to be kept in mind when we are considering the implant success. Another very important systematic review and meta-analysis is by Shanovic, which is which was published in 2014, which compared implant failure rates in relation to dental implants with that is inserted in PCPs with PHPs. Now here the articles were reviewed from 1996 to 2014, and 22 studies were selected. And out of that, the number of implants which were inserted in PCPs were 10,927, and the number of implants inserted in PHPs were 5,881. So these 18 studies out of these 22 were followed up for at least 5 years. So what they have observed is a very significant observation, that is implant failures are 1.78 times likely to happen when implants are inserted in PCPs compared to those when implants are inserted in PHPs. So relative risk is 1.78. So what they concluded that increased susceptibility for periodontitis may also translate to an increased susceptibility for implant loss, loss of supporting bone, and post-operative infection. Post-operative infection was observed around three times more for PCPs. Now, what about chronic periodontitis? Is there anything significant for chronic periodontitis? Because this is the one which we deal very commonly. So here the systematic reviews have given an observation that patients with history of severe or moderate periodontitis have lost an average of 5 years after implants placement more than twice the amount of peri-implant marginal bone, that would be approximately 2.6 millimeters, compared to patients without history of periodontal disease, that is approximately 1.2 millimeters. And they also observed a trend towards peri-implantitis in subjects with history of severe periodontal disease. So this, what they say is, it increases the risk of peri-implantitis by 3 times. So aggressive periodontitis, anything significant? Yes. Now in generalized aggressive periodontitis patients who were treated as compared to periodontally healthy patients, there was 5 times more risk of implant failure observed, 3 times more risk of mucositis, 14 times more risk of peri-implantitis, and the implant survival was observed up to 96% as compared to periodontally healthy patients, which would be as high as 100%. So then another recent study, as recent as August 2020, so published by Pandolfi, which was a retrospective study to assess the survival and success rates as well as the incidence of peri-implantitis in patients with history of periodontitis and implants with 1 to 10 years of functional loading. This was a very significant finding where they observed after 10 years that they concluded that peri-implantitis begins to appear more frequently after the 5th year of functional loading, especially between the 7th and 8th years of function. So this we have to keep in mind when we are doing the follow-up for such patients. Now, again, we come to the same question, that does history of periodontal disease compromise implant success rate? So now, after going to this discussion, what do we feel? We feel that yes, history of periodontal disease has potential to cause a significant higher risk of increased probing depth, increased marginal bone loss, increased incidences of periimplantitis, as well as a higher risk for implant failure. Then we come to the other risk factors which are negatively affecting the outcome of implant or the implant success. Smoking, as we know that it is an established risk factor for periodontitis, and the negative effects of smoking on implant therapy is well documented. Now, just coming to the smoking and plus the PCPs or in periodontally compromised patients. So definitely we can assume that it will increase the implant failure, but the studies by Heights, Byfield and Yuba in 2009, they have assessed this and they said that it does increase the amount of or the risk of implant failure and marginal bone loss around implants by a factor of 2.5. Also, the implant survival rate in smokers with history of periodontitis was found to be poorer as compared to non-smokers with history of periodontitis. As you can see, this was 80% as compared to 100%. Now, also another important factor is, or the risk factor is the diabetes mellitus. Now, this also we know, and there is so much relevance is there in periodontal disease. In relation to this, what happens is, now we just have to see that there is a significant, statistically significant association between elevated HbA1c levels and increased marginal loss around implants. So in poorly controlled diabetics, a higher implant failure rate during the first year of functional loading has been observed. Now, this could be because of microvascular complications, which may compromise the healing of soft tissues and reduce the levels of bone implant contact. So then coming to the main part of this periodontal maintenance, as Dr. Sharath, my co-panelist, also has agreed to this, and I think there is no need for anybody to disagree, because this is the crucial part for implant success. So the control of periodontal and peri-implant parameters during periodontal maintenance are key factors for implant longevity. Now, all the systematic reviews which have been considered, all the meta-analysis and all the long-term papers which have been considered, they have one thing in common, that all agree that the SPT is the key, or it is very important for the maintenance of good implant success rate, or what I would say that SPT is a critical determinant for implant success. So now, what are the implications for clinical practice? Now, first of all, when a periodontally compromised patient is needed an implant, so first of all, our duty is to inform the patients about the risk involved. Then the decision of implant placement should be taken only after assurance of good patient motivation and compliance. Without that, we cannot even proceed, or we cannot think about placing an implant for such a patient. Then also we need to do our initial preparation and monitoring of factors of risk and of infections by removing periodontal pathogens, as we know that they may have a capability to translocate. So we have to prevent translocation of bacteria. Then we also have to be very sure that periodontitis should be completely and successfully treated. In smokers, smoking cessation protocol has to be followed properly. In patients with diabetes, there should be maintenance of good glycemic control to be achieved. And in all the patients, all the periodontally compromised patients, the golden rule is we have to have a strict program for SPT. Now, the most recommended protocol for SPT would be the cumulative interceptive supportive therapy that was given by Lang et al. In 2004. So my point here is that history of periodontitis is not a contraindication to implant placement, but may compromise implant success rate. Periodontitis must be completely or successfully treated before implant placement, and a stiff program for SPT should be set up for long-term stability of dental implants in periodontally compromised patients. I feel if this protocol is strictly followed, then every implant will get an opportunity to succeed. With this, I offer my sincere thanks, a big thank you to ISP for giving me an opportunity to share my views on this prestigious and unique virtual platform. I really feel honored to be associated with such a wonderful event. I also thank the moderator Anirban sir for this session, and also my co-panelist Dr. Sharath Shetty, who also has put very good points in discussing this. topic. And also a big thank you to all the delegates who are attending this session. Thank you once again.
Thank you, Dr. Sandeep, for a wonderful thing about whether it's overrated or not. I just wanted to add a few of the studies what you have included. One is the latest study in March 2021, where they have started a retrospective study of about 6,113 implants, 5 year of early failure or not. And eventually they came to a conclusion that the risk of early implant failures varied among different sites. You cannot exactly tell that all the implants will be a failure. With my little knowledge of whatever they are saying, they should be comprehensively considered as pre-surgical treatment plan. As Sharath also has put, as Dr. Sandeep has also put up, it's a long-term benefit thing what we need to take into account. So there are various of the studies which sometimes they say that they have taken long-term study of 172 articles for 20 years study they have taken up, and that in the end they have concluded that as told, surfaces also matters, as Dr. Sharath told. And because if there is a rough surface, one of the studies of 172 they have taken a metal, it's rough surface is better than a smoother surface. That's what they have come, and that survivability rate is more. So I will give a concluding remark. There are only two questions. I think both of you can answer one by one. Then I will give you a formula. One is by Dr. Ashish Kumar. Periodontically compromised condition and in an individual is mostly because non-maintenance and carelessness towards oral hygiene of the patient. Person who did not care for natural dentition, how do you make sure that they will do the same? They will have the same attitude. Very, very rightly said. What is your take on this, Sandeep, and then Sharath? I think first you can take Sandeep on this.
I can take this question. Okay. Yes, this is a very basic, very relevant question which has been asked, and I think I have made it clear in the presentation. So what happens is this is the basic attitude of the patients. Now, if such patients are going to have an implant, then we cannot immediately go for an implant just because of the desire of the patient. So as we are very versed as periodontists, we are used to or we are committed to doing SPT, and we are very good at patient motivation and patient compliance. At least we are supposed to be very good at it. So again, so this holds true for when we are placing an implants also. So unless we get a good motivation from the patient, good compliance of the patient, so after treatment planning, we cannot go ahead and immediately place an implant. So we have to wait, we have to observe, we have to recall the patient, and once we are satisfied, when we are very sure that the patient is now able to maintain properly, then only we can think or we can start planning for an implant placement.
Sharath, your take?
Yes, sir. In the similar way, like if the patient has Dr. Ashish's question, if they are not able to maintain their natural dentition and if they are suffering from periodontitis, I think they won't maintain the implants also. From that point of view, whatever the teeth are there, that has to be maintained well, or whatever the surgical techniques are there, treat them and see to that they are in the periodontally best possible status. Probably then the implants can be done with the tailor-made, customized SPT protocol, then they are ideal candidate. Otherwise, as I mentioned in my presentation, probably other varieties of prosthetic options like maybe the simple RPDs or cast partial dentures can also be given to them.
Okay.
It's not up to the mark in
Anirban sir, can I ask, give another small explanation for this?
Yes, sir. Yes, sir. Please, please, please.
It's in a lighter vein.
Yes, sir.
Since the natural dentition is free, people are not bothering about it. But when somebody shells out lakhs of rupees for a new dentition, I'm sure they will do the maintenance. I'm not advocating either way, but this is just in a lighter vein.
Yes, sir. Yeah, I totally agree with you. Even there are studies, sir, which have shown the completely edentulous patient There are studies by Leukovic and all. They have completely shown that any edentulous patient also after the placement of implant after 1 year after extraction, that means it should be free of any microbial load, are having failures because they were a patient of periodontitis.
Yes, sir.
Yes. So thank you, sir. I'll take up one more question is there by Shiv Manjunath. I don't know. He has put up as that Mengel's report says aggressive periodontitis has good prognosis. Your comment. So before I will give a comment in the end. Sharath, anything take on this? Like aggressive patient according to Mengel's?
Yeah, aggressive. There is localized and generalized. No, currently there is nothing called aggressive anyhow. When in the aggressive, if you see the organism responsible is AA, sir, that is Actinobacillus actinomycetum formitum.
Yes, exactly.
And if you see the literature, even in the LAP topic, they say like after certain period of time, these bacteria lose their toxicity. They lose their, or there is a reduction in the ability to produce the leukotoxins. And also, if it is localized aggressive periodontitis, as all of us know, these organisms are mainly around these molar and incisors. Maybe one patient comes to us, we say one molar is affected with the localized aggressive and indicated for extraction. Once the tooth is removed, over a period of time, the microbial load is definitely reduced. So that the literature says, if you are doing an implant in a localized aggressive periodontitis patient versus a generalized aggressive periodontitis patient, always the prognosis is better in localized aggressive compared to that of the generalized aggressive periodontitis patients. I hope.
My take goes. Yeah, Sandeep, you can just put in a review on this. Okay. What is your take on aggressive periodontitis cases are better, better for implant?
Sharath has already mentioned it. Okay, the problem comes when it is generalized aggressive periodontitis. Like most of the studies, like maybe the earlier studies also, they have stressed about the risk involved. So in localized cases, they may not be, like depending on the now latest literature says that okay, it is not a major the problem or a risk for the implant success. But most of the studies still say that generalized aggressive periodontitis, there is higher risk of failure as compared to chronic periodontitis.
Yeah, I also give a take on this because there is a study in 2014 by Homle Wong and they have done a systemic and meta-analysis. They also mention that the risk of generalized aggressive periodontitis cases, failures are more than chronic periodontitis cases. So it is as it is taken. If it is a localized, okay, but again it depends on the amount of bone loss which was there during the periodontitis case. If I'm right on that aspect of time, as meta-analysis and everything tells. So I think there was only 2 questions related, and thank you very much. Let me just conclude with the with this meeting of as a moderator. So in the conclusion, it was a wonderful points given by Dr. Sharath for placement, and even Dr. Sandeep. He also told whether it is overrated or not. He was like it is might be a little overrated that we usually do. But in the end, none of the article or none of the meta-analysis or systemic analysis has told that a periodontitis case patient cannot be placed, implant cannot be placed. First point. Yes, there are various risk factors, as both of you have mentioned. Smoking, the diabetes, systemic disease, genetic factor. This again comes into in general of periodontitis cases also, the success rate. And the most important of this particular thing, whether implant has to be placed or in a periodontally compromised case, is SPT, which both of you have agreed, and all of us as a periodontist agree that if SPT is not done or maintained, then it's of no use whichever implant you place, the rough surface, hydroxyapatite coated, or now the whatever the present thing is basal implants, or platform, whichever platform switch, whichever, or what I would tell any ridge expansion, and then you place it. But unless and until the patient has maintained it well, it is not possible to have a successful periodontally compromised patient of maintaining an implant. And as it is 10 years, if the success rate of 10 years of an implant is there, that means it's a good success rate. That's what we take. And as I would like again put up, any cases, if the success rate of an implant is 97% or certain cases 95% also, for a 10 means 95% success rate, I think it's a wonderful success rate. So overall, to conclude with this, all the systemic factors, all those smoking and things like that has to be taken into account. Patient, the particular the periodontist or any dentist per se, should take into account one thing is what is the proper maintenance of the patient. It is not that the patient has come, I want to place an implant, and they just place it implant for the welfare of the money or whatever, but they have to see the success also, how the patient success rate is there. And second, and another important thing is systemic maintenance, and first and foremost important is the treatment planning. Whatever it might be, whatever per se, whatever whoever has said, Homle Wong or Kalmesh or Reco, whatever 15 years, 20 years study, 6,000 implants or 20,000 implants is what doesn't matter with that. First, everybody has said SPT and your treatment planning is the ultimate goal of the success of placing an implant, whether it is in a periodontitis cases or whether it is not a periodontitis cases. So with this, I conclude the meeting. It was a wonderful interaction, and thank you, Dr. Anil, Dr. Nitin, Dani, Dr. Ashish Jain, and Abhay Kolte, to name a few. I mean, Jilu is there. So for giving us the opportunity to have a point counterpoint or rather exactly our point. We have placed our point in front of all the PG students, and they are wise enough to take our points, and they will be doing successful implant placements. So with this, thank you very much, everyone.
On behalf of Indian Society of Periodontology, we express our sincere gratitude and pleasure in thanking Dr. Anirban Chatterjee for his excellent way of moderation of this session. It was really a thought-provoking session which shed light into this spectacular topic. Thanks a lot, Dr. Anirban Chatterjee, for moderating this session in an excellent and interesting way with the scientific evidences and enlightening us with your experiences and knowledge. Thank you.
Thank you. That comes to the end of the session for today and the end of the session for the scientific session in the main hall. The last 3 days we are quite busy with the scientific sessions, and we always feel that because after the last day of the conference or the PG convention, while going back after meeting friends, we generally feel sad. The same feel we have in the virtual platform, because after a long time we are seeing people of fellow colleagues, and we had a real nice time for 3 days. It's a new platform, very well appreciated. Today we had 2 beautiful lectures. The first one by George Pellicos on management of extraction socket in periodontitis patients, chaired by Dr. Gopalakrishnan and Dr. Neeraj Deshpande. And this wonderful session, exactly my point, your take, moderated by Dr. Anirban Chatterjee and panelists Dr. Sharat Shetty and Dr. Sandeep Lavande. So entire 3 days of programs was very well appreciated. Thank you all the speakers and the panelists and the moderators. And it was nice to see that the entire session for the 3 days, all the sessions were on time without even a single minute lapse from our side or the tech team side. And special thanks to Dr. Nitin Dani for sitting through the entire 3 days, and especially alerting us in the morning at 8:15, and he is there always. And he has been leading the main hall team. So special thanks to Dani sir. And also I thank the moderators, coordinators of the main hall, Dr. Jilu, Dr. Hemlata, Dr. Arjun, and the entire team. And last, I thank the tech team, the WAMA events, special thanks to Dr. Neetu and Sejal also. And thanks Anirban, thanks Sharath, and thanks Dr. Sandeep. And Danya sir, I think valedictory function is at 5 p.m. I request everyone to be there at 5, and we'll meet for the valedictory function. Have a nice Sunday. Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you, Dani sir. Thank you so much.
So you want me to, I think I need to open that up. Praveen, you need to just guide me because I'm not on my computer.
Yeah, sir. Just keep your PPT open, sir. Then you can see that share screen. You're on system or Mac, sir?
I'm on system.
System, Windows, right? So just click on that share screen button.
Let me first figure out where my presentation is.
Okay.
Yeah, here it is. All right, so this goes here. To the share screen.
Share screen and select your PPT in that pop-up.
Still not showing the PPT actually.
No, click on share screen and under basic you can see.
I've done that. Here it is.
Yeah. Yes, sir. Go to
it works?
full screen. Yeah, it is visible.
Yeah.
Go to full screen. Sir.
Yeah, okay. Thank you.
Yes, sir.
Thank you, Dr. Grover, for the words that I don't deserve certainly. But thank you so much for at least making me feel good about it. And welcome all the students, our lovely students. We see you in good number, and as we move on, I'm sure we'll have more of you joining us. So before we move on, I really need to share something with you. So the other side of the screen that you see, the gentleman with equal gray hair as mine, Al Kantarji. He's a name to reckon with. I mean, all of you have heard about him, all of you have read about him, all of you would want to actually, see him in person and touch the flesh and, do that. But I have been really fortunate to have started my career under his guidance, so as to say. I mean, I'll take 2-3 minutes, but I can't really stop myself from saying this. So after having finished my post-graduation from Nair, I was fortunate enough to get a postdoc fellowship with Dr. Van Dyke at Boston University. That was the year 1999. So that was my first flight ever in my life, and that first flight was destined to go to Boston. So you can't get luckier than that. And the moment I landed in Boston, there were these two gentlemen standing there at the airport with Dr. Van Dyke and the other person whom you see on the other side, a lot younger at that time, but equally handsome. So he was there, and that was my first interaction with him. He was actually working with Dr. Van Dyke a year and a half prior to my joining there. So he was sort of, senior to me there. And from day one till the time I left Boston 3.5 years later, not even a single day I can say, passed without us interacting with each other. And there have been, those are stories for another day. But I owe a lot to whatever we could do in Boston. It was essentially, because you were there to guide us. And we had a wonderful time, and that friendship still continues. There have not been a single occasion when I have requested Al and PJ, his wife, to be with us, and they have said no. They have traveled all the way to India on occasion more than once on a simple invitation. They have agreed to stay whichever way we have wanted them to stay, never complaining ever. But I really can't thank you enough for all what you have done. Thank you very much. And okay, so students, so the topic that we are going to touch upon today, and Alp is going to speak more than what I would just lay a little groundwork for that, so that all of us are on the same page. Yeah, the idea of this presentation today and talking to you, and please be interactive. Please talk to us. Give us your feedback. You ask as many questions as you want. Dr. Kantati loves questions. If you don't ask questions, he really gets annoyed. So, you please ask questions. Otherwise, I'll have to make up questions for you. So do that, please. And the idea is how do you see your MBS? Do we get into our postgraduate training only to learn few clinical procedures and get out of our MTS and then practice those procedures all our life? Is that our whole agenda of spending 3 most valuable years of our life to run few selective procedures, for which, honestly speaking, 3 years probably is little overkill.
If you have to really delineate the procedures, if you are there only for the procedure, you can probably learn those procedures in 6 months of time and then go out and practice. Or is it something else that MDS is supposed to be? The master's program is supposed to be. You are going to be a master in a specialty. And when you are a master in a specialty, there cannot be a super master. So that essentially means that you have to master the art of the science, the art and the science of the subject that you have been trained in. And that art and science cannot be restricted only to clinical. Clinical is important, no doubt about it. But it, what is it that you are actually giving back to the profession, to your specialty in terms of the research? Have you done anything in your 3 years which would give some value addition to the specialty? Have you done something in those 3 years which 20 years down the line you will be proud and still say that that is what I did? Look at that paper that I published at that time. Because we understand moving out of your MDS, very few would stick to research, partly because we are not research bent mind anyhow. Most of us would want to either get into clinics, if not into clinics, want to get married and settle. So essentially meaning these are the only 3 years. These are the only 3 years for you to do something worthwhile. These are the only 3 years and only 3 years in your life when you will be able, when you have the liberty of spending 100% of your time into something that you should be doing. There is no other distraction. There is absolutely nothing which stops you from spending your 6 a.m. to 6 p.m. or beyond that into a lab doing some research. So this is what we are going to talk about today. There are a lot of excuses we come and we come to that we can't do this, we can't do that, and we'll touch upon that also as we move along. But let's start with our presentation. So MDS and research, can they go hand in hand? And when I say research, I mean research. I certainly do not mean a study for the heck of a study. When you say research, then that means that there is a viable question attached to the research, a question which the literature also needs an answer, not a question to which there is already an existing answer. And that is where we all falter in terms of spending our 3 years. Most of us, and including us also when we were young, spend our 3 years in doing something which is not addressing any pertinent gap in the a pertinent gap in the science of periodontics. So just to lay the base to the story. So in 1947, of course there was no MDS institution, and 1959 was the first time when postgraduate departments were established for periodontology at Government Dental College in Hospital Bombay and Nair Hospital Dental College Bombay. I'm proud alumni of Nair Hospital Dental College for my perio specialty. That started in 59, and almost 70 years down the line, today we have 269 dental colleges. And we have 800 MDS postgraduates passing out each year. And these are the numbers for only the specialty of perio. So we have 800 periodontists passing out every year. Why is it that we are not able to do good research? Why is it that research is not there in our mind when we are joining post-graduation or even after having joined post-graduation? I think the problem lies in these 2 or 3 slides. This is a guiding document from Dental Council, which tells the dental institutions that what is it that you are supposed to be teaching to your students? What is it that the student should be knowing in terms of skill sets for them to successfully complete the course of Masters in Dental Surgery in the specialty of periodontology? And if you go through them, From module 1, which starts at first year, it talks of preclinical work, it talks of some basic diagnostic microbiology, immunology, introduction to genetics, and talks of clinical work. The module 2 talks of clinic. Module 3 talks of all the clinical procedures. Module 4 again talks of clinical work. Module 5, second year, talks of clinical work and surgery. Module 6, another set of clinical work. Module 7, more clinical. Module 8, publication of an article in a scientific journal. Now, which article? Did you mandate the student to spend a specific time of their post-graduation into a scientific research? Yes, we did, because the student is supposed to do the dissertation. And unfortunately, so how the dissertation topic is decided? The synopsis of the dissertation topic is to be given within the first 6 months of the student joining the specialty. So somebody who has just taken the first step in periodontology, you are asking him to write a topic on which he intends to spend the next 3 years of his life, without really going into the topic per se, into the specialty per se. And that's where the dichotomy starts. And that's where we hunt for topics, which are not really scientific in nature. So it is not that DCI says you don't do research. The problem is we and when we say we as academicians have actually taken the wordings from the Dental Council of India's Holy Sermon as our Bible, and we want to stick to it as if deviating from it would be a sin. But then that is not a true justice to your 3 years. If all you are learning through these 9 modules is clinical and more clinical and more clinical and more clinical, you learn that, that's okay. But then there are no laterals to it. Okay, dentistry certainly has transitioned from a purely clinical science to an extended scientific discipline, contributing significantly to global research over years. For a statement, I'm making this contradictory statement to what I am saying to have my points cut across to you, that we are contributing significantly, and you would know that once we look at the numbers. And we did this analysis at our end, due to be published anytime now. Wherein we have looked at the scientific output of our dental community all through these years on various parameters, of course, and some of the results I'm sharing with you. So for the time period from 1955 to 2007, US ranked first with maximum publications. Right now, I'm being very quantitative. I'm talking only of numbers. Ranked first with maximum publications ranging in around 79,000 from 55 to 2007. That is a good 52, 53 years. And during the same period, the publication from India was only 2,138. However, things drastically changed post 2007. In the time gap of 2008 to 2021, US still have the maximum publications, which is 46,000 now, in a gap of, say, around 13 years. But look at India. Indian publications are now 16,960. In 13 years, vis-a-vis 2,000 publications in 55 years. From 19th rank, we have shot to 3rd rank world over in terms of quantity of publications. But when we do a qualitative analysis, things fall flat on our face. Whatever we were publishing earlier probably had good quality. What we are publishing now has gone down drastically. Some of this could probably be the reason that the number of publications, because this is rubbed against the number of publications, so of course the citations are bound to go down. But in terms of quality, we have not really improved too much. Not improved, we have actually drastically lost ground in terms of average citations per paper. If we look at overall distribution of dental publication in Scopus, we have published around 15,000 total till now. From 2007, it is 1479. Till 2007, and after 2007 is 13,707. It's only the articles, and of course, the same is, the books have stayed the same, the book chapters have stayed the same, the conference papers have come down, but right now what we are interested in the number of articles. This looks amazing if we are talking of number of publications. Look at the graph. I mean, it's almost like not a good corollary to make, but this is almost like a COVID graph. It shoots. What is the reason for this increase in number? To my mind, the reason for this increase in number is only because of one direction from Dental Council of India, which probably came in 2007 or 6, wherein the dental faculty was forced, and apologize for using this word, but dental faculty was forced to have certain number of publications if they want to get promoted. And that pushed the things left, right, and center, and that is where the spike in the graph came. So all of a sudden we were publishing. We were publishing, but just publishing. We were not looking at the quality of the book. And that is why we do not have citations. We do not have our publications in the best journals across the world. We are still so much dependent on our homegrown journals. We are still so much dependent on hunting for a journal which would publish easily. We are still so much dependent on staying away from the journal from where the rejection rates are very high. But anyhow, the positive picture is these are the overall description of the top 5 dental journals on the basis of number of articles published from 1955 till date, and these are the 5 journals, and proudly our journal also figures in that, and figures quite high in terms of the number of articles published, and that is due to the wonderful work of our editors. So why is it that we are having a lot of dental related publications post 2007? This is based on the top 5 publications, the topics of those top 5 publications. So these are the 5 publications which are toply cited out of India. These paper title hints to the area of active and rapidly disseminating research, and during 55 to 2007, most of the research was on cancers, precancerous, etiological, and risk factors for cancers. That is where most of our research came. The top research came in the last 5 decades or so. However, post 2008, things started to change a little bit. And that's when, we have started to diversify, and now some good papers are coming. I'm not saying at all that good papers are not there. Some of them are really exceptional papers which come out, really worth reading, worth remembering papers that come out from within our country, but the numbers are much less than the desired numbers we should have been. So what are the reasons, what are the possible reasons that we run away from research? Yes, and I have deliberately used the word run away. There are a few things, which I feel are important for us to know. Some of you would relate to some, others to others, probably. All of us, and when we say us, I mean us, the teachers, have this key article syndrome. You do a good study, you spend nights and nights and nights, framing a good question or a good research question for yourself, and you go to your teacher, and the teacher says, okay, bring me the key article. If the key article is said from the point of view of figuring out from where, what manuscripts are responsible for framing the question that this student has come to me, it's okay. But this key article syndrome is essentially, what you are suggesting, tell me where it has been done earlier. I mean, if it has been done earlier, why are you wanting the student to spend 3 years on it? Why are you so insistent on a key article? Why are you so insistent on a base article? If there is a base article, if there is a key article, and if it happens to be the only article, and if we really want to look at that article from the point of view of whether it has been done before and whether it is doable, then it is not worth it. Instead, we should, and the student also should be able to justify the research question that he has framed based on 10 articles. That this is a gap that I found in one of the studies I was going through, which has been addressed in these many ways, but still this gap stays. And this is the gap that I want to address. My area is the unaddressed area. And my area, I mean to say my geographical. So, role of NASADS in the management of post-operative analgesia, as a post-operative analgesia, post-periodontal surgery. Ibuprofen, for example. It has been done over and over and again. But, sir, this has not been done in my city. It has not been tried on Chandigarh population. It has not been tried on Visakhapatnam population. It has not been tried on Kochi population. Why? What is the logic of this being tried on a local population? Do you foresee any reason that the results would be different from what the results are on a Kochi population if you do that on a Chandigarh population? So if you look into the research that a lot of students are doing, you will find so many of these, which are essentially addressing the same question but in a different population, and then the different population is a convenient sampling, is a population within their premises of the college, and that's what it is. Without a very scientific reasoning of why that population, what is in that population that probably would make them not react the same way as the population 200 kilometers away from you. Compare A to B and anything up to C. So we have a bone graft A and we have a bone graft B. And we have a bone graft C. Sir, bone graft A has been compared to B, B has been compared to C, but A has not been compared to C. Is there a viable reason why A should be compared to C? Just because A and X has not been compared with each other, let us compare both and frame a question. We get so many students coming to us with those kind of questions. You need to ask yourself what this comparison would tell us. Whether the bone graft A, which has been proven to be better than B, and B has been proven to be better than C, now comparing A to C, what is the result that we would expect? And why is it that you want to do it again? This is one major issue, piecemeal research versus sequential research. And this is a very country-specific issue, I would say. And this has to do with your teachers, with us. How does the research in the department goes? We have 9 postgraduate students, and all these 9 postgraduate students are addressing 9 different questions. And question 1 to question 8 has no relevance. Question 1 to question 3 has no relevance. And once these 9 students pass out, another batch of 9 comes in and they address 9 different questions. So essentially meaning within my department, I am not able to build up a area of concern, an area of priority for my research. If you look all across our country, if we have to look at identifying individuals globally who are good in immunity, in periodontal immunity, you can immediately say Professor Tom Van Dyke, Professor El Khattachi, Professor Hatija. You can immediately say that because they have spent their lives into it. But can you name one Indian researcher who can get up and say, I have spent 20 years in periodiabetes and periodiabetes is my forte. Here are my 80 publications on periodiabetes. No. And that is why when you enter a department, you really do not have a direction where you will go, because that department itself does not have a direction. And then you are asked to hunt for the topic, and when you hunt for the topic, you are asked for a PR. And that's why we are not able to do what we want to do. Yeah, I want to do a lot of things, but there's lack of infrastructure. My college doesn't have the basic facilities. You're asking me to do a immunohistochemistry. No perio department in the world, and we have been fortunate to be working at Boston University, working at Harvard, Albus now at Forsyth. No perio department in the world is fully equipped wherein that department can say, bring me a work and I will do it. You have to rely on others. You have to collaborate. The only thing you need in your department is a facility to store your samples. If you are able to store your samples, from getting them spoiled, properly store them, there is no research that you cannot do. You just have to hunt for a suitable place to do that. My samples go as far as Visakhapatnam for evaluation. Because we store them, we transport them. I don't have those facilities. We are working with COVID now. I do not have pseudovirion platform at my end. Absolutely not. That is available only in Visakhapatnam. So I have to send my samples there, but I have stored them. The only thing I have within my department and other departments around, those who are doing work, is that we can store the samples. And once the things start, of course, slowly and gradually you build up on the infrastructure also. So that is not an excuse at all. That leads to, me, myself syndrome. I do not want to collaborate. I do not want to step out of my department and collaborate with somebody for which would mean, me going to that facility, 2 times a week for the next 2 years of my life. I don't want to do it. Please give me a simple topic. I don't care. Then your 3 years are gone. Which topic you want? 90%. If I ask you the question now, 90% of you would say, give me a simple topic. Why? Because we are surgeons. That is why we have joined perio. My dear friends, you would start working on or if you would get a clinical research topic or a dissertation topic, you would start working on that within the 6 months of you joining your postgraduate. And it would implant. Let us take implant. Implant is a good topic. I will do implant for my dissertation. Why? That way I'll be able to learn implant. If your idea of taking up a topic, a clinical topic, is to learn that procedure, please. So the first implant that you would be putting in your life would be your first patient of the study that you are going to do, wherein you would want to see the loss of the crestal bone loss compared to 2 implants. I'm talking very basic. So my dear friends, the bone loss that you will see in the first implant that you have placed is not because of the design of the implant. That is because of the lack of skill in your hand. If you have to do a clinical study, make sure that you achieve a level of perfection in doing a clinical procedure that you are wanting to test. And only then take up a clinical study. Just because you want to do a clinical study to learn the procedure otherwise. Who stopped you from placing 50 implants? Nobody. But do not mix research and study together, ever. Lack of funds. Where are the funds? Let me tell you. We get a lot of funds from the funding agency. ICMR has one perennial problem. They say, we have money for oral health. Where are the projects? And the reason for that is, writing a grant is not an overnight job. You need to learn to write grants. Al would tell you much more than I can. I mean, he's an expert in writing grants. But it has taken him ages to write a proper grant, an application for the grant. The funds are not a problem. The problem is for us to sit down and formulate a worthwhile grant application, because that requires. You do it I can tell you from my experience, ICMR will certainly provide you. They are short of proposals. We have got, since we work closely with ICMR, they have asked us so many times, please organize a workshop for the young researchers. We will tell them how to write grants. We will tell them, we will handhold them. We will give them a seed money also for them to start the research. So lack of funds is an excuse and would stay an excuse, not a reality. And lack of networking opportunities. I wrote that again in just during my presentation here. You know, where do you do your networking? The networkings are usually done when all of us meet. You know, the present times are not allowing us to, but when we meet and when we talk to each other, what the student in Nagpur is doing, what the student in Chandigarh is doing, what the student in Delhi is doing. But for us, the platforms of conferences are actually a gourmet feast. We don't go there, you know, for our scientific appetite. So students, these are some of the things that I thought, you know, are excuses for us to not spend 3 years of our life into doing something which would be worthwhile. The document that you write, the dissertation that comes out after 3 years, should be the one that should give you pride 20 years later also. If you are doing a work on which you will be really not happy what you did during your MBA, it's not really worth it. And it is not impossible. I will share, we collected the data from some of our colleagues, and this is the work which is being done in India. You know, this has come from Rajas, you know, biofabrication of titanium herbal nanoconjugates, their characterization, evaluation of synergistic antimicrobial activity, effect of beta-glucan biopolymers on the surface addition of osteoblast on titanium surfaces, you know, association between NAT2 gene polymorphism coming out of Bangalore again, and chronic periodontitis, C-telopeptide of type 1 collagen, resolving D1 and TNF alpha. These are all being done as of now, as we speak. So it is not that the research is not being done. It's just that it is being so concentrated at so few places that it has not percolated. My idea of telling you all this is that this is possible. If they can do it, nobody stops you from doing that. You know, likewise, we have from Bangalore, Dr. Biju Thomas, a very senior person with us. Biological properties of human periodontal stem cells, you know, formation from PPDL-derived stem cells and comparative evaluation of inflammatory markers. Then we have something coming from Guwahati, from Dr. Spurda Jyotidas, Dr. Varsha Rathore from Bharati Vidyapeeth. You know, a lot of work is being done. Huge amount of work is being done. Good work is being done. We have this coming from Kozhikode. Then we have, you know, there's no point in reading all this, from Kotiwal, from Kathak, Subhash Chandra, good friend, you know, he's doing amazing work with his postgraduate students. We have this from Bhimavaram, you know, Rajiv Gandhi, Bangalore. This is some of the work that we do. Now that you have the privilege of presenting, so let me tell you. So some of the work that we are doing currently is the analysis of M1, M2. Actually, this has been done already. Effect of periodontal intervention on oxidative stress in CKD patients going on. ICMR funded 3-dimensional finite element analysis of stress distribution in immediately placed, immediately loaded. Design and preclinical validation of a customized 3D printed dental implant. Development, characterization, and in vitro validation of composite anti-plaque agents based on selected phytochemicals. So these are some of the work that we do. Some have been completed, some in pipeline, some ongoing. So dear students, you know, I would want to end and not come any more in between you and Al. But you know, I would want to leave with this, that the best way to predict your future is to create it, and nobody else is going to create it for you. So create it yourself. Spend these 3 years in a way that you would be proud of. Thank you very much.
Thank you, Dr. Jain. It was really a wonderful and a riveting presentation. And I totally agree that interest in the fundamental research has been decreasing over a period of time because the focus has shifted towards the clinical, research. And that has perhaps been one of the reasons that why we see so little fundamental research, because it is always that what are the clinical implications. So we are more bothered about the clinical implications rather than, having something of a pure research sort of thing. Dr. Jan, if you allow, I may ask you a small question.
Yes, please. Please, sir.
Sir, you have talked so wonderfully well about the avenues, and you have been wearing many hats. You have been at the topmost position in our society also, and you have been a top-ranked academician also. Sir, what do you think is the role of professional societies in, making the student interest more in research, the MD students, the role of the professional societies as such?
Wonderful question, I must say, Dr. Grover. I think the professional societies and the basic owner should be on the professional society. Because this is the society, this is the platform where all the minds in that speciality congregate together. The society should actually create platforms for the young minds, for them to interact. We really need to get out of this psyche of coming to the conference and looking for food and more food and more food and more. We should at some point in time adopt to the culture. You go to an IDR meeting, there cannot be a bigger meeting than IDR. Where is the food served in IDR? You come, you learn, you present, go out in the cafe, have your lunch and come back. So the society really needs to take that onus on them in terms of creating enough opportunities for the students to interact. Give them platform to share. Let the societies, and we do that. I mean, fortunately, ISP does that. We started colloquium on a topic specific, and we are still continuing with that, wherein we go, all over the country at 3-4 places talking on a single topic. But that's what society should do. Society may also look in terms of hand-holding some. Excellent Selva, you would of course write that. So Selva has taken something that I was about to say in terms of having a multi-center trial. We have tried that at the society, in the society many times, and I think that is what the society should do. But again, society or anybody else would be an helping hand. Till the time I, as a student, don't tell myself that I have to spend my 3 years in a worthwhile manner, nothing will happen.
Very true, sir. Very true. And I think within the society, we should find more means, to attract our young generation towards the research, as you've rightly said. And now, sir, I think it is time to call Dr. L. I would begin with the short introduction of Dr. L. Dr. Al Kantarci holds a DDS and a PhD degree, and sir is a certified specialist of periodontology and a diplomate of the American Board of Periodontology. He is a senior member of the staff at the Forsyth Institute in Cambridge, USA. He serves as a faculty member at Harvard University School of Dental Medicine and as an adjunct professor at Boston University's Henry Goldman School of Dental Medicine. He has started his career as a dentist after graduating from Istanbul University in 1991 and moved to USA as a postdoctoral fellow. Upon completing his postdoctoral studies in 2002, he has started clinical periodontology specialization training at Boston University. After graduating, he was appointed as an assistant professor in 2004 at the Goldman School of Dental Medicine and was promoted to the associate professorship in 2009. In 2010, Sir joined the Forsyth Institute and Harvard University, maintaining his faculty position at Boston University. He is a practicing periodontist and implantologist. Dr. Kantarci is the clinical director of the Forsyth Institute's faculty practice, and during his academic career, He has been actively involved in training, education, and patient care, and has mentored more than 50 PhD, doctorate, and master's theses. Also taught in several graduate and postgraduate clinical and didactic dentistry courses, serves in the editorial board and a reviewer of more than 20 dental and medical scientific journals. His research interests include molecular mechanisms and resolution pathways of oral inflammation in periodontitis, experimental models, and he holds several patents also, having published more than 150 articles in peer-reviewed scientific journals. He has written many book chapters and presented more than 500 oral talks and posters in dental and medical congresses. He is also the executive director at the International Academy of Periodontology and assumed the role of the editor-in-chief of the Journal of IAP in 2021. We welcome you, sir, with a good morning once again.
Thank you, Dr. Grover. Thank you. This is a great honor for me to present to my Indian colleagues and my Indian students. And I mean, it's been a pleasure. I wish I was there, but I'm just enjoying my tea right now, as if I'm in India right now, rather than only enjoying the beautiful Indian cuisine that I've been always lucky to experience myself with my travels to India. And it's certainly a great honor to be with you, and it's certainly a great honor to share at least the virtual stage with my dear brother Ashish. And so it's a really a pleasure to be at this position. And this is actually a really interesting talk because it's not going to be only a scientific presentation, but following up what Ashish has presented is hard always, because he always is very methodical in presenting the details, like the work. I'm more of a dreamer than Ashish, so I'm glad that I'm following him because I don't have to set the stage for what it looks like. But during our presentation preparations, we also discussed a little bit about what we should talk to our young colleagues in India. So that's the reason why I prepared something quite different compared to what I'm used to present. So it's going to be still a lot of touching on the work that we've been doing. But I hope my colleagues will get more questions than my answers at the end. That's the whole mission that I've been doing in my life, to stir up more discussion and more curiosity rather than giving the answers for that. So without further ado, I will share my screen. And if I can. So can you see my screen?
Yes.
I think we're all becoming Zoom gurus at the end of the day to do this stuff. So this is, it's a great honor to be here. First of all, I mean, this is what Ashish and I looked like. So when and we were not professors by that time. So we were just simple junior postdocs, just fresh. And as you can tell from the hairs, Ashish were lucky than me. I mean, his hair, of course, grew very, very dark for a long time. And I was always very jealous. But I'm glad that he caught up. So we're equally gray right now. So one thing I liked about this seminar title is also not only the title, but the question about can they go in hand in hand. I highlighted this over here because this is our life story with Ashish. We've been always going hand in hand for the last 21 years that we met. And after these wonderful photos, I didn't dare to put any photographs that were actually representing us in between. So this is what we looked like, and this is what we like to remember each other in many ways. And I hope everybody on the call will appreciate that you can. One thing that I can promise everybody is that you will stay young when you're doing research, because one of the advantages of our job is that we always interact with the same age groups, regardless of how old we become. So at the end of the day, we always think that we're staying young and we're staying very productive, very active, just because we train the same age group over and over again. So it's certainly a great rejuvenating longevity creating exercise of being an academician, being a researcher, and being a mentor to our young colleagues. So I also took the liberty of changing my lecture title a little bit. And what I would try to push is that not to only talk about the MDS and research. And yes, the answer is, can they go hand in hand? I can tell that yes, the answer is very simple to the question. But what are we really doing today? And how can this be going through the education and dental research? And what can we do today? Can it change the way that we actually look for future? So that's what the entire lecture is going to be about. I prepared 29 slides, including my title slides, so I'm not going to bombard you with a lot of slides. And one of the things that I discovered through this past year of Zooming is that you cannot cover as many slides as you want throughout these lectures. And so there's always going to be some leftovers. And I also want to stir up some discussion as we discussed. But let's move on. So this question is how I start my thinking. Why dental research? Why should we even care about dental research? So last time when Ashish and I were together in India, we did the first colloquium back in 2013, when we traveled across India in 3 different cities in 6 days, including the travel. And it was in the Zoom times. So I wouldn't do this for a lot of people in the world. I did it for Ashish because it was crazy. We were like lecturing in one city, and I'm not talking about neighboring cities, packing up our bags in the afternoon on the second day, doing another trip to another city from Delhi to Kolkata to Bangalore in 6 days, literally, and traveling across the entire country with our colleagues from rheumatology, endocrinology, diabetology, and cardiology. So it was very learning, very teaching. And every lecture, if I remember correctly, Ashish was attended by about like 1,000 plus attendees. It was amazing. It was a great platform to talk to interact to each other, and also learn from each other, and also understand the country from different perspectives. And obviously, being in a country like in India, it's still a fragment, it's still a fraction of what we could be exposed to each other. But there was a great meeting organized by ISP there, and I really enjoyed it every moment. And at the end, we were very tired, but we really liked the way that we actually doing it. But one thing that we were like really recurring theme throughout this travel was, and throughout my career, is that first of all, you need to present what you're doing as unique. I like this banquet idea that Ashish was comparing the conferences. It's exactly the same thing. It's a delicious, very savory banquet that you're actually going to present your presentations to not only to each other, but also to people who are actually outside our disciplines. So why is it really important? Because what we're dealing with, dentistry and periodontology at large, is unique. So there's no way this can be actually reproduced anywhere in the entire human body or any in the mammalian body. And the second bullet point, it really talks about it. Teeth are the only mineralized structures that traverse the epithelium exposed to an extremely contaminated external environment. We periodontists, or the students of periodontology, as I try to see myself as well, is the only place in the entire body that deal with a hard tissue contaminated, and then really dealing with a very specialized mucosal immune surfaces. The soft and the hard tissues include and are resilient attachments, and these structures, being the periodontal ligament, is unique. There's no other joint, there's no other structure in the entire body. So we should start with selling our idea in this environment, in this niche. There's no one else better than we do what we do. So it's very important. The fourth bullet point, which is this part, which is within the sophisticated organ system, the tooth serves not only as an medium for external stimulus, but also its surface is an environment that accumulates and colonizes by a diverse group of bacteria species. Therefore, the interaction between the oral and dental and periodontal tissues and these organisms is a lifelong process that begins immediately after the tooth eruption. So this is very important. When I first moved to Forsyth, my office, and it's still the same office that I'm actually residing right now, was next to Professor Sokransky's office. So he was my neighbor. So Sig retired before I joined Foresight. That meant in his life that he was still coming to work 4 days a week. Okay, so this is very interesting, and he was very early bird. I mean, I come very early, and then Sig was coming early. And every morning when he was passing in front of my office, he was quizzing me every morning and sitting in my office chair here, which is still the same chair. And he was asking me about what I was supposed to do that day. And this is pretty tough, because it's Sikros Sokransky asking you guys every day what you're supposed to be doing that day, and you have to come up with a new answer every day. And one day he said, Alp, we're very good in what we're doing, and we wrote the literature for the entire microbiology research in the rest of the body by doing periodontal immunology, periodontal microbiology. It never went away from my ears since that day, because we're so good in what we're doing. We're so specialized in what we're doing. We basically, dentists, periodontists, periodontal researchers, set the stage for our medical folks elsewhere in the rest of the body. And this was, don't take my word for this, this came actually from one of the giants in our fields. And I'm humbled to have that type of insight by great master like him. And until his day that he passed away, he continued to come to work. And I saw him Thursday, and then on Friday he passed away. So this is what this passion is we're talking about. So the research is not really what you're supposed to be doing on your pastime, on your after hours. This is a lifestyle. And you can do different forms of research. So these are the questions that I pose to myself and to everybody on the screen.
Alf sir, sorry to bother. There is a one window appearing in front of your screen, which is a little obstructing us.
Is it gone right now?
Now it is clear. Yeah.
Sorry. So I use two screens sometimes because of that actually that appears. So that's reason if I don't really look at you, I'm looking at my separate screen. So the questions here that we need to pose, this is the boring stuff, but it's critical, is how can we add more science and research to our practices? Okay, this is critical because, as Ashish alluded very nicely, we train ourselves being very good practitioners, surgeons, periodontists. We place best implants in the world, and we're very good in what we're doing. But we never asked the question about how can we add more science. And compared to times that we were training back in 1980s and 1990s, the science is very accessible right now compared to what we used to. And one paper that we were trying to fetch across the globe was impossible to get by that time. It's really at the tip of your finger, then you actually can reach that article very easily. The most important question is not how, but really, should we add more science? How can you justify this? I mean, why do you need to add more research and science if you can make tons of money on basically placing implants, treating periodontal disease? Why should you do that? So that's an important question that I don't really want to answer, and I'm going to leave it to this. How much would this cost? It costs money, but it's not that bad as much as you think. It's just a cost of time to sit there and then write the grant to be able to get money. As Ashish said rightfully, there is money for research. There is money nationally, internationally, globally, if you sell your uniqueness, which is exactly what we are supposed to be doing, as I alluded in my first slide. The most important part is scary. Everybody's scared of doing research. And because we're not trained well as dentists in our curricula to be not afraid from research. So that's very important. Another critical question is that where does it start and where does it end? As I was giving an example from Sokransky's career, it never ends. It's a part of your life. It should be part of your life from the way that you should be looking at from the day one. And I'm going to give you some examples in the next slides. The most critical point here is that from our perspective, from dentists, from periodontists, it should be translation. So we should answer a unique question that is only important for us. Because if you're trying to go after your like other colleagues and things like that, you're not going to be able to compete because there's all the other people who are specialized, who are interested in doing what they're doing. But nobody can know and do our work better than we do. That's very important. So there has to be some translational arm, which brings up to the question of basically where does it start and where does it end? It starts the first day you start getting your dentistry training, your periodontics training, because that's the time that you should ask questions about why, how, where, and how can I translate this information there. There are obviously limitations, and these limitations are not supposed to be something that we actually should be shy of or should be blind of. It will cost time. You need to separate time for doing this. It should be dedicated time. Resources are critical, but Ashish said it rightfully so. I worked in some of the best institutions in the world in terms of research, BU, Harvard, Forsyth. I collaborate with a lot of people at Penn, Pittsburgh, Michigan, and lots of places across the United States. In Turkey, there are a lot of centers, actually, really, really good research scientists. No place in the world has everything. So that's very important. But you need to be good at something for people to talk to you. So you cannot just really be just good in like basically reading. You have to present something. It's like a marketplace. If you go to a marketplace in India, in Turkey, in Brazil, in Turkey, in the United States, everybody sells something. Nobody sells everything, but everybody sells something very good. So that's what you're supposed to be doing. What is like basically a school in India is going to be selling to another school, which is one of the questions that came up to Ashish after his lecture, that person in one center should be willing to collaborate with another place. We can do all sorts of things in the planet to try to standardize, to talk to each other. But if I don't know what my counterpart is going to be giving me on my plate, I wouldn't collaborate. So you have to be very good in what you're actually promoting to another place. And that's exactly what's going on here. If somebody at UCLA is very good in that model of using systems that I don't really know about, I will go and collaborate with that person. But in the meantime, I have also something to offer on the table. My institute here is next to the MIT, next to the legendary Broad Institute, where the human genome was basically sequenced back in 1999 together with Oxford. So they're in the walking distance, like, in 10 minutes from here. But for me to get out from here and talk to them or call them, I have to have something. So one of the colleagues that Ashish and I trained with when we were doing our postdocs at Harvard, for instance, Claire Klesch, is the head of the sequencing operation at Broad Institute right now. I did my postdoc with Clary. Ashish met Clary when he was doing a postdoc at Harvard together with me and Clary. Clary is a very good friend. I meet with him on a daily basis to have drinks, coffee, and so on and so forth. But for me to talk to Clary for a research position, for a research place, I have to ask a smart question. And in return, I have to offer something. This is a difference between being a good friend, being a good colleague versus a good collaborator. So that's very important. So that resources should be very important to share with. Finances, as we alluded, is not something that you should be dismissing. Of course, it costs money, but there is money if you sit down and write the grants. There are variations at the global, national, regional, and institutional variation levels. Obviously, we actually have to be very cognizant, very respectful about what each country, each region, each institution would be prioritizing that. The problems in India may be different compared to problems in the United States or from Malaysia, from Singapore. We have to be very focused on what you're, again, prioritizing in what you're doing. And of course, the dental education should be the priority because we're not trying to create researchers. We're trying to create, at the end of the day, periodontists, dentists, who are very cognizant, very much interested in doing research and they're really good at what they're doing in terms of research. But that has to be part of the curriculum. And it's not only us. This was published by the Royal Society in the United States, in the United Kingdom a few years ago. it really talks about knowledge networks and nations from a very bird's eye view about how we can actually globally and scientifically collaborate in the 21st century. So that's an important article that I would, or like basically a book that I will refer you to find out. So this was a work that was published by Stashenko and his co-workers in Journal of Dental Research a few years ago. That was about like 15 years of research. So he created this funnel, and it's really interesting because, as you can see, it's an upside down funnel. So we like to see it from bottom up. In this perspective, Phil Stashenko, who was our past president at the Forsyth Institute, and he is a great scientist, a great researcher, put basic science studies at the very top, okay? The reason for that is just like another funnel, it really needs to pour more water, more liquid than the funnel can handle. And there is a reason for it. Basic science studies will be basically feeding the animal studies that we have to translate, start doing those type of work. It will funnel even narrower to human studies. There has to be some clinical evidence that we should be looking at this. And there's actually a Venn diagram in the center. There's going to be a clinical problem, clinician, and patient preference. Without this interaction, interface between the clinician, clinical problem, and patient preference, there's no way we actually can do research. And then there's actually outcomes that will go back to ask the same questions. This is presented as a funnel, but obviously it doesn't end at the outcomes. Outcomes create questions to go back to basic science studies and so on and so forth. On the left side of this slide, I showed a couple of bullet points. A few years ago, I attended a lecture by Carlo Tinti, one of the best, like the bone surgeons in the planet that I've actually met, from Italy. Tinti presented a very interesting square in Italy, where he's from. He's a tiny town, tiny village up in the mountains in Italy. The square is full of chicken. He was looking at these chicken, and he was just saying, I mean, nobody would make sense out of what he was trying to say between chicken and bone. He looked at this and he said, chicken is chicken. All chicken are alike, very similar. I mean, obviously they have different characters, but you cannot tell that from just an outlook. And same way, bone is bone. Chicken is chicken, bone is bone, research is research. So there's no such thing as bad research. There's a difference between publishable research versus non-publishable research. So there's, of course, good research versus bad research in terms of publications and so on and so forth. But at the end of the day, research is out of curiosity. And that's very important in my fourth bullet point over here. If you don't have a curiosity about any of these things that I listed over here, basic science, animal studies, human studies, clinical research, clinical problem, and clinical observations and outcomes, you're not a researcher. But there is a room for every single person in our profession to be a researcher. So my research interest can be over here. Your research is coming over here. But at the end of the day, we are part of the large puzzle. We're part of the large equation that we complement each other. So there's no such thing as bad question. There's no such thing as wrong question. But if you stop questions, then you will never learn. So you should start with the simplest. In your mind, it may be a very shy question, but you should actually do that. There's a question, however, next to one fits all. That doesn't reside very well in this type of a thing. One size does not fit all. So every type of a research here will have its own methodology. Every type of a dish in Indian cuisine has an expertise to cook it right. And that will be done in a very different fashion in the southern India, where they add a lot of spices, versus in northern India, where there's not that much spices. I mean, in my taste, it's still very spicy. But if I go down to southern part, then it's a very different cuisine. But it doesn't fit very well because it's a different taste. However, there's a different methodology for doing this. One of the critical things is that you need to be open to change. Research, one of the things that my mentor and Ashish's mentor, Dr. Van Dyke, told me the first day I joined his lab, is that he said, okay, our meetings, Ashish will remember very well, and still is, we're very short. I mean, Tom is one of these most practical persons in the planet. If you're done, you get out of his office. If you want to spend time with Tom, it's really after hours. But during the daytime, it's very much by the book, 15 minutes. So my first experiment I was doing in Tom's lab, which before actually Ashish joined our lab there. And I went to his office and he said, okay, what did you find? I said, okay, I believe. And he stopped me immediately. He said, there's no belief in research. Your beliefs can go back to your church, mosque, your basically temple, whatever you do. There's no room for a research and belief there. Research doesn't have any beliefs. You can never use I believe. Until this day, I never use the word I believe in any of my stuff, in my presentations, because who cares what I believe? You don't care. What I publish is more important for that. So therefore, you have to be open for change. There's no dogma in this work. Just because I say so, that doesn't make something real or correct or true or a law. We're humans at the end of the day. So it is hard. It is hard to change your dogma. We all have gray hairs. We don't want to change. But if you don't want to change, you're done because you cannot adapt. So it is inevitable to do that. I touched the curiosity. Without curiosity, you're dead. You're not going to be able to do any of this stuff. You have to start with questions. Fun is essential. I'm still having a lot of fun on lecturing, talking, doing a lot of work in my lab across the globe in collaborations. That's very important. And I'm going to come back to this investment issue, but it's important because it's very rewarding. There's a lot of returns on this one. It's hard, but it is a lot of returns and rewarding. You have to define your outcomes. You have to be very clear about what your outcomes look like. And so after the question, you have to define what you're going to expect. These are the anticipated results. These are the results, data that you're going to be doing this, but you need to know how to interpret that. Last 2 points as the most important points of the slide. First, we need to educate the educators, train the educators from the beginning. That's why it is very important to infect everybody at the first level of their careers with this research virus. And it will mutate with you, just like COVID-19. It will learn how to survive with you, but you need to nourish this research virus throughout your careers. And you should start early. So I'm going to come back to the slides several times. So I picked up one critical thing out of everything that was on this funnel. It's the evidence. Without evidence, again, who cares what you believe? Who cares what you've been publishing in your entire career that you're basically dogmatically attached to, married to? It doesn't matter. The evidence can come with lots of ways. So we are only part of this entire team. It can start from college, high school students. I trained a lot of high school students in my lab, in my career. It can be dental students. It should be dental students. It should be part of their curriculum there. It can be you, postgraduate students. It will continue after you graduate. That's the reason why Ashish and I have been together for the last 20 plus years. We have met in our careers where we were very fresh, very raw, and we were not ripe enough. We thought we knew everything. As soon as we saw each other, we realized that we didn't know anything. So that's very important to meet each other, talk to each other at the postgraduate students. My students across the globe, they collaborate, just like me, what I'm doing. Because I will retire, I'll pass the stage to everybody who's actually junior compared to me. They need to keep on doing it. Junior faculty is extremely important because if the junior faculty does not get trained, does not get nourished with research, they will become very dogmatic. They will shut down everybody else in the planet because they will have to protect their turf. Senior faculty, therefore, has to be very, very critical of training the junior faculty. Junior faculty and postdoctoral fellows are our future. And dentists are our partners. They're not foes against, they are friends. We need to learn from our dental meetings. So that's the reason why, as Dr. Grover humbly introduced me, I'm humbled by Dr. Grover's presentation to me I'm still a dentist. I'm still a practitioner periodontist. I still see patients. Yesterday, I treated patients just like you guys. I'm the head of the clinic at Foresight Institute. You cannot be away from your base. You need to learn every day because patients are the best educators for us. Every case is going to be different in your careers. So I highlighted the evidence here. For evidence, you need to observe, you need to watch, you need to see, you need to learn. And then you need to gather your data, your evidence from other people. Then you need to build your case and you need to justify that. Let's see how we can actually do that. So the mechanism can be summer internships, long-term internships, research lab rotations. It can be short, it can be long. It can be programs, structured programs. It can be combined programs. It can be CE courses after you graduate from your specialty degrees. It can be postdoctoral trainings. It can be sabbaticals. So lifelong. I'm now qualified to go for some place to learn sabbaticals. I can do a sabbatical in another institute just because of a professor, just because published more than 150 times and so on and so forth, just because wrote so many chapters, doesn't mean that I know everything. I need to continue. And I do it in the settings like IADR meetings. The rewards are decision of the papers, acceptance of the papers, better understanding of scientific basis of anything that you're doing, critical thinking, competition, awards, promotions, collaborations, advertisements. So these are your awards. And one of them is not better than the other ones. This is a lifelong experience to go through this. So that's the setting. So now I'm going to present a case study. Let's see what we've done throughout our careers. So with this, I'm not going to present something that I'll be walking through a lot of the science, but I'm going to show you how this actually is happening in real life. So I'm a periodontist. I'm not an orthodontist. I'm a rat orthodontist. I don't see humans. I see rats. I see a lot of basically other things that are actually associated with this. I treat a lot of cases with my colleagues from orthodontics. I got interested in this business of accelerated orthodontic tooth movement when we were at BU back in 2007. Until this day, after 14 years, we continue publishing in this work and we're still going very well. But I look at this from a much more of a biology and from the mechanism perspective. I learned a lot. When 2007, this was starting, when my colleagues from ortho department and from the different sections were coming to me, they came to me because of one thing. What was actually really important for them was that they wanted to do a trap staining, osteoclast staining on the rat samples. They found me. And these are the stainings that Ashish and I developed in our lab when he was doing his postdoc in our lab. So, and this is really interesting story because we had no idea what we were doing, but we learned how to do it. We talked to the pathologist and we were really good in what we were doing in terms of this work. And when we published this work with Charlie Serhan, that was exactly what we were doing with the rabbit studies. So years later, these guys showed up from the ortho department to find out how we can actually do the trap staining the osteoclast. And that's how the journey really started. We were very good in one thing that we were doing. We had no idea what these guys were talking about, why they should be accelerating tooth movement and so on and so forth in the first place, but they approached us. So that was how the collaboration started. From this point on, for the last 14 years, I've been very much interested in understanding this mechanism. So I'm going to use this as a case study to talk about the journey, about what we've done so far and bring it on to 2020 and 2021 with this journey. So this is a case study. The question was a mechanism of acceleration of the orthodontic tooth movement. So what we knew when that time we actually started was that on average, it takes about almost like 1.5 to 2 years to complete conventional orthodontic tooth movement, especially in the adults. For those who are collaborating with the orthodontist, know that this is very true. By just increasing the force, we cannot just increase the rate of the tooth movement. On the contrary, it actually shuts down the orthodontic tooth movement because it does cause rhinalization, retrosorption, bone loss, and all the pathological things number one, we cannot move it faster. Number two, we create something that is not reversible. Therefore, the basic paradigm or basic premise of the orthodontic tooth movement is that you need to get sufficient bone remodeling for you to be able to move the teeth. This work was published in a textbook back in 2000, which is something that I found very interesting because this is based on 5 different theories. So in perio world, we don't have theories of how the teeth are actually responding, how the periodontal disease is moving. And believe it or not, the youngest theory in the orthodontic field is between 1973 to 1974. So they still don't know what to do with the orthodontic tooth movement, but they have theories about how this works. So the question that we asked, if this being supported by 100 years of research in orthodontics, and they still cannot go beyond the theories with the newest one between 1974 and 1973 range, back in 2000 and 2010 range. What is really interesting about this work? So according to this theory is that this entire movement is split into 3 phases. The first one is initial strain, when you activate the wires. Then it stops. There's a lag phase. Nothing happens in this phase. And then there's a progressive tooth movement. It goes in zigzag motions for this. So we asked the question, number one, is this correct? Number two, if this is correct, can we learn from this? Why everybody is interested in this initial strain and progressive tooth movement, but nobody really cares about this range over here? Can we learn stuff from the phase that nobody is really paying attention? Because clinicians, as we all are really interested about this outcome. We move teeth, but yet by just increasing the rate, by increasing the pretty much like the forces, we cannot move the teeth faster. It just stops it. So something happening before this evidence really is happening there. So that's actually over here. That's exactly what we've done. So this is the clinical evidence. What we wanted was to speed up the tooth movement without causing ankylosis, without causing root resorption, without tooth morbidity. Okay, this is a case that we treated at the very early part of my career. So we wanted to reach from this crowded case to this form faster, predictably, and evidence-based. How can we do this? So this is what we do really good. Surgeries. We know the bone anatomy. We know the bone physiology. We know how the reactions can actually happen. A periodontist is a very good oral surgeon by respecting the soft tissues. We may not be as fast or as good in looking at the complete impacted wisdom teeth and so on and so forth, or especially with the plastic surgeons or facial surgeons and so on and so forth, but we're very good in understanding the bone biology around the teeth. So this is one of the cases. This is a very severe case, as you've seen in the first ones. The corticotomy marks have been created. I'm not going to go into the technique. That's not the point of today. And we do this in maxilla, on the buccal, on the palate. We do exactly the same thing in the lingual and in the buccal sides of the mandible. So it's a pretty big surgery, very invasive surgery. This is what it looks like after 12 weeks. No evidence of anything that is actually irreversible in this case. I don't show the first, second, sixth, and all the in-between times, but there's absolutely nothing going on that you cannot even tell that this case actually went through a surgery, such an invasive surgery if you do it right. The braces are here, the wires are here, everything is activated. And in 12 weeks, we were able to go from here to here. This is like 3 months. Okay? This is what happens in the clinic. You can replace this by implants. You can replace this by periodontal regeneration. You can replace this by any other clinical case. The question is not like basic, okay, this is great. We've done it. We make our money earlier. We serve our patients faster. This is our job. But the question here that we should be asking is how? How does this really happen? we learned from the beginning that this cannot be happening because we just cannot move the teeth faster by activating the wires faster. But how does this really happen? That's where the research really starts. Without the how, without the question of asking why, how, you cannot really incorporate the research, and you cannot become a better dentist or better periodontist or better orthodontist, better multidisciplinary scientist. So the question of how brings up the question of possible mechanisms, which is your hypothesis building. Without asking a question of how, you cannot build your hypothesis, because you cannot come up with the questions of possible mechanisms that actually deal with this. So at the very beginning, we asked the question, okay, there are three possible mechanisms this can actually be happening. One of them is that we speed up the tissue turnover. There's a higher tissue turnover, as I've shown you with that lag phase. We most probably had that tissue turnover earlier and predictable. Another thing that we actually asked the question is that, can this be a very precise anatomic area? Because if you want to move a canine or upright a molar, create a space for implants by just opening up a space between the first molar and then the first premolar to place an implant in the second premolar area, or resolve the crowding while we're actually changing this anatomies. We want this to be very specific in one area. We don't want this to dissipate to the other teeth. We don't want this to be going into the other directions that we don't want to deal with root resorption. So it has to be a very precise anatomic area. That's another how question. And what we also want from the perio perspective, that's our contribution really will come to, is we need to make sure that we regenerate the bone that we're losing by moving the teeth faster or by doing these corticotomy marks. Okay? So this is all coming from the clinical evidence. So far, I haven't talked to you anything about the basic research or animal research or in translational research. But now that the fun starts, because we did the evidence, we are very successful in the clinic case, we did our treatment, let's go into the models. This is the model that we generated at the very beginning. This was in 2007. First, we need an animal model because obviously you cannot do this in cell culture models. So you need to move teeth. But you cannot do histology in humans with this invasively. So that leaves us with the model of developing an animal model. This is a rat jaw, rat maxilla. Obviously, we're not grown-up rats. So we cannot just be imitating what the rats are doing. So there are limitations. One of the major limitations is as you can see from the slide, they don't have premolars or canines in the rats, but that creates an opportunity for us. Because now, without trying to extract teeth, we can move teeth into the space that's empty. So the ultimate goal will be to move the first molar towards this incisor area in this edentulous site of a rat space. So that's an advantage of a rat model. So what we did was we actually created the burr marks around the rat first molar. So the first one was a proof of concept. And the idea is ultimately to move here, but we have no idea about the rat. So what we did was we created these burr marks. As I said, rats are not mini humans, or humans are not grown-up rats. So the first molar, instead of our molars, does not have like 3 roots, but it has 5 roots. So the first, second, third, fourth, 5, regardless of you basically count them. This is the mesial, this is the distal, this is the second molar, this is the edentulous space. Ultimately, we're going to move this tooth here. This is what happens after the 3rd week of putting burr marks. And on the right side of the slide, you see that there's absolutely a huge, massive bone loss by just creating burr marks here. We didn't get it in between the roots. We just created a burr mark on the buccal and the palatal aspects of the roots. So at 3 weeks, you cannot trace much bone in the interradicular space here. Very little bone is left. At this point, we also didn't know one more thing about the rats, about the timing. We know about how things heal in humans, but we don't know anything about the rats. So that's what we did. This was the first proof of concept study. So before we even publish this work in a high quality journal, we need to do some homework to do. We need to develop the model. So this is what it looks like. Third week, the light green is where the surgical sites of the interradicular space. It's all non-bone. Bone is, sorry, this is the bone part, this is the non-bone site. The non-bone site, which we will conveniently call it as PDL area, will expand, whereas the bone will be going down, as I've shown in the previous slides. Compared to the other side of the rat, same animal, where we don't do burn marks, where the bone to non-bone ratio is the other way around. So 75% of the space is covered with bone, as opposed to 25 to 30% of the space is covered with the PDL or connective tissue space. It's the other way around in the surgical site. By 7 weeks, everything goes back to normal. 11 weeks, you cannot tell the site that received surgery versus the site that did not receive the surgery. So we're good. Number one, we answered that this is a reversible process. Number two, rat model will work for us. And third, we identify the time that we have in our hands to move the teeth. Just for your notes, and one thing that we discovered throughout this process, the time that you can move the teeth for the accelerated orthodontic tooth movement in rats is very similar to humans, because it's exactly the same first 2 to 3 weeks that you need to accelerate the tooth movement. So that's another thing that we learned. So we looked at the osteoclast markers. These are the osteoclast or pre-osteoclast cells around the bone. And then by the bone that's actually covered with the PDL, there's nothing going on. Another thing that we asked at the very beginning, as you may recall, is that this is the red line where the surgical site of the control area that we did the burr marks versus the blue that did not receive surgery. So osteoclast counts went up fourfold almost here. And then they went down, they dissipated completely by 7 and 11 weeks, completely flattened. And here, this is the question to the second hypothesis that we asked here. Remember, we wanted this to be very localized, very regional. And it is. The brown and the green are from the third molar site, where we did not put the burr marks. So nothing dissipates beyond the area that we wanted to do. So we answered the second question. And the third question that we answered in this paper was, or we posed this question, can we regenerate the bone? So this is all osteoclast numbers. So we injected the animals with the calcium red, calcium green, tetracycline orange, alizarin red at different time points. This is just like a tree trunk. And the control site, surgical site, by 4th week, there's much more bone formation, similar to much more bone resorption in the 4th week, as opposed to 7th week. So the amount of the bone that we lost was also built by the osteoblastic activity. So the third question that we posed at the very beginning was the hypothesis saying that, okay, we need to regenerate what we lost. And we did. So the entire bone formation actually happened. So the rest of the paper, you can actually see it in this work. So I spend more time on this one. I'm going to spend much less time for the rest of it, but just to give you a concept. So the first paper, take-home message out of this entire work, is the most important paper that you publish. So you need to put 90% of your time designing the first paper, because everything else will be building on that. It may not be published in a huge journal, doesn't matter, but it has to be scientifically peer-reviewed and give you confidence, not to yourself, but also among your peers, that this is a good stuff. And what you're posing here should convince you before anybody else gets convinced. So you need to be very critical about your own work at every stage. Every stain here, every cell type that you're actually mentioning here should be going through utmost scrutiny. You cannot believe in what you see. You need to believe in what you count, what you measure. This model that we did over here is unique because until that day, nobody really measured this. When we saw these images, with Dr. Ferguson, who was the head of orthodontics by that time. Okay, he said, Alp, how are you going to measure this stuff? So we talked about a lot of things. And what we did was, one thing that you observe here is the thickness of these lines, nothing else. My father was a professor of forestry. So in my very young ages, I counted the age of the trunks of a tree. Okay? So the way that you will understand the age of a trunk of a tree will be counting the circles. And the years that the trees will go through droughts, you will have very thin growth. So the lines will go very thin. The years that you will have a lot of precipitation, a lot of rain, a lot of snow, the tree trunks, the circles get wider. That's exactly what happened here. So this is what the tooth looks like. And this is where the bone looks like. You basically measure the green, first stain, thickness, then the orange, the second injection after 1 week, and third, the red. So by the time rats ingest this in their drinks, you will be building this thickness. So when the rats are growing more bone, they will have larger growth, just like a tree, because there's more precipitation there. It's exactly the same thing. So we came up with this model, and we developed this model of measurements. We measure the thickness throughout the entire trunk of a root. We did this with every single root that you've seen. So it's a tedious process. It requires a lot of time in front of your computers, your screens and things like that, but it's very simple. We developed this, we measured this, and it showed exactly what we wanted to describe. The picture here is great, but you need to quantify that. You cannot just convince me out of one picture, because I will be asking you, okay, what happened in the next one? This one is real. This one is something that I can actually trust, because it shows variation, standard deviation, standard error, and bars that are actually represented in these pictures. So that's where the science really comes to. So this is the second study. Now we got the model, we wanted to move the teeth. So I'm going to spend basically one slide on this one. The rest of them is published. All work is going on. So this is the control site. This is basically the tooth, the first molar that we want to move. Remember, we developed the model around this first tooth, but we did not move in the first study. Now it's time to move this. Now we killed about like 114 rats to be able to do this with lots of groups and so on and so forth with different time points. We learned the timing. I'm not going to get into detail. And here, again, we wanted to develop a model. So this is rat cephalometry, in a way, if you will call it. I told you that I'm a rat orthodontist. So we treated these animals and we developed our models. So this cephalometry is taking an NFAS, like basically occlusal x-rays that we think would be useful. Of course, it wasn't designed for rats, it was designed for humans, but we just took the liberty of putting our rat jaws there. We took the x-rays. And then we looked at the control site versus the surgery site of the same animal. You can see the distance opening. Nothing is happening between the second and the third molar, which again shows that this is regional. But we developed a rat orthodontic appliance model. We moved the first tooth, first molar, mesially to the edentulous space between the first molar and then the incisors. And it did work. Then we quantified the distance. That's it. Very simple. Anybody can do it. But you just have to ask the question based on our experience, because we were looking at this. And when we looked at the quantification of that distance, we found that the classical orthodontic tooth movement, which is in blue, shows exactly what hypothesis, what these laws, what these theories have shown. There is an initial strain, which is happening around like the second week. There's a lag phase that's actually happening, and then there's a progressive tooth movement. Obviously, as I repeated myself several times, rats are not like humans, so orthodontic tooth movement is very much limited to the appliances that we can actually create. There's a limit that you can actually move the teeth, but we got what we needed. In this combination group with the corticotomy, we bypassed the first phase, okay, because we were moving the teeth in an area which didn't have that much of a resistance coming out from the tooth, from the bone. So that first jump start actually followed this, move the teeth faster and longer distance as we could measure from here. And then after the 4th week, it started imitating what the conventional orthodontic tooth movement looks like. It's exactly what happens. So that also shows, just like in humans, we have a window of opportunity in the first 3 to 4 weeks. Just like in humans, we cannot move them more. So you learn as you go, but you also publish as you go. Another thing that we did was that we took, this was completely crazy out of this, we looked at the distance and we divided that by the day. So we wanted to look at the rate. Again, nothing genius in this one. I'm not Elon Musk. I'm just a simple periodontist as a dentist. But I'm trained to observe and learn. That's exactly what happens here. The rate was even more impressive. Look at this. When you divide the rate, when you look at this from a rate rather than a distance, you can easily differentiate the combination group doing much better than the conventional tooth movement group. The third study was asking the biology of this. So how does this really happen? So we developed a model. We proved that in the clinical sense that we're reproducing what we see in humans. Now the understanding is that why are we killing all of these animals? Because you could have done the same thing in humans anyway, so far. More or less. You cannot do histology, but you can actually do a lot of radiological methodologies and things like that. The beauty about using an animal model, of course, you can do stuff that you cannot do in humans. And that's where the real power comes from. So what we did was we looked at the life map of an osteoclast. We looked at the life of an osteoblast, and we looked at how the osteoclast and osteoblast collaborated with each other, talked to each other. So the life of an osteoclast can be traced all the way to the progenitors coming from the hematopoietic osteoclast precursors. And then there are several cytokines, several ligands, several basically cytokines that actually evolve in this, and several transcription factors. You can map the entire hematopoietic osteoclast progenitor, becoming osteoclast precursors, mononuclear osteoclast, quiescent osteoclast, and become an osteoclast by looking at these markers. Just like us. You can identify person A from person B, person A's childhood from person A's adulthood and aging by looking at markers. Why cannot we use the same methodology here by learning the basic science behind this? So the question is exactly the same thing, much simpler for the osteoblast. There are mesenchymal osteoblast progenitors committed by the bone morphogenetic proteins to osteoblast precursors, can be mapped by RUNX2 as a precursor of a transcription factor. You can take a look at parathyroid hormone and so on and so forth, converting this osteoblast precursors to active osteoblast by looking at alkaline phosphatase, collagen, osteocalcin, and so on and so forth. Life of an osteoblast. Life of an osteoblast, very similar. And the way these guys are going to talk to each other will be osteoclast and osteoblast talking to each other by looking at Rankel and rank, basically binding to each other. One of them is a receptor, the other one is a ligand. That's it. Without the osteoprotegrin, without the Rankel or rank communication, osteoclasts are not going to call for help from osteoblast, or osteoblast will not stimulate osteoclastic activity. So this is the key. So that's exactly what we've done. We took these bone specimens from these rats and we ground them down. Again, we developed our own method of how to grind down the bone from the rat jaw. Rat jaw, or any bone, for those who have experience in this one, is very poor in RNA. Doesn't have that much RNA. So lots of methods actually used, lots of different technologies, basically combined, pulled lots of RNAs from 10 different rats to be able to do that. So we didn't have that luxury because we killed enough rats for all of these groups anyway, for different time points. We needed every single rat as a group, just like in humans. Every rat counts. So what we did was, we looked into the literature and looked at who else was struggling to get enough RNA from different tissues. We found that the best methodologies, the most accurate methodologies were developed with the lipid biology. adipose tissue is also very poor with RNA. So we modified the RNA extraction method that was designed for fat tissue, for adipose tissue. And we adapted this over here. And that's exactly what we've done. That's exactly what we published back in this paper. So this again shows that RANKL goes up in both tooth movement and connective tissue combination group. And then there's not that much of a difference. However, as soon as RANKL goes, which is the osteoclast precursor, osteoprotegrin goes up, which is the osteoblast precursor. This doesn't happen in conventional tooth movement. As soon as this goes up, which is the bone resorptive factor, bone opposition factor, bone building factor goes down, as expected. So, osteoprotegrin being an osteoblast marker, mature osteoblast marker, going up with an osteoclast marker, which is RANKL, tells us we discovered something. This discovery was we're not speeding up the orthodontic tooth movements, which is here, molecular-wise. We're defining a complete new healing pattern, which means in this experiment where we combine corticotomy plus tooth movement, we also have a corticotomy group, which I'm not showing over here, but that didn't really show that much of a change over here. We're not adding one, which is tooth movement, and another one, which is corticotomy to get two. We're creating 5, which is not 1 + 1 = 2. This part, the green line here, I can talk about this, but we don't have that much time, and that's not the focus today, is a new discovery. Because what we've discovered here is a complete different healing pattern in the jaw bone by combining 2 different methodologies. One of them is our expertise, which is the surgical expertise. The other one is the biomechanics applied to the tooth. And at the end, the combination ratio goes down, which is also another discovery, because this is what you expect to be able to move teeth faster, to resorb more. But this shows that what you're doing here is that slowing the resorptive fashion. Therefore, what we're seeing here is basically a completely new healing that is reversible. And that's the beauty about this work. And this was published. So I'm going to spend a few slides about the future now. And we're going to wrap up with a couple of slides left. So can we get the same impact with something that is not invasive? The question is light. The answer is yes. So what we did was we used an extra oral device to move the teeth faster in humans. Again, our job is to answer human research questions. By putting the light from extraoral device, from photobiomodulation here, we did the rat studies, but I'm not going to spend more time in the rat models here. We were able to speed the tooth movements by 2.3-fold. By putting an intraoral device, we did exactly the same thing. We moved the teeth faster in this humans by resolving crowding by 2.1 to 2.8-fold. Okay? So, where do we stand on this research? This is a gene array map. Every animal here is a rat. We did the gene array. We wanted to find out what else is going on in terms of the gene that actually turned on and turned off in response to these models. So this is the gene array that we're actually publishing right now. So the future brings information technologies, artificial intelligence to dentistry. This, what we're doing right now, is the future. Nobody could have told us that this was going to be where we're going to be about 1 year ago. So now, me not traveling across the world to talk to you guys, of course it has perks, like being presenting down of this work here, but it also has downsides. I cannot see your physical appearance there, but it basically transmits the knowledge faster. So you are equal to me in terms of getting all the information. PubMed revolutionized the entire work that we're doing. Online access journals revolutionize the way that we're doing things. So information technologies are out there. But what we're really not completely fond of yet or understanding yet is that how can we train this monster that we created? There's a lot of knowledge out there. I just did a literature search because my next week lecture to be Boston University's oral biology or immunology lecture that I'm directing is about viral immunology in the oral cavity. I lectured this right after the pandemic started, right last year. Now I'm going to repeat myself again. In 3 months last year, we learned about 1,500 papers were published in COVID-19. I'm not going to ask that question right now, but I'm just going to give the answer very quickly. Right now, we have more than 110,000 publications about COVID-19. Nobody can read this stuff, and nobody can process this data in 1 year. There's no way. So we need computers. And every field is exploding in dentistry, in medicine, in periodontology, that we cannot catch up with this reading. So it is scary. That's the scary part. If you don't know what you're looking for, it's completely chaos out there. So you have to be very good in understanding, basic understanding what you're learning from the get-go. And eventually, learning your focused research question based on a hypothesis, and eventually make a case out of that. So it's very important. And we need systems biology, we need artificial intelligence, we need machine learning. We need to integrate these molecular, clinical, epidemiological data into these monsters that we created so we can actually make sense out of that. So the future is really systems biology and understanding that. And India obviously has a very big expertise on this one. You guys trained some of the smartest people in the information technologies in the world. And that's what we did with Ashish. I mean, the plane landed next to the airport was this Bangalore Institute of Technology. And on the way to going into the city where we're actually talking about science and things like that, it's massive. This is the Indian Silicon Valley. You guys can do a lot on this one. So be on your turf, learn what you can do, and then sell something. That's exactly what the whole point is. I mean, that doesn't mean that you shouldn't be doing other things, of course, curiosity, but you already have tools in your toolbox to dominate and to really be the people to go, be the researchers to go in your field. And at the end, there's a new scientific understanding of human biology is being born in every field. So I'm going to spend 2 more slides to give you what we're doing today. This is a paper that one of my postdocs, and I'm not a big fan of reviews myself, but this is something that I agreed on because this is interesting because this is blending all the oral and maxillofacial diseases under translational aspects and putting the basic of biological mechanisms. This was published in Frontiers in Immunology. Carla was my student by then. Now she became a postdoc of mine, and she's originally from Chile. And Ashish and I are the testimony of this. Our lab is still an international, like a Mecca of having so many people from different places in the world. And this is an interesting work because what we did here is that we use periodontal disease, we use periapical diseases, we use all sorts of diseases that may have osteoimmunological bone loss where the immunology can play a role. And this is one of the cartoons there. I will leave it to you with the publication because I know that you're recording this. The one thing that I wanted to highlight here, and this was published in 2019, these applications can be the development of immune-based therapies that can promote bone healing and regeneration. The identification of host-derived inflammatory collagenetic biomarkers are diagnostic tools. You can read the rest of the abstract here. You can take a look at this more. If you don't have access to this, I'll be happy to send the paper to Ashish and to Dr. Grover so they can share with you. So that's one thing that we're actually doing. We're trying to find commonalities as opposed to being silos in research. We need to talk to each other. As I've shown you in the case study of orthodontic acceleration, we need to put our expertise, but we need to also learn from orthodontic colleagues. Same model applies here. And final paper that I'm going to share with you is a paper that we just published with one of my students, who's actually also another great collaborator right now from Brazil. This is a work that Ashish and I started our careers. This is where we stand right now. This was just published in 2020 in Frontiers in Immunology. We have something to sell. It was not gone through the scrutiny by the dentist. It wasn't reviewed by friends. It was not reviewed by collaborators. It's these two papers I showed here. They're actually reviewed by people who are not going to like who we are, but will trust the science that we publish. This was published in a very fast way. In this work, again, I will be happy to send this paper if you don't have access to this. What we showed was that inflammation is one of the major hurdles of periodontal ligament stem cells that we have isolated from the human teeth. I extracted all of these teeth myself. So Emmanuel did all of this work himself in the lab. And then what we did was we created an inflammation potential, and then we treated them with the resolvins and maresins, and then we were able to restore their regenerative properties. So now they can become osteoblasts, they can become fibroblasts, and they can become cementoblasts in vitro, by just changing their inflammatory process. And that's the cartoon that we published. So, in closing, the dental professional in 2030, I'm not going to be looking forward to retire, but who knows? I may be done, but it's you guys. Should be able to move beyond the challenges to expand the integration of biomedical research to dental medicine, patient care, and social services. This is the triad for us. You need to serve, you need to care your patients, and you need to be really thinking as dental medicine specialists and periodontal medicine specialists as doctors, not only as technicians who can just do a really good job in extracting a tooth, who can do a really good job in placing an implant, who can do a good job in moving the teeth. These are all technical skills. There's nothing wrong with that. You can be perfect in those, but there's something beyond that. You need to be a medicine person. This is a slide that I used before, so I'm not going to go through this. Take-home message is this: investment in science and knowledge in yourself has great returns and rewards. And with that, I thank you for your kind hospitality, and I'm honored to present with my brother in India, Ashish, and it's certainly a great pleasure to work with my young colleagues in India and across the world. Thank you so much.
Thank you, Al. Yes, Ashish, sir, please.
Yeah, I mean, what a presentation, I must say. Absolutely, I'm blown. I'm completely blown in terms of. I mean, I know what else is all about. But I think what our students need to really look at is when he was showing the papers and you had those names on those papers. So only one paper was there. The other 5 names were his students. And those students are just like you. So essentially, in their record, in their life, they have been exposed to the kind of work, which they would be proud of later in their life. The only thing is, each one of our students here also can do it. The only thing is, they need to probably scout for help around. We won't have any help within ourselves, but at least you need to figure out with whom you want to work. And Alp, I mean, excellent presentation, Alp. I mean, there is no comment that would justify what you have just presented. But if how it is that how is the post graduation studies built up in US? Essentially, how would a student spend his 2 years or 3 years of specialty residency in US in terms of time devoted to research and in terms of time devoted to clinics?
Thank you, Ashish. I mean, thank you very much for your kind words. And I think my job is to pose everybody with more questions than I should answer. And I promised that, and I hope I delivered that. So stir up a lot of the minds, don't believe what you believe, and then just ask questions, keep on going on with that. So that's the whole point. And I do this, and if I stop asking questions in my career, I would never be enjoying myself with MD. And then one other thing that was actually very important for knowing is that these international collaborations or national collaborations are so valuable. Carla is now writing a grant with one of the postdocs of my lab from University of Bergen and from Norway. And so she can actually go there and then learn a new technique there. So I'm very much willing to send her there, and because that's going to be investment for me. So I'm going to invest her to be investing in our research. So that's very important. As for the education, when I was listening to your presentation, I think there are a lot of issues and there are a lot of hurdles in everywhere in the world. So it's not like what you presented is not unique to India. So you shared me with the curriculum before. So I went through the curriculum. Very similar. I mean, so everybody follows the same curriculum. So that's why a dentist is a dentist. I mean, a bone is bone, research is research, dentistry is dentistry. So it has advantages because we can train dentists wherever we are. So because we have patients. So dental practice has become has always been, since the dawn of the civilizations. I was just looking at an early implant. Somebody in ancient Greece, basically ancient Egypt, can do the same thing. Just taking a lost tooth and implement this and so on and so forth. That's exactly what the whole point is. So that's going to happen. But what makes a difference for us is how to create the future dentist. And everybody's asking the same thing. Harvard, which after I joined there and I took over the directorship of the immunology and microbiology course there, went through an accreditation. During the accreditation, the same question is being asked. Because in the US, as you know very well, accreditation is the most important thing. And if you don't get accredited independently and very fiercely by the American Dental Association, you're not going to be able to accept students. And since students pay so much money, of course, that's your lifeline. So you need to really do a really good job. But what they discovered in this case study or self-study was that they were not really building the dentistry for future. They were building the dentistry for today or for past. So the same question is being asked. So I think there's no easy answer for it. But one thing that the push is to increase the work that what we are basically implementing. So every student, every master student, every doctor student, every dental student, even every pre-doc student, in the US, of course, there's a college and then you go to the dental school and so on and so forth. These schools have to present research. So if my high school students or my college student, pre-dent students, can show that he or she has spent some time, summer. We have a research summer program at Foresight, for instance. We train high school students here. We train college students in my lab. We train dental students in my lab. To not only to beef up their CVs, but also infect them with the research virus, as I was saying at the very beginning, as early as possible. Make them as critical thinkers. The return is this. Last year, I was lecturing and I gave a talk about the resolvins and epoxins. And we talked about our cutting edge research there. And this is Harvard students, dental school students. And I asked a question. I said, okay, according to, what is the healing mechanism of this? So the response was, and this was a lecture that I gave in March. I asked a question in April about an exam. So the student answered, saying that according to what you lectured in the class, this is the right answer. But according to the publication that came from Dr. Serhan's lab I think it was 2020, 2019, because I did it in person, 2019 April, the answer should be this. That's what I want. And I gave the student full marks and actually gave him bonus because that is the student that's going to pave way for us in future. That's our future. Not take my words, even if it was only 1 month ago that I presented that work, it was still up to date. Not take my words, go and look for the answers. Not everybody will do it, but those who will do it will be the leaders of our future in every field. So I think we should just make sure that what we are doing in terms of our lectures, in terms of our research, we just have to make sure that this is not scary to think. This is not scary to ask questions. Please ask questions. Please, without questions, you cannot answer the questions. I think it's a long answer, but I hope I gave you the answer that I.
No, absolutely. I think, this is what we also want our students to kind of inculcate within themselves. Dr. Grover,
Yeah.
if you have.
First of all, Alp, it was an awesome presentation. We really, enjoyed every bit of it. I just want to ask you one thing, that our student community, our postgraduate community, like in US, they have say about 2 years or a little more than 2 years to do their research when they are in the university or colleges. And most of the times they are opting for, clinical research, and they have a small sample size because they have to make do, their research within a limited period of time. Now, because of the small sample size, there's a low, statistical evaluation, and most of the papers, they fall flat, in international arena when they go, because of the small sample size as such in their studies. Sir, what would be your advice? What sort of topics they should, really look for, so that they can complete within a limited period of time and they are more acceptable at the international level?
Yeah, I mean, that's a great question, Dr. Grover, and thank you very much for your kind words. As I said, I'm very, very honored, and it's a humbling experience always to present such a distinct group, and that's perfect. And I congratulate ISP for its wonderful efforts, and truly enjoyed every meeting that I organized and I joined with the ISP. So congratulations. So that's a very important question. When you're doing clinical research, size matters. I mean, that's it. So without sample size, without a good power estimates, unless you're working in a very rare disease, which is not the case in oral cavity most of the times, there's no way the PERC will be published. So I think it's a wasted effort in lots of ways. And I need to be blunt about this, because unfortunately, that is actually the most important thing with this, because most of this work is wasted. I mean, people think that clinical research is easier. And yes, it is easy for us because we've trained as clinicians. But the variation at the human level, and there's a reason why we're doing a lot of animal models, is that because variation is not that much. But that doesn't mean that every animal result is going to be translation to humans. Most of the times, the work that we've done with Ashish, with the rabbit models, whenever we were ready to move to the humans, they said, well, you haven't really published anything that's a relevant model. We were asked by FDA was that we had to go back and repeated some of the rabbit models and did the mini pig models to be able to at least talk to some that was safe and so on and so forth. That was great. So humans have shown a lot of variety. And so in a country like India, I mean, there's a lot of different nationalities, not nationalities, but there are different ethnic groups, different cultures. Obviously, you need to be very cognizant about the sample size. So that has to be representing. Even in the United States, compared to Turkey, for instance, the population is very diverse. Every time we do a clinical study, we have to represent African Americans, Asians, minorities, Hispanics, American Indians, and so on and so forth, different regions. So that's important. So what I would recommend before jumping into a clinical study is to do a power analysis and know your power and know how much you need to recruit, how many patients. And the second thing is that make sure that your inclusion and exclusion criteria are very, very good and very well designed. Not saying strict, because strict means that it's maybe actually also self-limiting. But you have to be very clear about the inclusion, exclusion criteria or demographics. In a way, the table 1, which is your demographic tables, should be done before you even do the study at the tentative phase. Of course, you were going to be having retention issues and things like that. Once you do that, once you do a statistics at the very beginning or design of this, it doesn't really matter what your research question is, but you have to be very good in terms of the power, sample size, inclusion, exclusion criteria. Once you do that, you're basically 50% done, because the rest of them is really the methodology that you need to ask about your research questions. That's for the clinical research. And without this, I don't think there's going to be any chance of any paper getting published in a clinical journal. From the translation perspective, from the animal studies, just repeat. I mean, basically, that's a wonderful way to follow the things, because you just have to reproduce what people have done in different parts of the world. And what I'm doing is not rocket science, as I was sharing with you. I'm not saying that it is easy, because you need to put a lot of things together, but I'm also saying that this is not a genius thing. At the end, I'm just a human being with average IQ. That's it. Are there any last minute discussions that
we're asking? We all for your time. Let us look to see you
both in person.
We have 15 minutes more, I think. 11 o'clock.
Yes, sir. Yes, sir. Yeah, we are live on YouTube.
Okay. When is your presentation?
Next Monday.
Monday, why? Okay.
4. In another 5 minutes, I'll start permitting others, sir. 10 minutes.
Yeah.
But this program is hit us, sir. Yeah. Almost like around 500 people are attending on Zoom, and around 200 people are attending on YouTube.
Okay.
And people from outside India are also there.
Okay, right. Okay. So
from Nepal and other countries.
Okay. Probably this we can continue even after this lockdown, monthly one.
Yes, sir. Yes, at least monthly one.
So many webinars nowadays. Audio is clear?
Audio is clear, sir. Fine. Now I will mute myself and I'll switch off my video.
Yeah.
And I'll permit others now.
Okay.
We're ready to go. 11 o'clock will start, sir. Sharp 11 o'clock.
Okay, you just tell me, I'll start.
Yes, sir. Yes, sir. A very good morning to all dear friends present here. As we start one more week in lockdown, we are here with a very new lecture series, the fourth part of this lecture series. The speaker for today is Dr. Anil Melat sir. Sir is a past president of Indian Society of Periodontology and currently working as a principal professor and head department of periodontics and implantology at Mahe Institute of Dental Sciences and Hospital. Over to you, sir, to start the session for today.
Thank you, Dr. Neeraj. Am I audible?
Yes, sir.
Yeah, good morning to everyone. Let me first take this opportunity to congratulate Dr. Nimfia Pandit, President of Indian Society of Periodontology, and Honorable Secretary Dr. H.S. Grover, sir, for taking the initiative of starting this webinar series, especially during this lockdown, for the benefit of exam-going postgraduate students. As well, acknowledge and congratulate Dr. Neeraj, who is the Treasurer of Indian Society of Periodontology, for coordinating this webinar series in an exemplary manner. Hope you're all staying safe at home and we're all going through a tough time. I'm sure that we all can face a better tomorrow. So the topic given to me is to discuss on implant complications, peri-implantitis, and its management. Now we all know that we are all fighting this dreadful disease, COVID-19, and our deepest sympathy and prayers and condolences for the COVID victims as well. At the same time, let us all congratulate as well as acknowledge the effort taken by the health professionals, health authorities, government, as well as police authorities for working day in and out and making sure that we're all safe for a better tomorrow. So with this, I start my presentation on implants, complications, failures, peri-implantitis, and its management. Hope I'm audible, Neeraj. Can I go ahead?
Yes, sir, you're audible. Please go ahead.
Okay. Now, we all know that dental implants is the key option in replacing any edentulous area. Where we talk about the fixed option, the first option, what we give the patients are dental implants. Now, the availability of the dental implants definitely has created a revolution in dentistry. And now we can see that various dental implant systems are available with different designs, different thread designs, different length, different surface topography, all to enhance osseointegration. Along with that, the availability of zygoma implants as well as cortical implants. Now, the dental implant practice is a practice what every dentist nowadays they incorporate in our practice. So it is equally important to know that when you place it into dental implant, what are the complications, what are the failures, also what you encounter in a dental implant practice. I always believe that placing a dental implant is easy, but maintaining a dental implant as well as understanding the failures and complications of dental implants is equally important, which will lead to the success of your dental implant practice. That is why I have heard a couple of senior dental implantologists saying that if I can manage a failure, I am a successful dental implantologist. So it is very important to us that you know the failures to understand how you go about the treatment of dental implant failures. Coming to what is a dental implant, according to Glossary of Periodontics 2001, it's an alloplastic material or device that is surgically placed into the oral tissue beneath the mucosal or periosteal layer or within the bone for functional, therapeutic, or aesthetic purpose. So basically, you are replacing a natural tooth and getting the function, aesthetic, and therapeutic part by placing a dental implant. So that is what we have to achieve as a surgeon, or from the patient point of view also. They should be happy functionally, as well as the aesthetic concern is also one key factor in placing an implant which is successful for the dental surgeon as well as in the patient point of view. And what we are achieving by placing a dental implant, we all know that we are eager in going to achieve osseointegration. Now, the father of implant dentistry, Branema, he has defined osseointegration as a direct connection between living bone and a load-carrying endo-osseous implant at light microscopic level. Now, when you see a direct connection, any interference with this direct connection between the bone and the implant, there is a chance of failure of the dental implant. So we are placing a dental implant. We are making modifications in the dental implants to achieve or enhance osseointegration. So anything, there is any problem, any also wherever there is a wherever there is a deficiency in the osseointegration, or where there is a deficiency in the connection between the living bone and load carrying implant for various reasons. It can be an infectious failure. It can be because of the trauma to the prosthesis. So all these factors causes definitely a failure, which can lead to failure in the osseointegration, leading to the failure of an implant, which we'll be talking to you later when you talk about the implant failures. Now, when you compare the tissue, what is the basic difference between the periodontal tissue and the peri-implant tissues? When you talk about the natural tooth, you have periodontal ligament and cementum, while in case you have, in case of an implant, you have a direct contact between the bone and the implant. That is why we say that the connection of in natural tooth is a resilient connection, and in case of a peri-implant tissues, it's a rigid connection. So when you compare these both, that is why we say that many articles in the literature quote that you cannot connect an implant to a tooth when you give a prosthesis, when you give a fixed prosthesis, because there are articles saying that because you don't have this adaptive capacity of cushioning effect what you have in the natural tooth in an implant. But there are majority of the articles are stating that it's always better that for the prognosis of an implant, it is always better to connect an implant to an implant. So this is the basic difference when you see the tissue quality between the periodontal tissues and the peri-implant tissues, and the remaining all the differences as mentioned here we have highlighted. So these are the basic difference. So that is the reason why always we say that it's always better for the prognosis and to avoid failures, connect implant processes, do an FPD only, connect an implant to implant, and try to avoid connecting implant to a tooth. But there are articles showing that showing and justifying that the connectivity between the implant and the tooth is also possible and showing prognosis. Now, what we are achieving as an implant success. Now, when I place an implant, I am looking forward to place an implant without any complication. And I want to achieve an implant that remains stable and functioning without any problem. As well, the peri-implant hard and soft tissues are healthy. And finally, very important, patient and the treating clinician are pleased with the results. This is the success mantra, what I would achieve as an implant practitioner. And this is what we are looking forward for a successful implant practice. Now, coming to complications, what we can encounter in dental implants. Now, like any other surgical procedures, now the first thing what we can face is accidents during the surgical procedures. And second thing is complications during the procedures. During the procedures, you can encounter accidents. For example, in implantology, if the drill can puncture the nerve, artery, all this possibility because of your lack of skill, all this can happen because of in your implant practice as well. Many times what we see that the accidents and complications are very, very important to identify and treat at the earliest. So complications, in this case, we divide complications into early and late complications. Now, under early complications, we are expecting infection, edema, ecchymosis, hematoma, emphysema, bleeding, all these factors which normally we have in majority of the surgical therapy. And later stage complications in implants, we can have mandibular fractures, maxillary sinusitis because of your drill or the implant placed in the sinus region, failed osseointegration, bony defects, and peri-implantitis and periapical implant lesion, also perforation of the mucoperiosteum. So this classification was given by Misch and Wang and in the Journal of Implant Dentistry in 2008. And they are broadly classified into two categories, that is early stage complications and late stage complications. Now coming to the complications, classification of complications by Carenza, they have classified into four headings. One is surgical complications, one is technical complications, one is biologic complications, and the fourth one is aesthetic and phonetic complications. Now, surgical complications, as we discussed earlier, complications related to surgery, and technical complications are any prosthetic complications such as screw loosening and fracture or implant fracture or fracture of a respiratory material can be put under the technical complications. And biologic complications are due to the pathogenic microorganism setting in, causing peri-implantitis or later dehiscence, recession, inflammation, and later causing the implant loss or failure can be put under the biologic complications. And finally is the aesthetic and phonetic complications on the patient side, not satisfactory after the placement of the implant. So these are the two classifications of implant complications. The first one is early stage complication and the late stage complication by Misch and Wang, and followed by the second classification by Carenza, that is classification of implant complications, which have been described in four headings as surgical complications, biologic complications, technical complications, aesthetics, and phonetic complications, which is generally self-explanatory. Now whatever we say when the implant fails, the surgeon can say that it was successfully integrated but failed because of excess loads. But the restorative dentist also can say that implants were poorly integrated and so failed under normal masticatory loads. But finally, the patient's tale is the implants have failed. So it is important to understand what are the complications and what are the failures you can encounter, because finally convincing a patient after the implant failure is not as easy as placing an implant for the first time. So it's always better that you understand the complications, you understand the implant failures, and take necessary action prior so that it will help you for long-term prognosis of your dental implant treatment. Now coming to the positive factors what we consider for the implant success. First, definitely I would like to have a bone type that is density D1 or D2, more of cortical bone, less of cancellous, because for a better osseointegration, and patient healthy, preferably less than 60 years old. Mandibular placement, because mandibular placement, one is the ease of placement. Second, as per literature, the mandibular prognosis in implant placement is much more than the maxillary. Implant length, and I have 2 implants or 3 implants placed and going for FPD processes for a better anchorage. Axial loading of an implant, regular post-operative recalls, and good oral hygiene maintained. These are positive factors what we look into when you do an implant practice. Now, other than this, negative factors, we all know that when it's a D3 or D4, the prognosis is poor, low bone volume, any systemic factors, smoking, maxillary, particularly the posterior region, short implants, and inappropriate early clinical loading, and definitely bruxism and other parafunctional habits. These are negative factors, and that are positive factors which definitely help in prognosis. And the warning signs, more importantly, what we have to look into is, one is pain, second is gingival bleeding. So the patient normally, when in case of peri-implantitis, the patient comes with a dull radiating type of pain. And in case of gingival bleeding and enlargement, and second is purulent exudates from the pockets. Angular bone loss can be seen in peri-implantitis, and also fracture of prosthetic components, long-standing infection in soft tissue, connecting screw loosening, and connecting screw fracture. So when a patient comes to you with these warning signs, many times it's important, and we all know that we take the necessary X-ray or CBC to analyze whether it's just a screw loosening or whether the patient is having peri-implantitis. Because once you diagnose that, it's easy for us to understand the prognosis part and how to go about the treatment. So these are the warning signs of some of the implant failure and the other positive and negative factors. So we have already gone through the complications classification, then positive factors, negative factors, followed by warning signs of implant failure. Now going to the classification of few implant failures. Rosenberg et al. Classified as the implant failures into 2 categories. One is an infectious failure, second is a traumatic failure. Infectious failure caused by microorganisms, similar to a periodontal lesion, And traumatic failure is basically the lack of clinical sign of infection and demonstrate few or no more periodontopathologic pathogens. And it is basically they are contributing only to anything related to traumatic occlusion, which is causing, or any fracture component of the prosthetic part is causing the failure, is under traumatic failure, and other one is the infectious failure. So broadly they have broadly they have defined this classification into two: infectious failure and traumatic failure. And the second classification by Esposito et al., they have classified broadly into four headings. One is biologic failures, mechanical failures, iatrogenic failures, and inadequate patient adaptation. So when you talk about biologic failures, they have considered the loadings. If the failure is before loading, before the second stage, it's early or primary, and after loading, it is late or secondary. And mechanical failures are basically due to fracture of implants, connecting screws or bridge framework, etc. Anything related to the prosthetic is mechanical failure. And iatrogenic failure is basically to the surgeon, where improper implant angulation, alignment, or nerve damage is calling iatrogenic failures. And finally, it's an inadequate patient adaptation, which is phonetics, aesthetics, or psychological problems. So can be put under the failure of inadequate patient adaptation. So this classification gives you a picture of biologic component, iatrogenic component, mechanical component, and inadequate patient adaptation component. Well, in the earlier one, we had only two failures, that is infectious failure and the traumatic failure. And the third classification, what we go into, is the classification of Escari et al. On implant failures. And in this, they are classified under seven subheadings. First is according to the condition of failure, that is before stage 2, and second after stage 2 and after restoration. And second is according to etiology, whether the failure is due to restorative factor, host factor, surgical factor, or implant selection factor. And according to the timing of failure, whether it's ailing, failing, failed, or surviving implant. Now, ailing, failing, or failed, I'll be talking in detail when I talk about the peri-implantitis. According to failure mode, it is psychological problems from the patient side, lack of osseointegration, unacceptable aesthetics, and functional problems. And according to origin of infection, it's whether due to peri-implantitis or it's whether due to retrograde peri-implantitis. And according to supporting tissue, soft tissue loss or bone loss combination. And according to responsible person, it can be dentist, dental hygienist, or because of the laboratory technician or patient. So they have broadly divided into seven subheadings. That is conditions of failure, etiology, according to timing of failure, according to failure mode, according to origin of infection, according to supporting tissue type, and according to the responsible person. So these are the three types of implant failure classification which I have highlighted today. So we have finished off with the implant classification of implant complications, followed by classification of implant failures. And from here, we move on to our topic as peri-implantitis and its management. Now, here, when you go to the peri-implantitis, we have ailing implant, which we discussed in the classification earlier, ailing implant, failing implant, and failed implant. Now, what is an ailing implant? We always say that failing is not always a failure, because here we understand that what is the involvement of the supporting tissues or the peri-implant tissues to understand the treatment aspect. So this is very important to understand what is ailing, failing, and failed implant. When the problems is limited only to the soft tissues surrounding the implants and not involving the supporting bone. So I repeat, it is limited only to the soft tissue, not involving the supporting bone. It is called as an ailing implant. And failing implant is that shows progressive loss of supporting bone. There is a peri-implant pocket that is clinically, but the implant is clinically immobile. And failed implant is one that is clinically immobile. So this gives you a picture when you get a case, how to go to the treatment line or how to diagnose it, whether it is ailing, failing, and failed. And normally, because it's very important, the prognosis for the ailing and failing is good, while in case of a failed implant, normally we go ahead with the retreatment by removing the implant and going for a replacement of the implant possible. So this is the three types of implant failures. One is ailing, failing, and failed. Now, Recently, this is termed as a biological complications, and many times on the exam point of view, when they ask the biological complications of implants, you will have to highlight on ailing, failing, and failed implants as such. Now, according to the first European workshop of periodontology, now peri-implant disease is defined as a destructive inflammatory process affecting the soft and hard tissue around osseointegrated implants, leading to the formation of peri-implant pocket and loss of supporting bone. So this definition, we discussed earlier that about the ailing, failing involving the soft tissue and hard tissues around the osseointegrated implants. So this is a definition given by the first European workshop of periodontology. Now, peri-implant diseases are broadly divided into two categories, that is peri-implant mucositis and second is peri-implantitis. So if the inflammatory changes, which are confined only to the soft tissue surrounding an implant, we call it as a peri-implant mucositis. And in case of peri-implantitis, progressive peri-implant bone loss with the soft tissue inflammatory lesion. So this is self-explanatory, saying that when the inflammation is confined only to the soft tissue without tissue surrounding an implant, we call it as a peri-implant mucositis. While whether the peri-implant bone loss with the soft tissue inflammatory lesion, we put it under the category of peri-implantitis. Now, authors, initially, many of the literature, what you can see that there is a prevalence of peri-implant mucositis and there is a prevalence of peri-implantitis. There are a lot of literature showing that once you load an implant initially, many times there are chances of crestal bone loss up to 1 mm initially in the 1 year. And now here, this article, a lot of articles showing the prevalence of peri-implant mucositis here and the prevalence of peri-implantitis. So it's important that showing this particular data that we have to make sure that in the first phase or the first phase after the restoration is the process is placed, you have to have a regular recall protocol to understand that to prevent this peri-implant mucositis getting converted into peri-implantitis. So this literature gives you a correct idea because of the prevalence of peri-implant mucositis and prevalence of peri-implantitis. So it's equally important the role of maintenance therapy in this peri-implant diseases so that the prognosis of the implant will be good for a longer time. Now this is a diagrammatic representation of this healthy peri-implant mucosa, peri-implant mucositis and peri-implantitis. You can clearly see that the involvement of the soft tissue in the peri-implant mucositis, there is a peri-implant pocket of bone loss in relation to peri-implantitis. Now, classification of peri-implantitis, it's classified as early, that's a pocket depth, equal to or more greater than 4 mm, and less than 25% of implant length, bone loss less than 25% of implant length, bleeding or suppuration on probing. This is classified as an early peri-implantitis. The second one is moderate, the pocket depth greater than 6 mm, equal to or greater than 6 mm, bleeding and suppuration on probing, bone loss 25 to 50% of the implant length, which is considered as a moderate periodontitis. And third is advanced, where pocket depth is more than 8 mm and bone loss more than 50% of implant length. So this is give you an idea that somewhat similar to what we said. I will put it in the category as when it is advanced lesion, we can put this as a failed implant, and while the other two classification, early and moderate, where there is a bone loss, we put it under the category of failing implant. So this is classified by Fromm and Rosen in 2012, and according to this, there is a first classification early. There's a slight horizontal bone loss with minimal peri-implant defects. You can see the diagram. And second is moderate horizontal bone loss with isolated vertical defects, which is the second diagram, what you can see. And third is moderate to advanced horizontal, and the fourth one, advanced horizontal bone loss with broad circumferential vertical defects as well as loss of buccal and lingual bony wall. So this classifications gives you an idea about failing and failed implants, as well as that gives you an idea how to go about identifying what type of failure, whether it's early, moderate, or advanced type of peri-implant diseases. Now, I go to peri-implant soft tissue bar dehiscence bar deficiencies. This is a classification which has come out Journal of Periodontology in 2019. Actually, this is not a part of peri-implant disease as such, but since for the benefit of the postgraduate students, I thought I'll just mention about the PSTD classification. These peri-implant soft tissue deficiencies are broadly classified into 4. That is PSTD1, PSTD2, PSTD3, and PSTD4, with 3 subclassifications: subclass A, subclass B, and subclass C. Now, initially, this is PSTD1. You can see that the arrow I'm pointing out, so you can see when you compare the implant crown here, the soft tissue margin of the implant crown here with the soft tissue margin of the natural tooth, this is the same line, but you can see that the keratinized tissue or the marginal tissue is thin, the thin biotype of gingiva, which is showing which the abutment or the implant is visible. So in this PSTD1, you have the margins in the same line with the natural tooth. There is no gingival recession in the implant crown, but the abutment or the implant crown is visible. In PSTD2, you can see that there is some amount of gingival recession, and when you draw an imaginary line connecting the soft tissue margin of the homologous natural tooth and the implant abutment crown profile, you see that the crown is placed more on the palatal side in case of a PSTD2. And in case of a PSTD3, now we analyze PSTD3 by removing the crown. You can see there more amount of recession here. And when you remove the neck of the crown, you can see the implant head is more towards the palatal side in case of a PSTD3. So PSTD3 and PSTD4 is assessed by removing the head of the crown, and that is how you assess. And in PSTD3, when you remove the crown, you can see that the head of the implant is more towards the palatal side. While in case of PSTD4, you can see more the recession is gingival soft tissue margin is more apical. And when you see, compare the imaginary line connecting the soft tissue margin as well as the implant crown profile, you can see that this is placed more labally. And when you remove the implant crown and see the head of the implant, this is seen more facially placed. So this is the difference between PSTD1, PSTD2, PSTD3, and PSTD4. I repeat that PSTD3 and PSTD4 is assessed by removing the implant crown. And in PSTD3, the head of the implant is more towards the palatal side. And in case of PSTD4, the head of the implant is more towards the buccal side. So according to this, the treatment aspect can be analyzed. And many times in PSTD4 and PSTD3, you will have to have a prosthetic approach to recorrect the implant prosthesis. While in case of PSTD1 and PSTD2, we can have the correction done by soft tissue augmentation. So this basically connects you to the treatment aspect also. So hope it's clear. This 4 classification, that is peri-implant soft tissue deficiency 1, 2, 3, and 4. Now the subclass classification, what they mentioned is, you can see this is based on the tip of the papilla. Now when you compare the soft tissue margin here with the tip of the papilla, if the tip of both the papilla is equal to or less than 3 mm, it is coronal to the ideal position of the soft tissue margin of the implant supported crown. So this is they compare the tip of the papilla with the soft tissue margin here. The second one, subclass B, is tip of the papilla is equal to or less than 1 mm but greater than 3 mm, coronal to the ideal position of the soft tissue of the implant supported crown. We put it on the category of subclass B. And C is, you can see that height of at least one papilla is greater than 1 mm, coronal to the ideal position of the soft tissue of the implant supported crown. Here, yes. So this is the tip of the papilla. So here, this is classified into subclass A, B, and C are classified into according to comparing the tip of the papilla with the soft tissue margin and ranging the distance from the soft tissue margin to the tip of the papilla. So these are the subclass A, B, C classification. And as per the literature, the C classification is not applicable to the PSTD1 because as there is no recession pertaining to the PSTD1. So this is a classification of peri-implant soft tissue deficiencies of peri-implant soft tissue dehiscence by deficiencies in the Journal of Periodontology, which has come in the year 2019. Now coming to the microbial flora, so we have finished peri-implant classification of peri-implant diseases followed by PSTD classification. Earlier we had dealt with classification of implant complications and classification of implant failures. Now coming to the bacteria microbial etiology of peri-implant disease, many times going through the literatures, we have seen that it's almost the pathogenic microorganisms are similar in the periodontal microbial flora as well as the peri-implant microbial flora. But recently, a couple of articles, what they highlighted is the presence of Epstein-Barr virus and cytomegalovirus, herpes simplex virus 1 has been, and presence of Candida albicans have found in higher proportions in peri-implantitis sample, which has been highlighted by the articles in 2019. But majority of the articles, what we go through, or when you compare it, the pathogenic microorganisms are similar to what you see in periodontal microbial flora and peri-implant microbial flora. Now, factors that contribute to peri-implantitis. Now, the factors that contribute to peri-implantitis, or factors what we have to take care of which are leading to failure, is we have to assess the patients when you do an implant on a patient with thin tissue biotype or inadequate keratinized mucosa, which we have mentioned, you have seen in the PSTD classification. What are the problems what we'll face when you do place an implant, especially in the aesthetic zone with the patients with thin tissue biotype, the prognosis is poor. Then thin buccal plate. Many times we have to, the diagnostic tool, what we do to place an implant is very important. We have to have a CBCT. We have to assess the thickness and width of the bone and the buccal plate. So if you don't assess that properly with a thin buccal plate, there is always a chance of implant failure. Then placement of an implant adjacent to the teeth with existing periodontal infection. This is also one cause where you see that there can be an implant persisting periodontal lesion which is causing the implant failure. Also, immediate implant sites in sites with periodontal disease or existing infection where proper care is not taken to remove the apical lesion or the periodontal lesion before placing an implant, which also causes a failure in the implant. A placement of wrong implant size, especially many times as a postgraduate student, I'll advise you, or even after you finish your post-graduation, many times we don't have enough implant sizes in our hand when we do an implant practice. So it's always important that if you have not taken a proper CBCT or a radiograph to assess the size of the implant to be placed, when we open a flap, we see that the bone is deficient and you don't have the size of implant, then you compromise placing an implant what you have. So that goes into poor positioning or alignment of the implant, what leads to definitely a failure. Prosthetic part will be difficult, and failure also is one thing what you can expect immediately after the placement of implant. So it is always better to have the diagnostic protocol in line with the proper CBCT taken in your implant practice, especially in your early implant practice, to make sure that you don't land up in an implant failure. This is again one diagram of the X-ray on the poor surgical implant placement technique. And distal pontic, you can see here the distal pontic with the implant, which normally we have earlier we spoke about connecting an implant with the tooth. Also, there is a lot of literature which is for and against. But here the distal pontic is not advised in any case of implant because there's an extra load, and definitely that can lead to a failure. So these type of cases normally are cases where we are actually leading to failure, which is unnecessary. So it's always better that see the fixed processes like how we follow the Antis law. Identify implant to implant placement, as well as you make sure that there is no distal pontic attached to the particular implant. And you can see here also that they connected the tooth to the implant with the distal pontic, which is definitely a case of failure which you can encounter. Now coming to diagnosis, so these are some of the factors other than the regular negative factors what we have discussed earlier. We have discussed positive and negative factors earlier. So other than that, some of the factors which I would like to highlight contributing peri-implant lesion. Now diagnosis, indices, you can go for an index similar to your periodontal index, plaque index, as you have seen in the class. I'll be talking about cyst classification where they've taken the plaque index. And peri-implant probing is very important. So you have to assess the peri-implant probing depth and you can use a blunt, straight probe, periodontal probe, plastic periodontal probe, is automated probe or proof pressure sensitive probe, which can be used in case of a diagnosis of a periodontal implant, and also assess the mobility, which will help you in assessing whether it's a failed or a failing implant, and pain from the patient. And in cases where you have gone for a full mouth rehab, where you are not sure that there are a couple of implants which you have failed, you can even go for a biomarkers to understand that, to understand about the progression of the disease, to understand the microbial flora, as also to better know about the future progression of the disease. So you can assess the markers in that. And now these are some of the advanced diagnostic aids, which I thought I'll just mention on. There's a microbiological, biochemical, and genetic test. So these will help you in identifying the active state of the disease, as well as this will help you in understanding the progression of the disease, as well as it will give you a guidance for the estimate, the response of the therapy. That is something pertaining to the antibiotic sensitivity test. So it is always better. Now you can go for a microbiological culture, and there are chairside kits are available. Chairside kits are available to understand the active state of the disease, and there further you can response to therapy can be done specifically to the particular microorganisms by doing an antibiotic sensitivity test. So these are some of the kits which are available, biochemical kits which are available, which are chairside, and microbiological tests what we do to understand the active state of the disease, as well as to understand the response to therapy, as well as to understand the progression of the disease. Now, treatment options of peri-implant diseases, basically broadly it is classified into non-surgical and surgical aspect. Now, this chart gives you an idea about the treatment aspect. Now, we have already covered on ailing, failing, and fail. So remember that what we have spoken on ailing, failing, and fail. And assessment, when you talk what's the assess, how do you assess first? Now, first when you have the patient, you assess the patient. First, without bone loss, no mobility, there is only peri-implant mucositis. We go for a conventional oral prophylaxis, and you can give an antiseptic mouthwash, oral hygiene instruction, and directly this goes to the maintenance phase. But on the right-hand side, you can see that if there is a mobility, if the mobility is there, it is a failed implant, and it's always better remove the implant and do a retreatment of the implant later. So in the second part, the failing implant, that's bone loss is there, you understand, you analyze whether it's a failing or ailing. Ailing, we have already done the treatment plan on the left-hand side, and the failing is you have a bone loss less than 2 mm. You can go for and pocket depth less than 5 mm. So you go for a conventional debridement, local antibiotic therapy, local drug delivery, antiseptic mouthwash, oral hygiene instruction. Again, assess the patient and then go ahead with the maintenance. But if the bone loss is more than 5 mm and you have to go for a surgical technique, you can do the non-surgical debridement followed by conventional flap with regenerative or resective therapy, and then bring about the surface decontamination by either laser or ozone, whatever it is, and then analyze the situation and put it under the maintenance therapy. So this chart give you an idea about ailing, failing, and failed implant, how to manage or what is the treatment protocol to manage in a ailing, failing, and failed implant. Now, Lang et al. Has bring about a treatment protocol called as cumulative, interceptive, and supportive therapy, CIST protocol, which is called as they have analyzed the probing pocket depth, plaque index, and cratering, and they have come to the conclusion of the treatment protocol. Now, cumulative, interceptive, and supportive therapy, that is probing pocket depth less than 3 mm. That indicates that plaque index in A, the plaque index less than 1 and bleeding on probing negative, or plaque index greater than 1 and bleeding on probing positive, it is mechanical debridement, polishing, and scaling. So this is the treatment protocol for probing pocket depth less than 3 mm or equal to 3 mm. Probing pocket depth 4 to 5 mm, you have mechanical debridement, polishing and scaling, plus antiseptic cleansing, that is, and also 0.1% fluoxetine gel twice daily with antiseptic cleansing, and for 3 to 4 weeks. So probing pocket depth 4 to 5 mm will be A plus B, And the third one is probing pocket depth, more than 5 mm, that is bleeding on probing positive, no cratering. You directly go ahead with A plus B, that is mechanical debridement plus polishing and scaling plus antiseptic, local drug delivery, as well as in case of probing pocket depth more than 5 mm, that is bleeding on probing is positive and notable cratering, that is greater than 2 mm, you can do the conventional debridement, polishing, scaling, local antiseptic therapy is done, then followed by third C, that is systemic or local antibiotic therapy. In case of probing pocket depth greater than 5 mm, where notable cratering is less than 2 mm. Now, if the probing pocket depth is more than 5 mm, you have bleeding on probing positive, bone loss is greater than 2 mm, you will have debridement, initially A plus B plus C, then add resective or regenerative surgery along with that. So this is self-explanatory in understanding the treatment protocol of peri-implant disease proposed by Lang et al. So in the BOP positive, in the third one where notable cratering less than 2 mm, they have mentioned the arrow here down. That is in case of molars where the accessibility is less. Once we finish the A plus B plus C, if again the infection persists, you can even think about combining the conventional flap surgery with the regenerative surgery, A plus B plus C plus D in that cases. So it is clear that this is a treatment protocol where basically depending upon the depth of the pocket, as well as depending upon the presence of catering, we have analyzed that divided into 3 protocol. One is conventional non-surgical debridement, plus local drug delivery, plus systemic or local antibiotic therapy, and then plus resective or regenerative surgery. This was proposed by Lang, and this was again modified by Lang. It's called as an acute protocol, and it was called as the pocket depth less than 3 mm, no plaque or bleeding, no therapy, and pocket depth less than 3 mm, greater than 3 mm is plaque and bleeding and probing is there. It's mechanical cleansing and polishing, your conventional non-surgical debridement, and oral hygiene instructions are given. And pocket depth 4 to 5 mm, radiographically no bone loss. It's mechanically cleaning, polishing, oral hygiene instruction plus local anti-infective therapy. And pocket depth greater than 5 mm, it's again conventional debridement with a systemic antibiotic therapy along with that. And if pocket depth more than 5 mm with bone loss greater than 2 mm, we go along with the conventional flap surgery or along with the regenerative surgery or a resective surgery. So it's somewhat similar to what they have done with what the modification was there in the CIST protocol. Only modification what they've added to this, they added radiography along with this acute protocol by Lang. So these are the 3 classification according to the treatment aspects of peri-implant disease. What I have to add before going to the treatment aspect. So initially we discussed about the classification of implant complications. Then followed by we discussed about the classification of implant failures. Then followed by classification of peri-implant diseases. And now coming to the classification, we have discussed 3 classifications on peri-implant treatment plan, peri-implant disease treatment plan. Now we go to the treatment of ailing. Now, in case of ailing implant, we have seen in all this treatment protocol, it is basically the treatment to mechanical debridement. The conventional, you do the oral prophylaxis, and you can administer local drug delivery, or also in certain cases we can even think about giving antibiotics systemically. Now, the non-surgical debridement in this cases where what we can think about is which include plastic curettes are used for debridement, carbon fiber curettes, there are titanium curettes which are available, and also we can use rubber points, abrasive paste, abrasive wear, titanium brush, and also antiseptics such as citric acid, tetracycline, and chlorhexidine has been used, and systemic antibiotics as mentioned here can be given. So this is a non-surgical approach, what we normally do for the ailing implants. And now here, recently the article has come in 2019, where they have mentioned that the formulation of a controlled release material containing metronidazole and doxycycline as a local drug delivery is quite effective along with the conventional debridement as an adjunct along with the conventional debridement in treating peri-implant diseases. Now, other than this, if in case of a traumatic failure, as we mentioned in the earlier classification by Mish and Wang, in case of a traumatic failure, it's always better that you identify whether the failure is because of occlusal factor or because of any pathogenic factor causing the peri-implantitis. So if it's a traumatic failure, what you have to think about the processes, design changes, or improvement in implant number and position, or even think about first assess the occlusal adjustment, check the premature contacts, check the supra contacts, so that the load is not more on the implant surface, which is causing the failure. So occlusal therapy is also, along with the non-surgical, we can consider, which is a factor which has to be considered, which are leading to the implant failures. Now, failing implant, we told that there is a peri-implant bone loss, and when you have peri-implant bone loss, the treatment protocol, as mentioned in the earlier classification, they have mentioned that conventional non-surgical debridement followed by local drug delivery, and you can have a systemic antibiotic given, and followed by conventional flap surgery in deeper pockets, where you can even think about regenerative procedures such as GBR. You can do a guided bone regeneration, and I think on regeneration, detailed discussion was taken on the previous session, I think, by Dr. Rameshwari. So I'm not getting into that. So the failing implant, the treatment option is it's assess the pocket and assess the pocket. If it's a pocket is deeper, you do the conventional non-surgical debridement initially, followed by local and systemic factors. And after that, if assess the healing, and if required, in certain cases where the healing is not satisfactory, you can go for a conventional flap surgical technique along with the regenerative procedures. Now, implantoplasty is also one, because surface polishing by implantoplasty, we bring about surface changes on the implant, because the rough surface on the implant can cause definitely accumulation of plaque and further leading to peri-implantitis. So implant topography should be altered with a high-speed diamond burst, and we polish to create a smooth continuous surface to prevent the inhibition of plaque accumulation. Now, in this, the standard protocol, as per the literature, they use two bursts, that is a regular fine diamond burst and a super fine diamond burst. Then followed by, they use something called as a brownie silicon polisher and a greeny silicon polisher. So this is a standard protocol what they follow, a standard gig. That is a regular fine diamond burr 10S, followed by a super fine diamond burr 10S, followed by a brownie silicon polisher and followed by a greeny silicon polisher, to create a surface which is smooth and which brings about inhibition of the plaque accumulation, or a surface which is going to create a problem later leading to peri-implantitis. Now, surgical in deeper peri-implant pockets, we told that we can think about a regeneration, and we have to do regeneration, guided bone regeneration using a titanium mesh. All these techniques are available. Like in regeneration, we can do along with the conventional flap surgery in a deeper peri-implant pocket. Now, resective surgery is also performed along with, in many cases, where you can see there is a pocket here. So the flap is raised and you can see the osteoplasty is done. So along with the resective surgery, you do an osteoplasty as well as an implantoplasty, as well as make sure that the flap is sutured apically and you get a thick keratinized tissue collar along the implant. And as we are doing an implantoplasty along with the alveoloplasty in this case, along with the osteoplasty in this case, it's better that the smooth surface is created on the exposed implant here, so that the further accumulation of plaque accumulation won't be there on that particular site. So this is the procedure. Along with the resective surgery, we include osteoplasty, implantoplasty, and the flap is placed apically and sutured to get a thick keratinized tissue collar around the implant. So there is some other resective implant therapy. What I have gone through in the literature is, in case of a retrograde peri-implantitis, where you are seeing the periapical lesion at the apex of the implant, they even open the flap and resect the apex of the implant and augment the socket. So that is also one part of the resective therapy, what they mentioned in the literature. But as per the literature, what I've got and what I've gone through the resective therapy, I've included these pictures for your information. Now, lasers are also used in peri-implant procedures. Now it's called as a laser assisted peri-implant procedure. Now laser assisted peri-implant procedure. Now why we are using lasers? Laser is used in edging to the non-surgical debridement or a surgical debridement. Now basic idea of using laser is removing the microbe infiltrated oxide layer from the implant surface. And the advantage of using lasers, it does not bring about any thermal change on the implant surface. Now, when you compare a laser, when you see about the laser-assisted peri-implant procedure, it's basically a modification of the laser-assisted new attachment procedure. So, laser-assisted peri-implant procedure is when you use a laser-assisted peri-implant procedure, it removes the inflamed circular tissue and decontaminate the implant surface, as well as after that, the surface, whatever after you finish the non-surgical, it removes the inflamed sulcular tissue and followed by it decontaminates the laser surface, and then we follow it with a non-surgical debridement. So with the clot which is formed there, basically the clot which is formed there promotes the healing apicocoronally, and definitely it inhibits the downgrowth of the gingival epithelium in case of a laser assisted peri-implant procedures. So the basic idea is you assess, you do the laser assisted basically to remove the microbe infiltrated oxide layer on the implant surface and decontaminate surface without any thermal change as an adjunct to the non-surgical or surgical procedures. So a lot of literatures have shown that there is an immense, comparatively the results are good when you incorporate the laser along with your peri-implant procedures. Ozone therapy is also one adjunct along with your non-surgical debridement, where it is commonly used in the form of ozone water. And ozone has got a strong antioxidizing agent, and it has got a strong antimicrobial activity. And ozone that
Yeah, there are some connection issues from Anil sir's side. We'll just wait for some time. Please wait for some time. There are some connection issues on Anil sir's side. We're just sorting it out. Sir. Glitch on Anil sir's side, so we're just trying to sort it out. Please share your screen, sir.
Yeah. Okay.
No, we can't see your screen, sir.
Hey. You can
yeah.
see now?
Yes, now it has come.
Is it okay?
Yes, sir.
Is it okay?
Yes, sir.
Yeah, sorry, this is because of the net issue. I don't know what is the reason now. I'm using my hotspot and I'm back to the webinar. Thank you for helping me out. And we start with the retrograde peri-implantitis. So just recapping what we have finished. Initially, we started off with the classification of implant complications, followed by classification of implant failures. Then we spoke about peri-implant diseases and then classification of peri-implantitis, then classification of peri-implant soft tissue dehiscencies or deficiencies. Then followed by, we had a classification on treatment protocol on peri-implant disease, and then management part, we spoke till ozone therapy and retrograde peri-implantitis. Basically, normally we see that mainly because the persisting periapical lesion, which does not subside, which is causing the retrograde peri-implantitis. And sometimes the literature has also shown that when it is not late and certain infection, which is also causing retrograde peri-implantitis. So depending upon the periapical lesion, as I told you, there is some resective therapy in severe cases where if the implant length is long, or if you want to remove the apex of the implant and then augment also, it's possible. And depending upon the lesion, we decide if in cases the prognosis is poor, we go for an implant extraction, or then the cases what I've told, we can also think about periapical surgery, debridement, regenerative, and local decontamination, and antibiotics. So this is about retrograde peri-implantitis. The percentage of retrograde peri-implantitis is comparatively very, very less when you compare with the peri-implantitis as such. Now, finally, it's an implant, the failed implant. We implant with mobility. That's if with a severe peri-implant bone loss or unfavorable bone defect, host response is bad, and ineffective surgical therapy, rapid bone destruction. These are all the factors what we put under the failed implants. And the treatment aspect will be remove the implant, analyze the situation, and in case later, if you want to augment the bone and go for an implant, that is also possible depending upon the cause of failure, and you analyze and then go for a treatment plan. So this is all about ailing, failing, and failed implant, and the classification and about the treatment therapy as such. Now, it's very important that in an implant practice, because you have to have a team approach, because you have a dental implant, you place an implant, you need a prosthodontist when you plan an implant, and you need an initial good diagnostic tool to understand what type of implant you have to, what is the size of your place. So it's basically a teamwork, and especially when you're going for a full mouth implant placement, full mouth rehabilitation, it's always better that the team is there with you to help you out. There's no problem like what we discussed earlier about the surgeon state or restorative person state. But finally, it's important is to understand that the implant should not fail, and we have to have a better prognosis for a long time. So identifying all this what we have discussed, and if you can put the classification into place in analyzing it, it will help in the treatment plan for the patient of peri-implant disease. Now, success is the ability to go from failure to failure without losing your enthusiasm. We see, in all cases, we see successful people as only the success part we see in them. We never see the dedication, the hard work, the compromises what they have done, or the sacrifices what they have done, and they would have gone through different phases, but they have been persistent enough to achieve that success in their life as well as their practice. I'm talking about your dental implantologist, for example. When you see a dental implantologist, successful implantologist as such, we have not seen that what all they have gone through. And so it is always better that, considering all these factors what we have mentioned, go through an adequate training and a complete protocol, including the importance to maintenance to come to achieve the success in implantology practice. Now, it's equally important to the summary. It's equally important that you have to emphasize on the maintenance therapy. So I have seen that the possibility of developing inflammation and infection or any complication also should be there in the consent form, which will be helpful to you later to tell the patient about, or if any problem persists, you can tell the patient that it's been informed earlier. So same time, maintenance schedule also should be given. So in some of the articles, I've seen that the first visit, or the first after the loading, after the restorative phase, the first year they have 3 visits, that is 3, 6, and 9 months. And followed by the second year, they have 2 visits, followed by the third year onwards, 1 visit mandatory. So you can have a maintenance chart for each implant patient, so that will help you in giving an idea whether the patient has visited you, or that will also help you in guiding that is the status of the patient. The maintenance chart will give you an idea of the prognosis of this particular case also. Because it's very important, we have seen that the articles earlier, that's a prevalence of peri-implant mucositis. So if the peri-implant mucositis is not controlled, the chances are that it can lead to the peri-implant lesion at the earliest. So it's always important to make sure that the maintenance therapy is also equally important in placement of the restorative part. So this goes the implant placement, the restorative phase, and the third one with the maintenance phase, which is equally important and which probably can be done with the charting properly in the maintenance therapy. So I conclude by saying that paucity of well-controlled scientific evidence against the backdrop of increasing prevalence of peri-implant mucositis and peri-implantitis, and a lack of robust evidence-based treatment options make the prevention of peri-implant disease classifications pertaining to understand the etiology as well as understand the treatment plan or understand the clinical scenario of peri-implantitis, as well as what I mentioned about the advanced diagnostic aids to understand the active disease, to understand the disease progression, as well as to estimate the response therapy about what you're doing on this peri-implant lesion are available. So peri-implant disease definitely treatable. And also the peri-implantitis as such, if you identify the complications or identify in advance, that will be helpful for the treatment part of the peri-implant disease. Once again, I thank Madam and Dr.
Hello. 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 I think we have again lost the connection from Sir's side. We'll just try to get him back for questions. Yes, sir.
Yeah.
Yeah, so there are a few questions from the students. So I'll just take few questions one by one. The first question is, how much is the biologic width around implants?
Hello.
Hello? Yes, sir.
Yeah.
Yes, the first question is, how much is the biologic width around implants?
Hello.
Hello? I just a minute, sir. Hello?
रूम शांतच ठेवूया.
Sir, can you? Hello? 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 Sir, I think the connection has freezed from your side. Hello? Hello. I think there are some network issues from sir's side. Yes, sir. We are just waiting for sir to join back. Yes, sir. Hello. Yes, sir. Welcome back, sir. Yes, sir. Yes, sir. We can listen. We can hear you.
So I'll
Welcome.
email ID for anyone who wants a presentation. I can send it to them. Okay.
Yes. Yes, sir.
Bolo.
So the first question is, how much is the biologic weight around implants?
As per literature, I think the biology bit what they mentioned is comparatively more. That's 3 to 4 mm in the implants when you compare with this 2.07 in the natural tooth. So that is what is the 3 to 4 mm.
Okay. So, second question is, what is the standardized method for measuring probing depth around implants?
Standardized
method for measuring probing depth around implants.
Standardized measure, probably I'm not very sure about that. Probably I have to look into that.
Next is, what is the ideal time for implant loading in various regions of maxilla and mandible?
See, it depends on normally as per literature. Now, as per there is a classification on implant loading also. When it is the straightforward case of D1 and D2, normally the loading time what they mentioned is 3 to 4 months. But if it's a regenerative therapy along with the conventional surgery, normally the procedure, what the time period they mentioned is 6 to 9 months, depending upon the involvement of the defect. That is what, as per the literature, what they're shown as classification.
Okay, thank you, sir. Next is, when normal probing depth is 4 to 5 millimeter, then how can we follow CIST protocol?
No, CAST protocol is, it's last they have mentioned that, probably they have not mentioned, understood that more than 4 mm is basically A plus B plus C plus D. That is a conventional non-surgical debridement plus along with your regular regenerative and resective therapy. So there is an option Other than more than 4 also, it's the last option what they're given in the CIS protocol. And that is modified in ACUT protocol, where they have clearly mentioned that the radiograph or the pocket of more than 5 is along with the conventional debridement plus along with the flap surgery.
So next question is, what is the protocol for placement of implants in infected sites?
We are talking about the negative factors. We have clearly mentioned that what are the negative factors, what will lead to implant failure. So it is always better in compromised cases, the systemic situation as well as the infectious site, whatever you're talking about, take care of that first and then only think about implant placement rather than compromise placement of implant. That is what we discussed in cases where there is a failure in factors contributing to periimplantitis, because persisting periodontal lesion and persisting periapical lesion, that is also one entity which will contribute to the factors of failures in periimplantitis.
Okay. So we have one more question. Can you explain regarding implant dehiscence management?
Implant?
Dehiscence management.
That is what we have, according to classification, the peri-implant soft tissue dehiscence we have mentioned. No? So PSTD 1, 2, 3, and 4. In the 1 and 2, what they have mentioned is basically it is the connective tissue graft along with the coronally advanced flap. In 1 and 2, because in 1 there is no recession as such, but there is a soft tissue thickness is comparatively less. That is why the implant and the abutment is visible. So 1 and 2, where the second is just the emergence profile, the line connecting the emergence profile is more on the palatal side. So for the soft tissue emergence in the anterior, for the 1 and 2, they preferred the treatment aspect. In that article itself, they have mentioned that the 1 and 2, PSTD 1 and 2, it will be CAF plus coronally advanced flap plus your connective tissue graft. And 3 and 4, depending upon the head of the implant, the palatal and the buccal, you will have to have a prosthetic approach along with the other 2 therapies what I mentioned for that. Otherwise, you have to go for a angulated abutment, or in cases of 4, where it is placed on the facial side, more you will have to go for a retreatment of the implant also for the aesthetic reasons. So that is clearly mentioned in the article on the 4 aspects, the treatment also.
Okay, sir. Thank you very much for your presentation, and few other questions we have taken today. Others questions you can directly direct.
Hello? Yeah? Hello? Yeah, your voice is breaking, Neeraj.
Yeah, so we are signing off now. Thank you very much for the wonderful lecture, sir. It was really wonderful to listen to you.
Thank you so much for your cooperation and patience, in conducting all the webinar series. Thank you so much, ISP. Thank you, President and Secretary, for giving me an opportunity. And thank you, dear PG students. Wish you all the best for your exams, as well as take care, stay safe. Very important.
You will tell me when to go online?
Yes, sir. Yes, sir. I am admitting others, sir.
लोगों को admit करोगे आप?
Yes, sir. Done, sir. Just a minute, sir. Just 1 minute.
Come on, start for the link.
You will tell me when to go online?
Yes, sir. Yes, sir. Yes, sir. Yes. I am admitting others, sir.
Yeah.
Yes, sir.
So we are online?
Yes, sir. We are online. All are in. And we'll start with the... Yes, sir. Yes, sir.
You will tell me when to start?
Yes, sir. I'll just start, sir. Presentation, you just start, sir.
Start.
Uh, Good morning. Good morning, all the life members and associate members of Indian Society of Periodontology. So we'll start with another lecture from the ISP lecture series. And today we have Dr. Ashish Jain sir with us. Sir is a past president of Indian Society of Periodontology. Sir is also director of IQSC at Punjab University. And sir is, I still remember listening to sir on various topics and very tricky topics such as periodontal medicine and host modulation. And sir has authority on these topics. So today we'll have a deliberation from sir on from bacterial plaque to arterial plaque. Over to you, sir.
Thank you, Neeraj, and good morning to all the worthy members, associate life members, and others. I see a few others also, logging in. First and foremost, of course, ISP need. Don't worry about that. Balan and Roti. I'll come to that story a little later. But before that, let us. ISP has been really in the forefront when it comes down to scientific deliberations. And they've always tried ways and means and innovations to keep engaging our young periodontists, our budding periodontists, and when that is reflective in a lot of events that ISP does. We little senior in ISP now. I joined ISP probably 1996. 97. So almost like 20 years, and ISP has really grown many folds. So the president, the secretary, and the other office bearers of ISP really deserves a huge kudos for this beautiful event of having us connected, even though things are so sad, things are so heavy outside. But most importantly, I think the person who should get all the credit for having connecting me to you and likewise other speakers is Dr. Neeraj Treasure. I think he has a wonderful alternative career in being a webmaster also. So he really doesn't have to worry much, even if the lockdown goes on extensively. So, friends, the topic today with us is periodontal medicine. This picture that you see, now coming to this picture, all of us are confined to. There's some disturbance, Neeraj.
Sir, if you can use the earpods or something.
I think इसका audio शायद on है.
I'll just check, sir. I'll mute, sir. I'll mute all.
So this picture actually is yesterday's picture. As we are all confined and doing activities which a lot of us are not used to. So this is one such activity that I have been assigned to. And as I was doing this activity, and all of you know pretty much. So my daughter, who was standing besides me, said, "Dad, you are a hardcore dentist." I said, "Why?" So she looked at what is there, on that. So we were trying to make some snacks and all. So she looked at it and that, banate hue bhi you can't really forget a tooth. And then I looked at it a little closely, and it really looked like a tooth. So I just took a picture and I thought I'd share with you. So it's about a passion of dentistry and about what he does. Is what drives us these difficult times. But like all other times, this time will pass too. So coming to the topic, this essentially is an opening statement that I take up pretty much in all my lectures whenever I have to talk about periodontal medicine. Is something like this. You would actually have a lot of patients coming into you, a lot of your colleagues are asking you whether your oral health, you have been hearing so many things about oral health and systemic health, but they are really not sure whether anything in this correlation has any substance in it. So, I get these questions a lot often. You have been harping about perio and systemic link. So is my oral health really related to my heart condition? Patients would ask that. It is easier for us to say yes to the patient. Yes, of course it is. To our colleagues, we may be little submissive in accepting that yes, there is a correlation, and this is essentially coming in pretty much from our convinced enough within me to say substantially that oral health is related to heart condition, and that would happen only if I am convinced within myself. And my convincing myself would essentially come in terms of how much I really know about this topic. We as periodontists really can't have an excuse of not knowing this topic. So today, what we are going to do is, I'll take this journey of periosystemic. I would try to focus more on perio at one end and cardiovascular on other end, and I would like to share pretty much, a lot of my presentation would be on the work that we have done in this particular field, and we have done few things which you will see in next few slides. The idea is, of course, to explain the correlation a little bit. Anybody poses this question to you, you remember that you went through the torture of 1 hour in the in this hard times, wherein evidence was shown, and some of this evidence may stick onto it, and you'll be able to then blurt that evidence out to the person asking the question. What is periodontal medicine? Periodontal medicine is described as a subdiscipline of periodontics, which deals with non-plaque induced conditions or lesions of periodontal tissues, including the periodontal manifestation of systemic disease. So this is what essentially it is. Periodontal medicine is the periodontal manifestations of systemic diseases and syndromes, and the other way and is the systemic manifestation of periodontal diseases. So where would it all start? No brainer. It would all start in the mouth. From what part of the mouth is all about deposits. Now we have classification of these deposits, which can be classified as soft deposit, as hard deposits. Soft deposits are further classified as food debris, materia alba, acquired pellicle, plaque, and hard calculus. So now just one slide each for them. What are food debris? Food debris, where do they actually settle themselves? In open contact areas. If you have mobile teeth, chances are you will not be able to clean that properly, so you will have more of food debris. The irregularities of occlusion, the plunger cusp, the missing interdental papilla, all of this would be housings for the food debris, and hence the subsequent sequelae of that. Materia alba is a loosely adherent mass of bacteria and cellular debris that frequently occurs on top of bacteria. What it contains, materia alba, what it contains are living and dead cells, desquamous epithelial surfaces. I'm sorry about these vendors. So, it's just to give you light. Desquamative epithelial surface, disintegrating leukocytes, and salivary proteins. What are the characteristics of materia alba? That it's a bulky, soft deposit, which is not really adherently bound to the tooth surface, which actually, distinguishes it from the next slide. It is visible without the application of disclosing agent. Another distinguishing feature from plaque, it is white or grayish-white in appearance. What it results in, subsequently, it will result in inflammation, gingival inflammation. It will result in dental caries, which could come from tooth surface demineralization. What is plaque? All of us know exactly what. This probably is not even the right gathering. So I will concentrate only on the definitions for academic purpose, so that all of us are on the same page. I know a few of us sitting on the other side of the computer are probably not periodontists. Plaque is a soft tenacious material. Not that they don't know, it's just that all of us are on the same page. So what is plaque? Plaque is a soft tenacious material found on tooth surfaces, which is not readily removed. As a specific but highly variable structural entity, which consists of microorganisms and their products, all embedded in a highly organized intercellular. A dental plaque is also defined now as a specific but highly variable structural entity result from sequential colonization and growth of microorganisms on the surface of the teeth and restorations, consisting of microorganisms of various strains and species embedded in extracellular matrix, including bacterial metabolic products and substances from serum, saliva, and blood. So plaque is a complicated structure. Certainly it is. All these definitions are coming out from one of the lectures we did, which so dental plaque is defined as microbial ecosystem or a biofilm composed of, this is how plaque stands today. So it is defined as microbial ecosystem. Now we are talking of an ecosystem. We are not talking of just a plain, simple coating onto the tooth surface with probably some kind of bacteria in it with intercellular matrix, and matrix would have some kind of glycoproteins. We are not talking of that. We are now talking of plaque as a microbial ecosystem, which is there as a biofilm. It's a biofilm composed of densely packed microbial structures, insoluble salivary glycoproteins, microbial intracellular products, and to some extent epithelial cells are arranged in an organized complex. So from the starting of plaque, as given by WHO in 1978, to the definition as of today, plaque has really traveled a long path. Today, plaque is not just a film, plaque is not just a deposit. Plaque is an entity, plaque is a biofilm, plaque is tenaciously adhered, plaque has its own character, plaque has its own strength, plaque has its own definition. Plaque is something which is not as easy to deal with as we used to think earlier. And that is why now we are talking. So if it is not, that means it is here to stay. And if it is here to stay, and if it is composed of all such kind of things, then certainly it should have an impact which should go beyond where plaque is. So it is readily visualized on teeth after 1 to 2 days with no oral hygiene. All of us know that it is. We don't really have to wait for even 1 to 2 days. A plaque is there, at least in its initial pellicle stages. No sooner you finish your plaque gets deposited like that. Then what can be done? What we are interested is not the plaque which is immediately there. We are not interested. Okay, we are not interested in plaque as long as it does not start getting its pathogenic potential. So dental plaque accumulates preferentially at stagnant sites that afford protection from the vigorous removals that apply in the mouth. These are the 5 steps in plaque formation. We are all aware of that. It starts with the formation of dental pellicle. Almost soon after, you have finished cleaning your teeth, which is initially colonized by bacteria, mainly strepto, gram-positive, aerobic, facultative aerobics, good plaque. I mean, not technology, but probably a good plaque. But then the initial colonization gets followed up by secondary colonization, and here comes the bacteria brothers, which we don't want them to. In this process, the plaque gets matured in terms of getting a structural entity, in terms of getting a biofilm entity, in terms of getting a very closed, tenacious activity in it. And then after all this has been done and it has not been removed yet, then there is, of course, an active detachment. It's an active detachment, which leads to whatever is there in the plaque, traveling to wherever it can. This is the era, the way the plaque hypothesis has moved from 1880 to 2020 now, starting from the golden age of biology, when they were searching for oral pathogens, which therein comes the non-specific plaque hypothesis. All of you know, wherein it's just a bacteria, which kind of bacteria, which was then moved with specific plaque hypothesis, and then you have new terminologies now. Understand is that once the plaque is there, it essentially has to has to create some kind of pathology in you, and the pathology can be defined as named as pyorrhea, which is more of a general layman term, but a gum disease or a gingivitis or whatever name you want to call it. But then once the plaque sets in, once the plaque gets matured, once the bacteria sets in, have their foot firmly on the tooth in the plaque, that's where they start showing all these kind of diseases, which are right now very localized diseases. So what is periodontitis? All of us know what is periodontitis. It is nothing but a gram neck infection. Slide says infection, but if you have not read the fourth point yet, I would want to argue this. People tend to talk about periodontitis. I have an issue with this. It is not a solely infectious disease. Okay, there may be terminologies wherein people, there would be a group, there would be a school of thought who would say, okay, you don't want to call it a completely infectious disease, let us call it infectious inflammatory disease. Initially, I used to think that probably this would be the right definition of a periodontal disease, of a gingival disease, that it is not infectious, period. It's not infectious. Certainly, it's not only infectious. It is an infectious inflammatory disease. But as more and more evidence is coming out, I am kind of getting convinced that what we are talking of has more of inflammation, immunological component to it than the infectious component. So rather than calling it an infectious inflammatory disease, I would want to call it as an inflammatory infectious disease. And that is how it should rather stay. It's an inflammatory started by an infection, but it is an inflammation. Take inflammation out of this relationship, this will not do anything. You can't really explain it. So I take periodontitis as an inflammatory infectious disease. What happens? There's a destruction of tissue, which is mediated by the host. There are different clinical presentations. All of you know about it. And the pathogenesis is similar to other inflammatory diseases. So the pathogenesis of periodontitis is similar to other inflammatory disease. The pertinent question to ask here is, if it is an infectious disease, I can understand you can talk about a local disease. There's a local tissue, there's a local infection which gets taken care of there. But if it is an inflammatory disease, can this inflammation stay local without any systemic component to it, without any systemic impact? The impact can change, can vary, but without any systemic impact, I don't think so. So what is an inflammation? Inflammation is so that again, all of us know what we are talking about. Inflammation. Inflammation. I'm trying to move this because it is coming in my way. So inflammation is an observable alteration in tissues associated with changes in vascular permeability and dilation. That is what the vascular changes are. Often with infiltration of leukocytes into the prosected. Signs of inflammation, all 5 signs erythema, edema, heat, pain, loss of function. It has 3 stages to it: immediate, acute, and chronic. Leukocytes are the cells to go to. Leukocytes control all the 3 stages of inflammation. Leukocytes originate in bone marrow, and they exit from the blood by transendothelial migration. Once they exit, and I'm talking of a normal hemostasis, once they exit, some of these leukocytes would actually and stay there as resident leukocytes, and your gingival pocket, your gingival sulcus is no exception. So you will have some resident leukocytes set in there, also disease or no disease. Among the most important of them are the mast cells, the peripheral dendritic cells, which are the resident leukocytes, and the monocyte derivatives, such as dermal dendritic cells, histiocytes, and MCPs, and all those kind of things. These are the ones which initiate the immediate inflammation, or these are the ones which is the first line of defense, which comes in contact with the infection right away and have the body respond to it, and this is then followed minutes later by a short-lived period of acute inflammation. Then there is an influx of neutrophils to the area after they exit the blood. So we have resident leukocytes here in terms of dendritic cells pretty much. And after that are the neutrophils which would rush to this area. How would neutrophils rush? There are cytokines and chemokines, which we will come to a little later. So this is the part. This is the state of acute inflammation. If the problem is not solved, it will lead to a phase of chronic inflammation, which is dominated by migration of lymphocytes and macrophages now. So the leukocytes recruited in the immediate, the acute, and the chronic phases are termed as inflammatory leukocytes to distinguish them from the other homeostatic. So, okay, this was a little about what periodontal disease is, what goes on in the mouth. Now before we move on to the other component of our discussion, which is what happens in the body because of what happens in the mouth, at ISP we have been we are very conscious of this. We are very sensitive to periosystemic interrelation. Year after year after year, we have been doing a lot of activities, not only to educate our own people, which is essentially you, but also to sensitize the fraternity outside our family of perio. So it started in 2014, which happened to be my presidency also, wherein we did our ISP colloquium completely dedicated to perio relationship. That's how in fact ISP colloquium started. So we did this back to back 3 events in Delhi, Kolkata, Bangalore, which was actually done in collaboration. Why I'm sharing this as a story, which was done in collaboration with Forsyth Institute, which is an affiliate of Harvard School. And we had faculty coming in from there, and it was done at Maulana Azad Guru Nanak, where it was done. And we traveled. So there was a big set of speakers. We traveled all over the country at these 3 back to back, and it was very jam packed, very very intensive. 6 days, interacted with over 1,200 periodontists, budding periodontists at these 3 towns. And we thought that we did a great job, and we created a lot of enthusiasm in the younger crowd also on periosystemic. I'm talking of 14, which is like almost 6 years back. So we were not really very in India at least we were very nascent in terms of periosystemic at that point in time. However, after doing all this activity, so this is Al Kantarchi and Hatije, of course, besides me. Both of them, friends, we worked together, but they stayed back. And so they were very, very, very kind to have come over to India for 8 days precisely. And out of those 8 days, they were traveling. So they were very kind. Anyway, so after finishing the 3rd one in Bangalore, we were coming back from Bangalore to Delhi. And this is a picture why I'm sharing this is, in the same flight, we came across this article, which is pregnancy and preeclampsia spectrum, and which talks about the risk of preeclampsia, preterm low birth weight babies. So you're very, all of a sudden, she said, not a word was there mentioning oral health has anything to do with preeclampsia. So you can understand, so 6 days all over the country, 1,200, 1,300 people. Perio has a role in preterm, Perio has a role in preterm, Perio has a role in preterm, and boom. The moment we look at this, there was nothing. This was 2014. This is okay. Before we go further, this is, as I said, we were in a nascent stage in infancy in 2014 when we spoke about perio medicine.
at that point in time. But out there, they were serious. They were serious, so much so that there was a joint meeting, and I'm sure a lot of you know about this publication. I don't know whether you have read it or not, but we'll go through this publication a little because it's important. So all these guys, the names that you see at the bottom, is a mix of cardiologists and periodontists. Some of them you would have heard of, for example, Kenneth Corman, James Beck, Bob Jenko, Steve Offenbacher, Thomas Van Dyke, the periodontist. Others are presumably cardiologists, out of which I certainly know Peter Libby, who's working at Brigham and Women, where I also happen to work for some time in my life. Excellent guy, great guy. He's an editor of he was an editor for a long time of New England Journal of Medicine, and which is a huge journal. So all this group came together, and then they came out with a consensus report, which was published both in GOP as well as in the Journal of Cardiology. This is one of the video. Again, another one European workshop, and I'll not just have a look at all the names I said. You see them. Bob there, Bob Jenko, Conman.
Well, this first workshop on periodontal and systemic diseases is a real historical event.
It unites the American Academy of Periodontology and the European Federation of Periodontology in one common workshop.
And so it's quite an exciting opportunity, and one that hopefully will enable us then to give really important messages to general practitioners, both medical and dental, and also to the public, to our patients.
It represents really a key opportunity at a time when we know a lot, but not enough, to define where we are, how we move forward in this next phase to resolve some of the critical questions. So then we define some mechanisms, and those mechanisms do exist.
The first, of course, is bacteria. Periodontal disease is an infectious disease. And we also know that if you have periodontal disease and you brush your teeth, you get a bacteremia, or you get bacteria in your bloodstream. All of these diseases that we're talking about are inflammatory diseases. And so the second hypothesis is that the bacteria themselves are inducing inflammation, which is in fact the link.
In fact, we must always remember that periodontitis is indeed an inflammatory disease on one side, but at the other end of the spectrum, it is the bacteria, it's the infection that is driving the inflammation.
Disease. And the term that's used is attributable risk. So we're looking at how much of the risk for developing cardiovascular disease can be attributed to having periodontal disease.
With respect to heart disease, we know there's an association. We have a lot of evidence for plausible mechanisms, but we don't yet have the intervention trials which show that, in fact, if you treat or prevent periodontal disease, that cardiovascular disease will be better.
Plenty of scientific information linking oral bacteria are able to travel systemically to this fetoplacental unit and then cause. The real proof needs to come from intervention studies.
The intervention studies are the studies that we really need on big numbers and diverse populations that show that actually if you intervene periodontally, diabetes outcomes improve.
We need to provide clear recommendations to the medical profession that they should evaluate whether there is bleeding in the interface between the tooth and the gums and whether there is gingival inflammation. And in these situations, they should recommend their patients for a dental checkup.
Periodontal disease is relatively straightforward.
All these guys, huge eyes that they got together from the Europe and the and they came out with eventually a paper. Small exercise. Let all of us do. I'm going to ask few pertinent questions, and I would want to have your opinion onto it. You may want to write it on a piece of paper because I'm going to give you, or you can just write it in your minds. So the answer is in two parts. One is the confidence description on a scale of 1 to 4, which essentially to the question asked,
how confident you are, from very confident to not confident. So this is something that you think should be your answer in terms of a yes or a no. And the next part would be what the evidence says in terms of where are we to that particular question in terms of the evidence, A being the strongest with well-designed RCT, and U being unknown or no appropriate evidence, just a biased evidence. D is an undocumented opinion of experienced research investigator. C would be multiple case studies. B is the single retrospective case control studies. First question is, recommendation is, patients with moderate to severe periodontitis should be informed that there may be an increased risk for atherosclerotic cardiovascular disease associated with it. What is it on a scale of 1 to 4? You think the answer is. So this is what pretty much a lot of people said so. So this is the level, and 2 actually means that a lot of people said that they are confident. Could be marginally very and not. I'm just repeating it again. Whereas the literature was at the end, which is that there is not much of evidence. In terms of recommendation B, that patients with moderate to severe periodontitis who have one known major atherosclerotic risk factor, such as smoking or family history or dyslipidemia, should consider a medical evaluation if they have not done so in the past 12 months. So patient coming to you with this, what is it that you would want to tell the patient that you should go for a cardiovascular medical evaluation or not? I don't know what you said, but this is what the survey said. Well, this is what those people actually thought so, because the evidence is still not enough. Patients with perio and this time 2 risk factors, should he go for a medical evaluation if not done so in the past 12 months? But the literature is still not conclusive. Rather than being conclusive, still literature is just indicative, not even a proven kind of a statement. Cigarette smoking. All patients with periodontitis who smoke tobacco should discontinue, because this is a major risk factor, of course. Everybody would think so, and that's how the literature also says. Hypertension recommendation. All the patients with perio and elevated blood pressure should be treated to target levels. All of them thought yes, I do. And this is what the literature is. As long as the literature is C and beyond, C, B, and A, we are okay. As long as the confidence level is 1 and 2, we are okay. Second recommendation, with perio, elevated blood pressure should undertake lifestyle changes? Certainly, yes. All patients with periodontitis and elevated blood pressure not controlled to target levels with lifestyle should be treated with pharmacological therapy. Still, there is not enough evidence for that. Should be monitored for worsening of perio? We tend to think yes, but certainly there is no literature for that. Assessment of atherosclerotic cardiovascular risk, including so this is how it goes on and on and on. If you really want to have this, I would strongly recommend each one of you to go through this paper. Very important paper. You should certainly go through this and see how it is. So at ISP, we actually did an exercise in terms of creating, we did a workshop in 2016, I believe, 2017 probably, which was supported big time by Colgate. And we had after 2 days of deliberations, we had come out with a document, with ISP guidelines of periodontal care, which is available for free. Go through it, share it with your fellow colleagues in terms of non-periodontists, because we will not be able to have this thing put in the minds of a non-periodontist till the time they do not get educated enough to actually diagnose a periodontal disease. For them to diagnose a periodontal disease, there is a need for a document, and that this document essentially that. After that, ISP also did in 2019, last year, ISP and the Research Society for Study of Diabetes in India did a combined workshop, which was a periodiabetes symposium, and came out with a document which is again available on the website. After having done all this, after having that depression of SpiceJet magazine, and still continuing doing work in terms of ISP, went across the stream, talking to whomsoever possible. The Endocrinological Society of India, which is a huge society, like Perio, you have Endocrinological Society, and they came with this document, which is clinical practice recommendations, pretty much like our GCP, wherein they have now recommended as a protocol for screening and early detection that dental care screening is also required for the diagnosis, or at least diagnosis indicators for the diabetic patients. So this I really see as a big win for us as Perio family, wherein we have been able to convince our endocrinological friends, endocrinologists all across the country, to now take cognizance of the fact that if a patient is moving around with diabetes, dental care needs to be looked into. So what we will talk today is in terms of perio-CV interrelationship, and I share some animal studies and some human studies that we have done. So one of the earlier works that we did, which got published in Infection and Immunity, this is for your references, the role of periodontitis in the progression of lipid deposition in an animal model. The question that we asked at that point in time to us was, can periodontitis have an effect remote from the oral cavity, or periodontal infection, whether it is a risk factor for systemic disease patients? So you come across all these kind of things pretty much every day in the literature. When this got published in 2003, it made huge noises around, which was picked up by IBCM, Eureka Alert, and was actually labeled as a key article by American Society of Cardiology, essentially meaning that there was an importance in it. Does it make sense? Certainly, yes. And there was no new hypothesis in it. The hypothesis that we are talking now in terms of periodontal disease and systemic disease was something which William Hunter said in 1900. He gave us a theory of focal infection, which said that oral bacteria and infection were the likely cause of most of person's systemic illness in the year 1900, 120 years back. So there was a school of thought going on at that time, when we really did not know much about plaque, when we really did not know much about oral diseases, about different periodontitis, all this. But still, at that point in time, William Hunter said that oral bacteria and infection were the likely cause of most of a person's systemic illness. For 40 years, infections, especially those originating in the mouth, were held to be the cause for most illnesses, and this era was known as focal infection. However, it went into a disrepute. Why so? Because it got into the minds of people at that time so much that everybody started getting their teeth pulled out, because it was kind of told to them that your issues in terms of bad knees, your issues in terms of heart attack, your issue in terms of whatever other diseases, fever, or whatever you are going through is coming from your teeth, from your poor oral health, the bacteria in your mouth. So they started kind of taking that getting their teeth extracted. So it fell into disrepute. This again picked up by Newman in 1996, and this time he said that let this time hypothesis not fall into disrepute, rather it should be substantiated with evidences. And now I'll talk about some kind of it. Does it make sense? Certainly, yes, it makes sense, because it's a chronic infectious inflammatory state in which bacteria and bacterial byproducts, they induce the inflammatory response, leading to release of pro-inflammatory mediators, factors, which via the circulatory system, each organ in our body is connected to the periodontium and therefore connected. Where all periodontal disease can have impact on poor metabolic control in diabetes, risk for cardiovascular heart diseases, risk for non-hemorrhagic stroke, respiratory infections, low birth weight, kidney diseases, arthritis. Now they're adding one after the other, and rightfully so. So where are we today when we talk of cardiovascular disease? Hepatitis, we all know, is a gram-negative infection, and we have gone through this slide earlier. all of you know in terms of what is the pathogenesis of periodontitis, which starts as a microbial challenge, which leads to the host inflammatory response. Then there is connective tissue and bone metabolism gets impacted by the prostaglandins and cytokines produced by as a result of host inflammatory response, and then you have clinical signs. This slide really needs a little bit of understanding that is in cardiovascular disease. So what happens when you have a microbial challenge here? There is an activation of the resident leukocytes. As a result of this activation of resident leukocytes, there is the first line of immune defense, which is the complement activation. And as a result of complement activation, there is a production of the activated complement factors like C3A and C5A. These C3A and C5A then act on mast cells, which then releases histamine and slow-reacting substance of anaphylaxis. This then travels systemically and leads to endothelial changes. What kind of endothelial changes? It actually leads to changes in expression of ICAMs, expression of VCAMs, which are adhesion molecules. These adhesion molecules then essentially helps in the rolling and adhesion of these adhesion molecules are actually produced in the endothelial lining, which leads to the rolling and adhesion of the leukocytes, which show diapedesis, chemotaxis, and by chemotaxis they come here. This is the second line and third line of defense, which cause opsonization and so on. That's how the microbial challenge is taken care of. On the other side, what is atherosclerosis? Till now, atherosclerosis was nothing but lipid deposition. Atherosclerosis is a disease of large and medium-sized muscular arteries. It is characterized by endothelial inflammation and the buildup of lipids, cholesterol, calcium, and cellular debris within the intima of the vessel wall. This buildup leads to plaque formation, and then plaque gets dislodged, and hence you have the outcomes of atherosclerosis as you see. If atherosclerosis was only plaque deposition, and if these five in terms of hypertension, hyperlipidemia, diabetes, family history, and smoking would actually be the only epidemiological reasons for cardiovascular disease, then why is it that only these five would actually account for only 50% of cardiac events? That essentially goes on to say that 50% of the cardiac events are still happening, irrespective in the absence of all of these risk factors. So Peter Libby, you heard his name earlier also. He quoted this in, I think, 2007. To that. So what he says is, hypercholesterolemia clearly predisposes to development of coronary heart disease. Many patients with arterial pathology have serum cholesterol levels within or below the average range. Coronary heart disease frequently affects individuals who lack other traditional risk factors as well. And only recently, and this is Peter Libby saying, only recently have we appreciated that inflammatory mechanisms, they couple dyslipidemia to atheroma formation. So now they've started talking about inflammation in atherosclerosis. And the moment you start talking about inflammation in any disease, all the inflammations within the body starts getting interconnected to each other, including the inflammation in your. What he says is identifying the triggers for inflammation and unraveling the details of inflammatory pathways may eventually furnish new therapeutic targets. And this was published in 2002 in Nature. You know, there cannot be a better journal than this. And this is what it is essentially. So you have this blood monocyte here in this VCAM production. You remember I showed you VCAM and ICAM production as a result of microbial challenge in the oral cavity. As a result of that VCAM production, the monocyte, which was otherwise just flowing through, rolls down and adheres to the endothelium. After that, show diapedesis. After having shown diapedesis, come in the intima. Having come in the intima, it ingests all the lipid droplets there and gets converted into a foam cell, which is so pathognomonic of a atherosclerotic lesion. So, for all you know, this VCAM production could be the result
of the infection inflammation going on in the oral cavity, which is then getting translated into the production of a foam cell and hence the lip deposition. So this essentially kind of correlates. If you really have to ask me to narrow down on one slide, this is one slide along with the slide earlier, I would say that as a result of oral inflammation, the production of adhesion molecules take place. Because of the production of adhesion molecules, you have blood monocytes, which gets converted to a foam cell and hence the plug or lipid deposition in this process. This is how the journey of bacterial plaque to arterial plaque probably takes place. About Sokransky's, he has you know all about it. Now some literature I would want to quote. So for those who are exam going, this is the literature which talks about the association of periodontal disease and systemic disease in terms of cardiovascular disease, coronary heart disease, with all the R values as high as 2.68, which has correlation values. Metila said that dental infections are the only factors outside the scope of classic coronary risk factors which independent association with the severity of adult coronary atherosclerosis in multivariate, and Di Stefano also have kind of said that, and which is a 10,000 patients with a 14-year follow-up. Okay, so that was about an epidemiological evidence. In terms of a mechanistic evidence, in terms of if periodontal pathogens are responsible, have you really been able to isolate and locate periodontal pathogens in the atheroma? So one of the studies done by Bob Jenko, where in 44% of the atheromas, 30% were positive for bacteroid forsythis at that point in time, along with AA and P. gingivalis. So what they concluded was that periodontal pathogens are present in atherosclerosis, where like other infectious microorganisms such as pneumonia, they may play a role in process. Another work by Caroline Jenko at Boston University, wherein this was an in vivo study, wherein they found that P. gingivalis can actually invade endothelial cells, and that Bob Jenko was able to find P. gingivalis in atheromas, and they indicate that it can invade endothelial cells and that fimbria are required for this. However, till that time, there was no animal study on cause and effect. So we asked that question to us, can periodontal infection lead to atheromas? And it was a very simple model. Rabbits were taken, experimental periodontitis was done in those rabbits. And how would you do experimental periodontitis? You tie a ligature and put P. gingivalis every other day. So we characterized rabbit as a model for atherosclerosis and experimental periodontitis. Why rabbit? Because rabbit is a wonderful model when you have to actually talk of atherosclerosis. Why is it so? Because to actually induce atherosclerotic changes in a rabbit, all you have to do is feed them high-fat diet for 13 weeks, and that's about it. The rabbits will develop atherosclerosis, certainly. So we divided them into two groups. One group got periodontal disease, the other group did not get periodontal disease. These were our endpoints. Characterized first we characterized, this was done first time in the literature actually, till 2003, rabbit has never been taken up as a model. So we happen to be the that. So it was on the left of the screen are the rabbit teeth which do not have periodontal disease, and on the right. This is a radiograph showing the bone loss. This is the histopathology. One intact fibers, intact bone. The other has a lot of inflammatory cells into it. And this is how characterization was done. And this is the aorta of the rabbit. Control rabbit, we did not have periodontal disease. The red lesions that you see here are the atherosclerotic plaque. So if there is an iota of truth in our hypothesis that periodontal disease would increase atherosclerosis, what is it that we would want to see, or we hope to see, in an aorta of a rabbit who has been induced with periodontal disease? This red spots here are Sudan-dyed atherosclerotic lesions. So if hypothesis is right, we should be able to see an increase in this Sudan-dyed atherosclerotic lesion. Okay, so if we are able to see an increase, how much increase? So let me now share the test bunny aorta. compare the control bunny with the test bunny, the difference between these two group of bunnies was nothing but induction of periodontal disease. So as a cause and effect, if you have actually induced a periodontal disease in a rabbit who was going to have atherosclerosis anyhow, because of the risk factors, which is diet in this case, you actually make him prone to get more atherosclerosis. You actually add on to his atherosclerosis. So much was the interest in this article that actually it came on the cover page of Journal of Immunology in 2003. To go over it on my research gate, I think this is all. Also, so what are the possible mechanisms? Direct effects of infectious agent, host-mediated events triggered by infection, common genetic predisposition for periodontal disease and atherosclerosis, and common risk factors for periodontal disease. Neeraj, you are there?
Yes, sir, I am there.
So should we call it off or go on? Because I think this will take a little longer now.
Sir, you can summarize in another 10-15 minutes.
Okay, so what I will share with you now. So these were animal studies, and let us have few studies, a few human studies also, more so for the exam going students, and these are all homegrown evidences. Okay. So MCP1 is monocyte chemotactic protein, paper which got published in Cytokine in 2013 out of our lab, wherein what we thought was how we created our story was established through assessment of clinical need for quick, reliable, accurate from the department. So we actually checked for MCP1 in GCF saliva serum. I think we need to let us off and talk just a little on host immune response. What does host immune response does? It activates the host defense. It triggers the inflammatory response by immigration of neutrophils, monocytes, macrophages. These cells, along with local resident cells such as fibroblasts and vascular of inflammatory and immune mediators, which are known as, and chemotactic cytokines are referred. Chemokine, and MCP1 is one such chemokine. So, why MCP1? Because heightened increased MCP1 expression has been observed in several chronic inflammatory diseases such as atherosclerosis. Thus, any increase in plasma level of MCP1 in patients with chronic periodontitis who are otherwise clinically healthy may be hypothesized to be a risk. What we did was, okay, let's summarize. What we did was we had two groups of patients. In one group of patients, we treated them, and the other group was not periodontally treated. And we took all the fluids out of them into the GCF, saliva, and serum, and MCP1 level checked compared to pre-treatment, compared to their disease pattern, and post-treatment compared to their health pattern. And what we found out was that the strong association between GCF, serum, and salivary levels of MCP1 in chronic periodontitis, both before and after treatment. That means after the treatment, the MCP1 levels were decreased not only locally but also systemically in serum. So, and MCP1 happens to be almost pathognomonic, almost etiologic for cardiovascular disease. So essentially meaning by periodontal intervention, we were creating an environment in that individual which was healthy for their periodontal health. This is what it was. Another one was we did another study with soluble CD40 ligand. Again, this ligand, this is soluble CD40, is very closely correlated to cardiovascular disease, and you can actually go through this also, wherein the results were pretty much the same in terms of pre and post treatment, as CD40 levels were drastically down, showing a very conducive systemic environment for the individual, for their health. So I think some of the other work that we have done, I hope all of that would be available somewhere as a recording. But I have pulled out the papers which essentially relate to periodontal disease and disease, and a lot of this have also come from from this Southeast Asia region, which we were for ISP was really fortunate contributed to this with 5 of us, including myself. And it talks very elucidly about. So I think, Neeraj, we'll call it off here. If there are any questions to address now
Yes,
or
sir.
later, I know how it goes.
So they just one question that few students have asked, that what are the possible questions that can be asked from this topic in the MDS exam, and how can they answer them?
What are the possible questions? Okay. So there are two ways how this topic can be addressed for examining students. One is through a very long essay kind of a question, which essentially would mean that you would be asked to build up the entire story in terms of periodontal disease at one end, and in terms of the systemic disease on the other end, and then all the systemic diseases, and create an essay out of it. But if you ask me, I would rather be happy in addressing in actually asking this correlation in depth. Pick up one. Maybe I might want to pick up a correlation between periodontal health and say adverse pregnancy outcomes. So what I really would want to know
Hello.
Is the hyper. I was interested of knowing what student can present us. Can you hear me?
No, in between there was a lag.
Oh, you want me to repeat?
Yes, sir, please.
Yeah. So what I was saying was that I would want to ask this question in terms of specific outcomes. So give me a correlation between periodontal disease and adverse pregnancy outcomes. Give me a correlation between pregnancy disease and cardiovascular disease. So that you talk about the pathology at one end, the etiopathogenesis at one end, but then more important than that, present me some evidence from the literature. So you can take this up as one of the starting from what periodontal disease is, define a bit about periodontal disease, and then you talk about the inflammatory component of the periodontal disease, and from the inflammatory component of the periodontal disease, whatever disease you want to address, talk about the inflammatory component in that disease. There's no point in talking about atherosclerosis and talking about hypertension and hyperlipidemia and all those kind of things. Those are, of course, etiological factors, but what we are interested is atherosclerosis as an inflammatory disease. So talk of inflammatory component of atherosclerosis. Once you have spoken of both the inflammatory component, it will be easier for you to connect the dots. And then you talk about evidence.
Sir, next question is, would it be appropriate to call periodontitis an immunodysregulatory disease?
It is actually okay. Strictly not immunodysregulatory would mean that the disease, the basic pathogenesis of the disease lies in an immune dysfunction. So it is not an immune dysfunction. It is an immune hyperfunction, so as to say. So may not be an immune dysfunction disease, but certainly yes, that it should be an inflammatory infective disease.
Sir, one next question is, can you tell us about CRP in pathogenesis of CVD and periodontal disease?
Okay, CRP is one biomarker which has been used and abused both. CRP, why used? Because it's easier. It's easier, well studied, well evidenced. Easier to pick, easier to study, simple ELISA kits, and boom, you get CRP. But why abused also? Because CRP is a very, very, how should I say? It's a very non-specific marker. You can have a CRP raise pretty much for any of the disease anywhere happening in the body. So CRP could be a correlating threat, till the time we did not have this MCP study coming in, essentially cardiovascular and periodontal disease were being linked through CRP by and large. So now you have MCP, CD40, and others also coming in now. So with more evidences, I would want to lay less emphasis on CRP and more emphasis on markers like MCP.
Thank you, sir. Thank you very much. Here we have taken few of the questions, and we'll just conclude the session, today's session. Thank you very much, sir, for a very elaborate and extensive lecture on this topic. And we are really enlightened by the topic, what you have deliberated today. Thank you, sir. Thank you very much.
Thank you very much, Neeraj. And without you, probably, the entire exercise of this program would not have been possible. So you have been a very, very important source to ISP. Thank you so much.
It's my pleasure, sir. Thank you. Thank you all. Thank you, members.
Everybody, and stay safe. Bye-bye.
नीरज
Yes, sir. You can share the screen now.
स्क्रीन तर केलेलंच होतं मी.
Sir, again you may have to do a thing. So, it's gone. Same option. Yes, sir.
Okay.
Yes, sir. Done, sir.
So do we wait or we start?
We'll start, sir.
Okay, good morning, all of you, and greetings from the Department of Periodontics, VSPM Dental College and Research Center, Nagpur. And before beginning with my presentation, I would want to compliment the ISP head office comprising of the president, Dr. Nymphia Pandit, secretary, Dr. H.S. Grover, and also the coordinator for this Zoom lecture series, Dr. Neeraj Deshpande, who has been doing a very meticulous task as far as coordinating the things required for the Zoom lecture series is concerned. And I have been attending the previous lecture series of the ISP, and I was fortunate enough to be there, to be present for the lectures of the previous speakers, and many things I have excluded, many things I have included in this today's presentation. Today, I have been bestowed with the responsibility of dealing with the topic of clinical diagnosis in periodontics. Now, most of you would believe the fact that clinical diagnosis is a topic which is not related to the theoretical aspects or to the theory papers. But then it does has its importance, it does has its relevance as far as the practical examinations, as far as the clinical examinations goes, because each and every exercise which is present in the practical examinations is dependent on the correct clinical diagnosis and also the various components of clinical diagnosis exercise. Now, I very distinctly remember one of my professors during the undergraduate days who used to say, Neeraj, this is not. Who used to say that eyes do not see what the mind does not know. Now, this was in oral medicine and radiology, but then this is not only applicable to the science of oral medicine and radiology, but in fact, it is applicable to each and every science, and especially in the science of periodontology, because unless and until you anticipate the things, unless and until you know the things, you would not be in a position to diagnose the cases. And for diagnosis of periodontal cases, you need to be aware about what is the normality of the tissues. You need to be aware about what is abnormality of the tissues. You also need to be aware regarding the pathogenic mechanisms which are involved into the abnormality of the tissues, the diseases of the tissues, the treatment modalities which are available at our disposal as far as treatment of the periodontal diseases are concerned, their prognosis, and of course, their diagnosis, and then later on the detailed treatment plan for the patients. So unless and until you know these things, you would not be in a position to successfully practice periodontics. You would not be in a position to successfully treat your patients. So coming on to the definition of diagnosis, as has been stated in the literature, it is the art of chronological organization and critical evaluation of the information obtained of the patient's history, clinical examination, and laboratory investigation so as to identify the disease type and etiology. Now, in this definition, you have two important components. First is the chronological organization, and the second is the critical evaluation. Now, when it comes to chronological organization, whenever we are recording the case history, we need to be very sequential in our manner. We need not be haywire in the sense that right from point one to the end, we need to be following the sequence which is given in the clinical case history taking. Many of the institutes would have a clinical case history recording pro forma, and we need to follow those pro formas so that we do not miss upon important or vital information which is required as far as arriving at a correct clinical diagnosis is concerned. And not only the chronological organization, but then the critical evaluation as well. because many are things which are required to be examined. All the details have to be examined, and during the examination one needs to think why this change has occurred within the tissues, and this critical evaluation would lead us to a correct path of diagnosis. And after this critical evaluation, what is required is the patient's history and clinical examination. Now, patient's history and clinical examination, most of the times what we observe during our examinations is the fact that many students would tend to believe or rely totally on the patient's history. There could be many patients, there could be number of patients who are not aware about their clinical conditions, because most of the periodontal diseases are asymptomatic in nature. They are painless. And so the patient would not be aware that he is affected with some or the other sort of abnormality within the periodontium. So here comes the role of clinical examination also, and we need to correlation of the patient's history with the clinical features which are present within the oral cavity are extremely important. And after this correlation, depending upon our thought process, we need to go in for laboratory investigations, many times which are really confirmatory in nature as far as the correct diagnosis of the disease process is concerned. Now, the most important and one of the foremost things which comes into our clinical pro forma is the overall appraisal of the patient. And amongst them, we have the health history, we have the family history, and the baseline vitals, which are required to be noted, which are required to be reported within the clinical case history. And in the health history, we have the pre-existing systemic diseases, the history of hospitalization, the history of medications, if any, if the patient is taking, the history of abnormal bleeding or allergies. Now, these are especially important because most of the cases which report for periodontal conditions would be in an age group of 30 and above. Now, you would agree to the fact that 30, 35, and 40 years of age, after that, many patients would be affected with some or the other sort of systemic diseases, be it the diabetes, be it hypertension, or so on and so forth. So it is utmost important that you need to record a correct health history. You need to record the history of the patient. Many times it would happen that the patient is not aware about his systemic condition as well. So in these cases, what is important for the clinician is the fact that he needs to go in for a detailed examination, and based on the detailed examination, based on the clinical features which are present within the oral cavity, he needs to assess whether the patient would be suffering from some or the other sort of periodontal disease. And this is especially important in cases of diabetes mellitus, wherein we do find that patients who are diabetic would have a more severe type of periodontal disease, and it would not match with the amount of local deposits which are present within the oral cavity. Now, coming to family history, many systemic diseases do have a tendency to run into families. Say, for example, a diabetic patient, there are increased chances of the offsprings to be affected with diabetes, maybe type 2 diabetes mellitus, but then considering the age of the patient, we need to assess the family history as well. Along with the diabetes, we have cardiovascular diseases, we have the bleeding disorders, we have periodontal diseases. Even periodontal diseases have been known to run in families, and you would have encountered many patients who are affected with periodontal disease. And if you go on to probe the history of the patient would tell that yes, his father or mother or one of his parents was affected with periodontal disease, or maybe exfoliation of the teeth at a younger age. So these things are important. These things are required to be noted, required to be reported in the case history pro forma, so that these minute things would have a cumulative effect and would enable you to reach at a correct diagnosis. As far as the baseline vitals are concerned, it is a good habit to have BP recorded, the height, weight, and the random sugar estimation, especially through glucometers if it is available within the clinical setups at a particular point of time. Now, coming to the importance of health history, it cannot be overemphasized in the sense that it has its own importance because of the fact that periodontal diseases are multifactorial diseases. It's not a single factor which is responsible for the periodontal diseases. It's not a single etiologic agent which is responsible for the periodontal diseases. But then along with the local factors, we have the systemic factors also, which may influence the periodontal diseases. And we need to know the possible impact, if at all it is present, of systemic diseases on periodontal disease. Now, if you go by the literature, there have been reported cases by Khader et al. In the year 2006, wherein it was reported in the Journal of Diabetology, and it has been reported that there are 3 times more chances of occurrence of periodontal disease in diabetic individuals as compared to non-diabetic individuals. And also the fact that if at all you have a periodontal disease and the patient is affected with maybe some of the systemic diseases, then the severity of the disease would be more, the intensity of the disease would be more. We also need to take special precautions in cases of systemic diseases, because of the fact that we may have to adjust the appointments of such patients. We may have to reduce the amount of stress which is given to the patient while treatment modalities, and also the influence of oral infections on the systemic conditions. It has been known that the oral infections would also affect the systemic condition of the patient. Now, there have been multiple studies in the literature which do report that the glycemic control in cases of diabetic patients would not be controlled if at all the periodontal condition of the patient is not treated. And also the fact that there is 3.2 times more chances of reduction in HbA1c levels if at all the patient is affected with diabetes along with periodontal diseases. So these are some of the examples. Now, just to quote you with one more example, which is important and which we have experienced in our clinical practices. In fact, there was a patient a few years back who reported to our departmental OPD. Now, just understand the thing that the patient was a young patient, 22 years of age. He on himself did not have any complaints. What was the reason for the patient visiting the departmental OPD was the fact that one of his relatives was admitted to the medical college of our institute, and since the patient was required to be admitted there for a few days, this patient had to do something and he walked into the dental college. He was referred to the Department of Periodontics for oral prophylaxis. Now, just mind, it was not scaling and root planing, it was oral prophylaxis. Thereby meaning that the local deposits, the quantum of local deposits, the amount of local deposits were very minimal. And this we observed when we did the clinical examination for this patient. But then again, along with this, we also observed that there was a minimal amount, there was a small amount of gingival enlargement.
Hello. Hello. Hello.
Hello.
There is some connection issue at Sir's end. Sir is joining back and will restart the presentation in few minutes.
I think we should start right from the beginning again. Neeraj,
Yes, sir.
it's okay now?
Yes, sir. Yes, sir. Done, sir.
I think we should start right from the beginning again.
Sir, yeah, sir. This health history.
Okay. From the health history. I'm really sorry for the inconvenience caused due to some technical problems with regards to the net connections. But then when it comes to the clinical diagnosis, the first and foremost is the overall appraisal of the patient. Now, in the overall appraisal, we have three important components. That is the health history, the family history, and the baseline vitals. Now, when it comes to health history, we need to know about the pre-existing systemic diseases.
Excuse me, sir. Sir, you have to go in presentation mode. Slideshow mode.
Okay?
Yes, sir. Fine, sir. Thank you, sir.
So we need to know about the pre-existing systemic diseases, if at all any are present within the patient. We need to know the history of hospitalization, if any, by the patient. We also need to know the medications, because there could be a possibility that the patient is affected with some or the other systemic disease, and we may have to alter in coordination with the physician, patient's physician, some drugs or some doses of the drugs. And we also need to know about the abnormal bleeding tendencies and allergies. The family history would encompass about the cardiovascular diseases, diabetes mellitus, systemic diseases which are known to be present into families, which are known to be passed on to the offsprings of the patients, bleeding disorders, and of course the periodontal diseases, because literature indicates that periodontal diseases are also passed on to the offsprings of an individual who is affected with periodontal disease. And baseline vitals, it is also important. It's also a good habit to record the baseline vitals in terms of blood pressure, the height, the weight, the random blood sugar estimation, if at all the glucometer is present within the clinical setup at a particular location. So these are some of the important things which are required to be recorded during the overall appraisal of the patient. And now coming to the first component, that is the health history. Nobody over here would overemphasize the importance of health history, but then it is important for the fact that periodontal diseases are known to be associated with systemic diseases. And if you go by the literature, there are more than 50 systemic conditions which are associated with periodontal diseases, be it directly, be it indirectly. And we need to know about if at all there is any possible impact of the systemic disease on the periodontal disease. This is especially true when we talk about diabetes mellitus, because of the fact that diabetic patients, if the patient is a diabetic patient, then the severity of periodontal disease would be found to be more as compared to a patient of the similar age, similar sex, and similar severity. So the impact of systemic disease would always be detrimental to the periodontal condition, and we need to know about that. It is also a fact that there have been studies in the literature, especially by Khader et al. In the year 2006, which has been reported in the Journal of Diabetology, wherein the authors indicated that the diabetic patients have a also related with the glycemic control of the patient, because if the patient along with diabetes mellitus and periodontal disease together is present, then the periodontal treatment, if it is administered, then there are increased chances of his glycemic control being brought to a normal stage, normal levels, if at all the periodontal treatment is initiated in such patients. So it's always good to know the systemic history of the patient, the special precautions which are required in some of the patients affected with systemic diseases, be it the scheduling of the appointment, be it the length of the appointment which are required for completion of the periodontal treatment. And also the influence of oral infections on the systemic conditions, because the oral infections or the periodontal diseases are also found to have detrimental effect over the systemic conditions, as has been reported by the glycemic control. Also the fact that if you go on to see the lecture series by Dr. Ashish Jain, wherein he went on to speak about the oral biofilm and the microorganisms within the oral biofilm, which are present into the plaques which are present in the atherosclerotic patients, then one may come to know about the importance or the influence of oral infections over the systemic conditions as well. Now, just to quote you with one of the examples which was reported in our clinical setup, in our departmental OPD, it was an experience for us, a lifetime experience for us. It was reported a few years back. Now, there was a patient, 22 years of age, an extremely healthy patient with no signs, symptoms of any intraoral or extraoral disease, who had come to our departmental OPD. Now, the patient came to our department just because one of his relatives was required to be admitted for some systemic condition in the medical institute of our college. And so he was required to be there for 3 to 4 days. And so he thought of why not have a dental checkup being done. So as a matter of routine, he went into oral medicine, and from there he was referred to Department of Periodontics. Now, just mind that this patient was referred to periodontics for a procedure of oral prophylaxis. It was not scaling and root planing, thereby meaning that there were very minimal amount of local deposits within the oral cavity. And when this patient came to us, we did the entire examination, and what we found was that along with a few local deposits here and there, we also noticed a gingival enlargement. Now, this gingival enlargement was very minimal in nature. And if you go on to see the size of the gingival enlargement, it was hardly 2 millimeters by 2 millimeters on the maxillary right premolar, first premolar. And since you all are aware that during your post-graduation, most of you are enthusiastic with regards to treating patients, with regards to taking patients for surgical procedures. So we decided to go in for a gingivoplasty procedure in this patient. We convinced the patient, we explained the patient, and as a matter of routine protocol, since the surgical intervention was required, we advised the patient to go in for a complete hemogram. And when the next day, when the patient came to us with the reports, it was to our utter shock. It was really surprising to note that his hemoglobin percentage was 4 gram%. Now imagine a young patient, 22 years, walking on his own without any problems, without any symptoms, into the dental OPD, and he is reported, he is investigated, and his reports indicate that his hemoglobin is 4 gram%. It was really shocking. And so we referred this patient back to the medical college, wherein his investigations were repeated, and then he was diagnosed with leukemia. And he had to undergo a few blood transfusions, and later on he was referred to Tata Memorial Hospital for bone marrow transplant. Just imagine such shockers, such shocker patients coming to your clinical setups. The clinician would expend quite a few years in building a reputation, a good reputation for himself. If such shocker patients do perplexes, they are not examined, if they are not investigated properly, then these sort of cases do have the capabilities of spoiling the entire reputation of an individual. So it's always better to have a detailed clinical examination, have a proper history, and also have a good amount of good time devoted for the patient's examination. Now, when it comes to dental history, if you need to record the previous dental problems, if the patient has been affected with any of the problems, because it would indicate with regards to the complexity of the situation, it would indicate towards the chronicity of the problem, the moment from which the patient has suffered the periodontal problem. And also, you would know the fact, how serious the patient is with regards to his treatment, with regards to his dental problem. We also would come to know about the oral hygiene regimen, the type and nature of the current problem, its onset and progress, and of course the parafunctional habits. Now, many of parafunctional habits are present, which would lead to various lesions within the teeth, within the oral cavity, which are required to be diagnosed at the correct time, so that you render adequate treatment, you render correct treatment for such patients. Now, just imagine what Dr. Ashish Kumar had explained with regards to occlusal discrepancies, which would lead to a fraction at the serina junctions. They would they would be very similar to the lesions which are caused by abrasions. They would be very similar to the lesions which are caused by erosions in that particular area. And so we need to diagnose the cases, we need to diagnose the correct etiology which has led to the lesion which is present within the oral cavity, which is present within the periodontal structures, or for that matter, the dental structures. Now, when it comes to clinical diagnosis, the casual approach which we have observed over the years is that many students would think that the clinical diagnosis would encompass all the 5 things which are present, which are mentioned over here. The soft tissue changes, the periodontal pockets, presence or absence, the clinical attachment levels and losses, the width of attached gingiva and width and height of gingival recession which is present. But then this is sufficient as far as the superficial screening of the patient is concerned. When it comes to a periodontal examination, you need to have all the things recorded, all the minute things to be recorded into your case history recording, so that you do not miss upon some of the vital elements which are so very important as far as arriving at a correct diagnosis is concerned. Now, it is a good habit to have a photographic documentation for the patient. In fact, each and every patient should be subjected to photographic documentation, which would entail an extra and intraoral digital photographs. It also helps us in record keeping. It also helps us in educating the patient. Now, education of the patient is especially important in periodontics because of the fact that majority of the patients, if you go on to see, if you recollect your 3 years tenure into post-graduation, then you would recollect the fact that majority of them were symptomatic in nature. They did not have any pain, and so they in fact came to the dental OPD. They in fact came to the Department of Periodontics because they were referred for maybe some problem which was present. So under such it is always better to have, it is always better to have a investigative document along with the clinical recordings, so that it becomes easier to explain it to the patient, and then it becomes easier to convince the patient to undergo the required treatment modality. Now, communication for referrals, plan and comparison between pre and post-operative changes. Now, whenever patients do come to the periodontal department, many patients would be required a surgical intervention. Mandibular first premolar, and that is because of a decayed tooth, and along the affected with periodontal disease is affected with chronic periodontitis, which is generalized in nature, moderate to severe. But then the patient, if you go on to ask, the patient has no complaints with regards to the periodontal condition. He is only interested into the decayed tooth and the treatment which is required for that. Under such circumstances, if you have a photographic documentation, if you have the investigational reports with you, if you have a detailed examination reports with you, and if you have previous patients who are treated for such conditions, the pre and the post-operative changes which have occurred into the tissues, then I do believe, and it is a universal truth, that many patients would be inclined to be convinced for the treatment modality which is advised in his or her case. May not be that the patient would immediately agree to the treatment. It may happen that the patient would listen patiently to what is advised to him. The patient may not agree for the treatment right over there, but then there is always a possibility that the patient would have at his back of his mind that there is some abnormality we addressed to. And over a period of time, maybe after a few weeks, maybe after a few months, the patient would again report for the treatment of that condition. So it's always helpful to have a photographic documentation along with when we are doing a clinical exam. We need to record about the facial structures, and if at all there are any abnormalities, the TNJ.
Good evening. Good evening, sir. Good evening, everyone.
Good evening, Ji. Good evening.
Ji, good evening, everyone.
Good evening, sir. Good evening. ਕੀ ਹਾਲ ਹੈ?
ਜੈਨ ਸਰ ਤੁਸੀਂ ਦੱਸੋ ਤੁਸੀਂ ਥੱਕੇ ਹੋਣੇ ਹੋ?
ਨਾ ਜੀ ਨਾ, ਸਾਡੇ ਕੋਲ ਵੱਡੀਆਂ ਤਲਵਾਰਾਂ ਸੀਗੀਆਂ ਸਰ, ਅਸੀਂ ਕਹਿੰਦੇ ਥੱਕ
ਨਹੀਂ ਉਹ ਤਾਂ ਗੱਲ ਠੀਕ ਹੈ ਸਰ, ਬਟ I must compliment you from my heart actually that it has been a tremendous show.
Very right.
much better than expected actually.
Yes sir. Good evening good evening Nivya ma'am.
Good evening, sir. Good evening. कैसे हैं आप?
मैं ठीक हूँ, आप कैसे हो?
ठीक है सर.
मैम मैंने ठीक कहा कि नहीं आशीष सर को?
बहुत बहुत काम करता है, पर ये इसके बाएं हाथ का खेल है. मैं जब जैसे बहुत बहुत लंबा एक्सपीरियंस है.
वो तो हमें पता मैम जो है, बट एक अनचार्टेड टेरिटरी में आके रियली इट हैज बीन अ वेरी यूनिक एक्सपीरियंस. एटलीस्ट आई एम टॉकिंग ऑफ माई सेल्फ, इट हैज बीन रियली यूनिक. बहुत एंजॉय किया हमने.
हाँ, बहुत अच्छा था. वेरी नाइस. वेरी फुलफिलिंग एंड वेरी एक्साइटिंग.
एग्जैक्टली मैम.
No, take your time. I just wanted to be sure that you're on.
Yeah, I'll be there.
Yeah. अब काम है अभय का. All those papers have been turned into him. Now he's sitting with all those papers and trying to, come up with the result just before. I mean, still working on the result. Yeah, अरे result पे काम करो भैया, यहाँ क्या कर रहे हो?
Papers is ready. Posters, 2 categories are ready. 3 are being worked out.
Very good.
Abhay sir, good evening.
Good evening, Dr. Abhay.
Good evening, madam. Good evening, sir. Good evening, all.
सुभाष, क्या हाल है भाई? म्यूट है.
Good evening, everyone.
सुभाष अनम्यूट कर, म्यूट है.
कैसे हो सुभाष?
ठीक हूँ मैम.
Very sad.
वो भी है मैडम, और तबीयत भी इसकी खराब है.
खुद की? तुम्हारी भी तबीयत खराब?
हाँ मैम.
लफड़ा लेके आया है कुछ ये.
Take care.
Bye sir, get well soon.
Good evening, Dr. Nitin.
Good evening, madam. Good evening, everyone.
Good evening, boss.
Good evening.
Good evening, sir.
आशीष बॉस सूट में है.
हाँ जी.
You know what? We are not standing on national anthem. Okay? this much is okay. Nothing beyond that.
Abhay sir, good evening.
Good evening, boss.
हेलो.
अदानी सर, good
सर
evening.
आपकी फोटो नहीं आ रही.
फोटो अभी देखता हूँ ना.
अभी तो आई थी बीच में.
मेरा बैकग्राउंड का प्रॉब्लम हो रहा है.
ओ बैकग्राउंड छोड़ दो सर, मैंने भी नहीं लगाया, वो मेरा बैकग्राउंड भी गड़बड़ कर रहा है.
सर पर आप स्टार के लाइट कर दो थोड़ा. लाइट क्या आ रही है? कब लाइट?
मैंने भी लगाया था, स्प्लिट कर रहे कलर्स.
अभी लाइट गई हमारे यहाँ. So I barely managed to get. I don't have an internet. वो मोबाइल डेटा पे हॉटस्पॉट करके मैं ऐसे balcony में कहीं तो भी बाहर खड़ा हूँ, so I've just put something behind. We still have 10 minutes, right?
Yeah. But ठीक लग
Let
रहा है.
me
I mean, you
try.
don't have to really worry. Everything is looking fine.
ठीक है.
But for your unbuttoned shirt, everything is perfectly fine.
यार क्या बात कर रहे हैं? मैं tie डालूं
I'm
क्या?
just kidding.
ये अब ठीक है?
Perfect है sir.
I hope you are not live. नहीं,
We hope
holding
so.
slide है. ये slide चल रही है
नहीं
ना?
है, नहीं है.
ये holding slide चल रही है. Yeah, I'll just switch off for a video for a moment and I'll be back.
अबे भाई छा गए यार.
हाँ.
Perfect in time. Must have been very difficult. हाँ जी मनीष भाई.
सर सब लाइव हो रहा है, सब सुनाई दे रहा है जो आप बातें कर रहे हो.
Don't tell me really. Okay.
Yes.
Oh man, sorry.
मैंने आपको मैसेज भी डाला है, आपने देखा नहीं,
Okay.
इसलिए मैंने आपको फोन कर दिया.
Okay.
एवरीथिंग जो भी बातें कर रहे हो सब सुनाई.
Oh my goodness. All right, bye. Bye. Behave guys.
I'm more comfortable without that screen behind me. I can't do much about the light. Let me see.
It's okay, not too bad. थोड़ा सा आपके फेस पे अगर लाइट आएगी तो बेटर होगा.
Sir, today also we'll be going live right at 5, no? I will start at 5.
We are already live. Start at
Sir,
5.
Getting a message. Everything is being relayed live. All our conversations.
Yeah.
Please, Neetu, can you manage to put us on mute?
Another 5-7 minutes.
Yeah, but we all should. All this is going live. I just got a message. We can hear you. Light lagao, unbuttoned shirt. ये वो सब. ठीक है.
That's okay, sir. Don't worry.
अभी हाँ करते हैं. This is okay. I can't do anything better than this.
ठीक है सर, ठीक है.
क्योंकि एक साइड पे ही लाइट है, दूसरे साइड पे लाइट नहीं है.
ठीक है, not too bad.
Maybe if I change my direction. Nice, no.
नहीं ठीक है सर, ठीक है.
बहुत चीजें
तो
adjust.
don't fiddle much with it.
Yeah.
We have attendance of 850 in the Audi right now.
Good.
ओए बाप रे.
सर बैठेंगे ना आपके अनाउंसमेंट के लिए.
But that is in the last.
सर वापस मैसेज आया, अपना ब्रॉडकास्ट हो रहा है. आई थिंक वी शुड ऑल जस्ट कीप क्वाइट टिल फॉर अनदर 5 minutes. We are good to go in a minute.
A very good evening to all my esteemed colleagues and delegates. I, Vishakha Grover, on the behalf of Indian Society of Periodontology, is delighted to be here and share this valedictory note. With over 1,500 delegates participating from all across the country, we are here at the closing eve of 19th ISP PG Convention. 3 days passed in the blink of an eye, and loads of scientific ideas discussed, exchanged, brainstormed, and in fact, new ideas born by this time. Three inevitable words I'm sure you all must have been accustomed with by this time. You are on mute. Please switch on your video, or the host will let you in soon. My dear friends, the fear of failures, technical connectivity breakdowns, there were so many things on the mind at the outset. Trust me, when the inaugural ended and first 2 hours session gone by, the load was like taking off the shoulders from the organizing everyone. And today at this time, we are also naturally synced in for the conduct of online event. I hope all of you enjoyed the virtual platform, the tour into the conference venue, as I got a lot of feedbacks about the positive feedbacks about the event. All thanks to our fantastic tech support who were there not only with their competency, but with their willingness to be there with us at each moment of the event. Needless to mention, we learned a lot online. And as they say, the popular belief, all is well that ends well. Honestly, the convention started on with some strong notes in mind, but we are winding it up with a sense of pride and satisfaction. With galaxy of speakers and panelists across representing different parts of world, I am quite sure of the standards of scientific deliberations and the impact it is going to make for all of you. My sincere appreciation to all the participants. You all actually, with your continued presence, demonstrated your commitment to the science of periodontology. I wish you luck in all your future endeavors. My sincere thanks to the organizing team who took on this challenge of taking this mega event on a whole new platform and conquered it all, conquered so beautifully that when I look back, we have some insights which we will be improvising probably our future meetings, whether physical or virtual. In particular, I will like to acknowledge and appreciate and congratulate our able scientific chairperson, Dr. Abhay Kolte, for putting in relentless efforts with his team to plan and realize this program the way we have witnessed it for last 3 days. Thank you so much, sir, for putting in such productive, lively, and intense scientific session. To hear the intricacies, I would like to call upon Dr. Abhay Kolte, sir, the scientific chairperson of ISP 19 PG Convention, to share his address with the delegates. Abhay, sir.
Thank you, Vishakha madam. A very good evening to all of you and greetings from the scientific committee of the 19th ISP National PG Convention, which was for the first time held up in a virtual mode. Dignitaries of the ISP, President Dr. Nimfia Pandit, Secretary Dr. H.S. Grover, dignitaries from the organizing committee of the 19th ISP PG Convention, Dr. Ashish Jain, organizing chairperson, Dr. Anil Melath, organizing secretary, Dr. Nitin Dani sir, conference secretary, convention secretary, our treasurer, Dr. Subhash Chandra Raj, and Joint Secretary Dr. Sibi, and all the other dignitaries who have been instrumental in organizing and conducting smoothly this 19th ISP PG convention. I am really overwhelmed with the response which we have got for the postgraduate convention, and it goes on to say the numbers reflect into the response that we have. It was over 740 papers and posters together that we had to manage in these 3 days. And not only these, we also had our keynote speakers, we also had the clinical training sessions, and we also had the point counterpoint, or the newly renamed Exactly My Point, Your Take sessions. So friends, it has been very rightly said that the team is as good as its leader. And it is also said that the leader is as good as his team. If we go on to see the PG convention, we would realize the fact that these two complement each other. And so it was enabled for all of us to conduct this PG convention in a successful manner. Now, first of all, I would also take this opportunity to thank all those who have helped in conducting these enormous tasks of paper presentations and poster presentations. In fact, we very rightly decided to go in for segregation of our work. The main auditorium was looked in by Dr. Nitin Dani sir and Dr. Anil Melak. The Hall A and Hall B was my responsibility for all the 3 days. Hall C and Hall D was taken care of by Dr. Subhash Chandra Raj, and Hall E, the entire poster session was taken care of by Dr. Ashish Jain. And mind you, these luminaries, these dignitaries did not say a single word as to why they should share the responsibility of scientific program. So we were really fortunate to have a team which gelled on very well. Now, there have been various volunteers who have helped us in organizing this event, helped us in conducting the entire scientific session very smoothly. I would also like to thank our speakers, our chairpersons and judges. They have really done an instrumental job. They were right on time at the start of the session, and after completion of the session, the submission of the results did not take more than half an hour. And this was not an isolated phenomena. In fact, if we go on to see, every chairperson, every judge made it a point that within half an hour, the documents were sent to the office, and this is how we could get the results formulated. The process is still going on, and maybe by in another 10 minutes or so, we would be ready with our results. Till then, I again would request all of you to have patience with us, and I would request Dr. Vishakha Grover Madam to conduct the further proceedings. We would be with the results in a short span of time. Thank you.
Thank you, sir. Definitely, we look forward to hear from you soon. To take on the ceremony further, I would like to call upon our organizing chairperson, Dr. Ashish Jain, for 19th ISPPG convention. Sir, kindly share your address to the delegates at the valedictory.
Thanks, Vishaka. When we started this journey, we probably never realized that you can actually get emotional overwhelmed sitting on the other side of the computer screen after having done the job. But as Dr. Dani also mentioned in the morning, after finishing his job role in the central hall at 11, he said it was difficult to leave the hall, as if he was really sitting in that hall. But that goes on to say the commitment that the entire team showed. That also goes on to say that nothing really is impossible. When we started this journey at HO, at the head office, thinking that, as we said in the inauguration also, thinking that we will try to, take all our brothers to Goa for a good time. But there was something else in our destiny. We could not do that. And then we realized that it has been more than a year. The science cannot just stop like that. We have to move on. So that is when we started thinking in terms of having a digital conference. But to be honest with you, we never thought that this online mode of science transfer would be so successful. To share with you, and we were getting the data in terms of attendance in real time, and to share with you, at no point in time, at absolutely no point in time, any of the halls, including the papers, and main hall is of course different, had less than 200 150 participants. We have been into this PG conventions for long now, and at least in the last 10-12 years, if I can recollect, we would not really see more than 10 or 20 people sitting in a paper hall. But here they were there. They were logged in. They were there in the room. Okay, they may be sleeping in their bedrooms, but they were certainly logged into their room. And the kind of feedback that we were getting, the kind of messages that we were getting, all of us here at the organization team were flooded with messages, with huge amounts of appreciations and thanks and everything coming in, which kind of told us that probably this what we wanted to do has been achieved. And that is why all of us are really little emotional now, when the time is there to say goodbye to all of you, at least for this year, till the time we meet next year. But it really went on very well. Nothing would have been possible at all had each one of us here at the COC not really had taken the mantle of doing this as their own job. We had in COC, fortunately, we had in COC people really senior. We had Dr. Dani sitting there. How would you actually tell, with what heart, with what courage would you ask Dr. Dani to manage the central hall? But we did that. Who would say to Dr. Anil, you please go and manage the central hall? We did that. And what a job these guys did. Surgical precision lectures, not a minute earlier and not a minute late. It doesn't happen in a physical meeting. Papers, the entire scientific program, just imagine, it was not about getting the abstracts and then, arranging 5 halls with PowerPoints and people come in and people go out and that's about it. Here there were more than 800 papers, poster, abstracts, which Abhay single-handedly managed to filter, managed to segregate which one would go into paper, which one would go into poster, made the entire schedule of all the 6 halls that you saw today. It was no easy task to make the schedule of 700 papers, keynote speakers, judges. We had more than 120 judges, I believe, if I'm not wrong. But he made that entire schedule, and along that, managed 2 halls. Somebody like Dr. Abhay Kolte, but he did that, and he did that beautifully well. The poster hall, of course, I was given the responsibility, but then we are all fortunate to have a supporting team in our people, that those who work with us. So we could really pull it through, really pull it through, hopefully to the satisfaction of all of you. We certainly missed on a banquet, but that stays pending from the HO. Of course, we will have our banquet in the evening, maybe even if virtual. So anybody who wants to join it, please join in the banquet. Of course, you'll have to bring your own drinks. We can't really do anything about it. But certainly, we would, as and when the situation gets normal, the Goa trip is pending. It's on HO. So some point in time, sometime, and Anil will not leave us if we do not do an event in Goa. Doing an event in Goa is probably a childhood dream for Anil. So we really have to do a conference or a convention in Goa. But from my heart, a big thank you, a big thank you to each one of you who believed in us, each one of you who supported us, each one of you who were there with us in this journey. This would not have been possible, absolutely, if we were all not together. This goes on to say that ISP is truly a family. And when today we see that a job is well done, friends or foes, everybody has been so appreciative, which again further cements that ISP is nothing but a big family. And let us all stay like that. Let us all make sure that this family grows. Let us all make sure that ISP grows. Because if there is ISP, there is a Perio society to which we belong. We also exist. So again, thank you very much, all the delegates, all the judges, all the chairpersons, all the keynote speakers, all the volunteers, WAMA team who executed the thing so beautifully well. Thank you, Neetu. Thank you, Sejal, Arjun, all then your entire team. Thank you, Colgate, GDC, Medicep, Hufredi, who with us as sponsors, and of course, thanks, President ma'am, Secretary sir. Without your support, probably you did not ask us anything, so that really helped. So we could do a lot of things like that. But we always knew that you are there with us. So thank you very much. And last but not the least, the four musketeers sitting there, Dani sir, Abhay, Subhash, then Anil. Where is Anil? I'm not able to see Anil here. Anil, you are there?
Very much.
Yeah. So thank you very much, guys, and thank you again. Thank you, thank each and everyone. Thank you.
Thank you so much, sir. Thank you. I think thank you is a small word to put through. Thanks to you for being there to stand there as a pivot, as a guideline to sail us through. At least as far we are concerned, definitely, and that's really really put in well words how ISP goes. So, not taking any further, may I kindly request our President-elect ISP, Dr. Anirban sir, for his address to the delegates. Dr. Anirban Chatterjee.
Yeah, thank you, Dr. Vishka.
Yes, sir. Looking forward to hear from you.
No, I'm looking forward to meet everybody physically, as such in the months to come. So thank you, Vishaka. I would like to first and foremost congratulate the entire team for this wonderful 19th PG convention, with the first virtual convention of our ISP. Especially thank Dr. Dani first, because of the precision of work he has done. It's like a clockwork. Already Ashish has told, I don't want to repeat much, but immediately there was messages coming in telling us to log in, telling us to send he used to send the Zoom things immediately to each one of them. It was really such precision work, we, as Ashish Jain told to, that we cannot see during our main conferences also. And Abhay Kolte, scientific chairman, wonderfully work done. So Subhash, Raj, who has also taken care with the scientific part, might be Hall C, D, that doesn't matter, but it was a great teamwork. Anil Melath, great dear friend and great friend of mine, everyone, and especially the president and the secretary, who had been the backbone of the society. Without their help, we couldn't have gone forward. But it was, and Vishaka especially, the host, all the time she has been doing a lot of work. So with this, I would like to just tell thank you very much for giving me an opportunity, and I look forward for the present running year and the next precision year to need all your support, all the big people of ISP support to do this type of wonderful convention. And as Ashish told, hopefully next year we meet in Goa for the PG convention physically. That is what we are all praying for. Let's see. But I think 99% we are going to do that, and we will have a scientific extravaganza like this we had this time. It was wonderfully portrayed and what wonderfully executed conference. I look forward for this with lot of, as I told in my president-elect thing in the morning, the inauguration also, to interact with lot of people from across the world for our scientific sessions, so that we can have a better interaction. Thank you very much, and Jai Hind, Jai ISP.
Thank you, sir. Thanks a lot for all your kind words, rightly stated. Now, I would kindly request our Honorable Secretary, sir, to please address the delegates. Dr. H.S. Grover, sir, Honorable ISP Secretary.
Thank you, Dr. Vishakha. Dear friends, a very warm welcome from the head office of Indian Society of Periodontology. ISP is a non-profit making association of periodontists of India, which was formed in 1975 with the sole aim of promoting and enhancing the knowledge, science, and skills of periodontology in India, especially amongst its student and life members. Dear friends, therefore, it is incumbent upon all of us to strengthen our society by encouraging all students enrolling in our discipline to acquire membership of the ISP as soon as possible. For the benefit of new members, the membership is now available online at the click of a button through our website www.ispperio.com 24/7, and the membership number is allotted practically on a real-time basis. So it is my humble appeal to all to encourage the students as well as the doctor members who have yet not taken the membership to come into the ISP fold and extend our family. Coming over to the last 3 days, you all must have enjoyed one of the best virtual experiences you must have ever had. It involved the top educators in business, both at national and international level. The COC has done a tremendous hard work to achieve this historic first in the annals of ISP, and no amount of appreciation to all these members can do a real justice to what they have managed to achieve. This may in fact become the new normal, as they say. Thank you once again to all delegates, volunteers, speakers, Vama events, our sponsors, especially Colgate. I also offer a huge cheer for all the winners in various scientific categories. We all pray for your success and good health. Thank you and Jai Hind.
Should we call upon the next speaker, sir?
I think there's a little issue with Vishaka. Thank you very much, Dr. Grover, for your wonderful words. And we know that ISP is actually doing great job under your leadership, you being there at the HO, despite all the hardships that we are facing. And thank you for your continued support and encouragement. Thank you very much. And next, if I may call upon our worthy president of the society, Dr. Nivya Pandit, to address the gathering, please.
Am I audible?
Yes, ma'am.
You are.
Yes, ma'am. Loud and clear.
So good evening, everyone, delegates, the ISP, like members, the student members, and the head office of Dr. H.S. Grover, sir. At the outset, I would like to congratulate the organizing team of the 19th PG convention, that is Dr. Ashish Jain, Dr. Anil Milas, Dr. Nitin Dani, Dr. Abhay Kolte, Dr. Subhash, and Dr. Sibi Chindakara, who are, and of course, the team of WAMA, consisting of particularly Neetu Gupta, who were really flawless and excellent execution of this convention. And that too in these challenging times. I can understand the magnitude of hard work that was behind the curtains to have such a precision and quality at the forefront. There's a saying that too much viewing of PowerPoint is really boring, but that's called as the death by PowerPoint. But over here, this proverb was proven wrong because we were all glued to our computers and to our screens. It was a wonderful 3-day scientific extravaganza, including the clinical training and some very useful tips related to the clinical discussions, situations in our done by our foreign speakers. It also included the extensive discussions and deliberations by our moderators and panelists who are experts in their field, and which was related with the most talked about things, that is the periosystemic link and the implant dentistry. The PG convention is especially designed for our budding periodontists. And I'm sure they must be highly enriched in their knowledge, not only related to their academics, but also the clinical skills that was taken up by the foreign delegates, as well as our Indian society stalwarts of periodontics. I would like to conclude by saying by Steve Jobs, which is very apt for the audience of this convention: don't be trapped by dogma, which is living with the results of other people's thinking. Don't let the noise of others' opinions drown your own inner voice. And most important, have the courage to follow your heart and intuition. The ISP head office acknowledges the undaunting support of the EC members and the life members who are committed to the progress of the Indian Society of Periodontology and always have been there to support us in whatever endeavor we took. And were really the real strength between for all these programs and all the events that we undertook last year or this year. And this PG convention has been really one of the most wonderful programs that we have seen in 1.5 years. This has really brought the scientific knowledge and the scientific agendas to a next level. And I'm sure if we go on the physical level, we will miss some parts of this digital world, because here, as other speakers said, that we were glued to our computers, and in the real physical conferences, we really see very few audience and people are roaming around here. Here, there was no way of that. We were trying at different methods how to make the people sit in the halls and listen to all the speakers whom we get with a lot of effort, but there seems to be no way of doing that. And on that aspect, this platform has been really good. And I congratulate once again the organizers for taking efforts for taking up such a wonderful show. And I wish all the best to all the PG students and wish them a very bright future. Thank you so much.
Thank you, ma'am. I'm extremely sorry for the inconvenience because of some, again, net disconnect. But I missed to introduce you, but I'm thanking you with folded hand. President ma'am, without your able guidance, we could not have actually been where we have reached so far, that too in these tough times of pandemic all over. With these words, I will like to call upon Dr. Abhay sir for the much awaited section of this evening, that is the announcement of awards and results of the academic achievements. So delegates, no more waiting for the results to be declared. May I kindly request Dr. Abhay, the scientific chairperson of 19th ISPPG convention, to announce the results for academic awards for this convention.
Friends, I'm aware of the fact that you are awaiting the most awaited announcements of the 3 days. It's not only 3 days, it has been since the past over 1.5 years. You are waiting first for the presentations and then now for the results. But just to brief you with some of the backgrounds, some of the awards which are to be presented at the main conference and which are selected, in fact, in the postgraduate convention of the Indian Society of Periodontology. We have 5 different awards for different categories. The first is Dr. V.N. Bhatavdekar Award for Best Clinical Paper. Second is Dr. K.R. Lakhanpal Award for Best Paper in Preventive Periodontics. Third is Dr. Y.P. Guglani Award for Best Research Paper. Fourth is Brigadier Dr. J.K. Gupta Award for Best Case Report. And the fifth one is Dr. Manish Kolle Award for Best Paper in Implant Dentistry. And looking at the numbers, the Indian Society of Periodontology very rightfully has decided upon a ratio, a fixed ratio, wherein in addition to these 5 awards, we also present with consolation prizes. And the ratio is 1:20. So for every 20 papers or posters, we have 1 consolation prize. So beginning with the presentations, but before that, I would want to say a quote of John Ruskin, wherein it has been mentioned that quality is never an accident. It is always the result of intelligent and persistent efforts. First of all, I would like to congratulate all those who have won the awards, be it the main awards or be it the consolation prizes. Both are really of great importance. But then those who have not done so, I would request them, I would appeal them not to get disheartened, because continuous efforts on a regular basis will definitely see them achieve their targets in due course of time. Now coming to the awards in paper category, the first is clinical research. We will start with the consolation prizes. Now the consolation prizes in clinical research papers, Dr. Meenakshi from TMDCRC Muradabad, Dr. Ankita Bhojak from ITS Dental College, Greater Noida, Dr. Nasreen Jamal from GDC Kozhikode, Dr. Evangeline Ida from Sri Balaji Dental College, Chennai, Dr. Surbhi Gautam from Dr. R. Ahmed Dental College, Calcutta, Dr. Shilpa Matthews from GDC Trivandrum, Dr. Shazneen Khandawala from Terna Dental College, Mumbai, Lieutenant Colonel Dr. Munish Joshi from AFMC Pune, Dr. Divya Trivedi from VSPM Dental College, Nagpur, Dr. Gunderao Kulkarni from ACPM Dental College, Dhule, and Dr. Merlin Thomas from SDM Dental College, Dharwad. Now, these were the consolation prizes. Now, coming over to the main prize in clinical category, that is Dr. V.N. Bhatodekar Award for Best Clinical Paper. This is shared by 2 presenters. First is Dr. Anu Priyanka from Maulana Azad Institute of Dental Sciences, New Delhi. And the co-winner is Dr. Soya Prava Sil from SCB Dental College, Cuttack. So this is about the papers in clinical research. Coming to the next category of basic research. In this, coming to the consolation prizes, Dr. Shreya Bhattacharya from Sri Aurobindo College of Dental Sciences, Indore, Dr. Angeline Fiona from Bharat University, Chennai, Dr. Vaibhav Nangaonkar from Government Dental College, Mumbai, and Dr. Srinivasan K from Indira Gandhi Institute of Dental Sciences, Pondicherry. So these were the consolation prizes, and the main prize of basic research, that is Dr. Y.P. Guglani Award for Best Research Paper Award. This goes to Dr. Aishwarya Khatsne from Government Dental College and Hospital, Aurangabad. So this completes with basic research category in paper presentations.
Then we have the preventive research papers. Coming to the consolation prizes, we have Dr. Nazia Nazir from Mahe Institute of Dental Sciences, Mahe. Dr. Himaju Kurlagunda from G. Pula Reddy Dental College, Kurnool. Dr. Vaibhav Sahani from Dr. H.S. Judge Institute of Dental Sciences, Chandigarh. Dr. Manjari Sauji from Government Dental College, Aurangabad. And the winner for this category, that is Dr. K.R. Lakhanpal Award for Best Paper in Preventive Periodontics is backed by Dr. Ankita Dharmapurkar from Sinhagad Dental College, Pune. So this is about preventive research papers. Then coming to implant research papers, the consolation prize in implant research papers goes to Dr. Amruta Joshi from MGM Dental College, Navi Mumbai. And the main prize, that is the Dr. Manish Kolhe Award for Best Paper in Implant Dentistry, goes to Dr. Tenzing Yutso Bhutia from Himachal Pradesh University. So this is about implant research papers. Then we have another big category wherein we had more number of papers. And in this is the case report papers based on case reports. The consolation prizes have been won by Captain Sunita Manandkar from AFMC Pune, Dr. Asit Kumar Mishra from SCB Dental College, Cuttack, Dr. Apurva Arun from Subharti Dental College, Meerut, Dr. Pooja Naik from YMT Dental College, Navi Mumbai, Dr. Divangana Washi from BVP Dental College, Navi Mumbai, Dr. D. Durga Bhavani from St. Joseph Dental College, Eluru, Dr. Parvati Thenappa from Meenakshi Ammal Dental College, Chennai, Dr. Arunav Gogoi from Vaidhe Institute of Dental Sciences, Bangalore, Dr. Vinisha Bajaj from VSPM Dental College, Nagpur, Dr. Mayuri Raje from SMBT Dental College, Sangamner, and the main prize in case reports, that is Brigadier Dr. J.K. Gupta Award for Best Case Report category, goes to Dr. Catherine Jean from Thai Mogambikai Dental College, Chennai. So this is about the case report papers. Now this completes with the prizes in papers. Coming to the posters, the case report category of posters. In this, the first prize, the consolation prizes are, in fact, all of them are consolation prizes. Dr. Manik Sharma from Army Dental Center, RR Research and R, they have mentioned R and R, Delhi Cant. Dr. Pasumarthi Sai Karishma from Mamta Dental College, Khammam. Dr. C.V. Shruti Vyasini from Pandit B.D. Sharma Institute of Health Sciences, Rohtak. Dr. Kabik Goldar from Kotiwal Dental College, Muradabad. Dr. Swapnil Pimpre from GDC, Aurangabad. Dr. Febi Asta Rodriguez from Krishnadev Raya College of Dental Sciences, Bangalore. Dr. Komal Bombe from SP Dental College, Wardha. Dr. K. Shweta from Al Badr Dental College, Kalaburagi. And Dr. Aparna Tyagi from SGT Dental College, Gurgaon. This completes with the case report category in posters. Then coming to the implant research posters, we have only one prize for this, and this is won by Dr. Gautam Nanavati from AFMC Pune. So AFMC Pune has had a rich harvest as far as the prizes in different categories are concerned. Now coming to preventive research category in the poster presentation. In this, the prizes are won by Dr. Rutuja Ghogre from Pandit Deen Dayal Upadhyay Dental College, Solapur, and Dr. Radhika Kherdekar from AIMS, Rishikesh. So this is done with preventive research posters. Then coming to basic research for poster presentations, we have the prize winners as Dr. Soma Sindhuja from GDC Aurangabad, and Dr. Shruti Devasya from Oxford Dental College, Bangalore. And the third one is Dr. Jasmine Angel from JKK Nataraja Dental College, Umar Palayam. And the last category in the poster presentations is clinical research posters. In this, we have Dr. Venkatesh T from Vinayak Mission Dental College, Salem, Dr. Shubham Zabak from SMBT Dental College, Sangamner, and Dr. Neha Garg from Maulana Azad Institute of Dental Sciences, New Delhi. So this completes the prizes in different categories for posters and papers. This was really an Herculean task which would not have been completed without the team support. I would like to thank all my departmental staff. I would like to thank all the departmental staff involved at Chandigarh, involved at Cuttack, involved at Mahe for doing a wonderful job. They have been really bang on time for submission of the results, for completion of all the allotted duties. So without wasting much of your time, I would again like to congratulate all the prize winners, and those who have not made it this time, I would wish them better luck the next time. Thank you.
Thank you, Abhay sir. Hats off really to the job accomplished. It's really great on your part, the way it has been handled. And many congratulations to all the winners. We do miss the big smiles and the rounds of applause in the auditorium in a physical meet, but nevertheless, there are awards for the achievers, and there is valuable feedback, lessons taken for the participants. Next, I would like to call upon Dr. Anil Melat sir, the organizing secretary for 19th ISP PG convention, to share his valedictory address to the delegates.
Good evening, everyone. Respected President, Madam Nimfia, Dr. Nimfia Pandit, Secretary of ISP, Dr. Grover sir, organizing team led by Dr. Ashish Jain, office bearers, EC members, life members, and students watching this valedictory function. It's indeed a proud moment for Indian Society of Odontology to see that the first ever virtual PG convention concluded in a grand manner. So congratulations to the entire team for doing the wonderful job. Going back, recollecting 2019 November till March 13th, where we worked for the convention in Goa, and where Goa was a totally unknown place for our entire organizing team. And we had done everything possible in a grand manner. Probably nobody knows about that. Everything was booked, everything was finalized, including whatever, nothing was left. And last minute on March 13th, sadly, we called off the event. And from there, that's the first time I'm working with Ashish, being an organizing chairman. And I saw his leadership quality. I saw his dedication to whatever he takes, what I've learned from him. And adding Abhay sir as a scientific chairman and Nitin sir as the convention secretary. And I know them because I was privileged to work with Abhay sir when I was a president. He was the Honorable Secretary of Indian Society of Odontology. Dr. Nitin was the immediate past president. The commitment and dedication, and it's really worth, and the energy what we get working with the people like this is really, really great. And even when I was talking with Ashish regarding the virtual platform, I still recollect, we were initially hesitating that because everywhere Zoom conferences are going on, whether we'll get enough people. But he told us one thing, let us stick to the best possible platform ever, and we'll do the best. And that word today, after completing, I repeat that we have done the best virtual convention ever in the history of the Indian Society of Odontology, or any other society for that matter. So thanking the organizing committee, once again, special thanks to Ashish, Dr. Abhay, Dr. Nitin Dani, Dr. Subhash as a treasurer, Dr. Sibbi Chennangada, and the entire team, including the volunteers, who did an excellent job. And special thanks to Abhay sir. I know how meticulous he is and how how he does the work. And yes, we can see that it's really appreciating to see that all the programs were lined up on time without any break, and everyone contributed. So special thanks to Vama, Neetu and Sejal, and anytime you call them, immediately they are with an answer and they're with us. That's the beauty of this. And special thanks to moderators, all the speakers, panelists and volunteers, and all who are involved in this wonderful 19th first ever ISP-PG virtual convention. And let us hope that Dr. Anirban, whatever he said, let it become true, and let us all meet in Goa and for the 20th ISP-PG convention. And I was sharing yesterday with Dr. Ashish, one more thing what we could have added is a banquet. We could have added some programs and had a session from 8 to 10. And probably in the next virtual, if it's virtual, we don't want virtual. If it's virtual, definitely we'll try to improvise the virtual platform. Anyway, thank you once again, everyone. Thank you for a wonderful leadership quality shown by all the great people, as well as all the participants, the delegates, who contributed in a grand manner. Thank you. More importantly, stay safe and take care. Thank you so much.
Thank you, Anil, for, amazingly, you put your feelings, in fact, everybody's feelings into words. Yeah, really. Who better can actually conclude it? He doesn't like me to be using this word, but you certainly are our Bhish Pitama, sir. So may I call upon Dr. Nitin Dani to bid all of us farewell as of now, for us all to meet again. Dr. Nitin Dani, the whole stage is yours, sir.
Thank you so much, Ashish sir. But before I say something, I would like to call upon our dearest friend, Dr. Subhash, who, in spite of the misfortune that has fallen on him, just took a day off and was back doing his work in spite of his ill health and problems in his family. So I would like to hear a few words from him, and I would like everybody to thank him from the bottom of their hearts so that he gets the courage to fight with this situation. I call upon Subhash sir first, and then I will say a few words.
Thank you, sir, for your kind words. A very good evening to all of you. Respected President Nimpia ma'am, Secretary H.S. Grover sir, all the organizing committee members headed by Dr. Ashish Jain sir, all the speakers, delegates, chairpersons. So I'm very sorry that I could not join for the introduction program as well. And neither I have been logged into any of the programs due to unavoidable situation. But while I'm going through the messages today and the day before yesterday, I can say this is one of the best PG convention. Maybe it's a virtual convention, but it is one of the best convention, and everybody has a high word for the virtual platform, particularly the Vama people. And the scientific was excellent. Abhay Kolte sir and all the volunteers, those who have worked for this scientific program, it was on time. All the results were transferred on time, and even I has to transfer the WhatsApp to all my people, those who are working for this. So though I was physically not present at the venue, but I would like to thank my students, because of whom this hall C and D, I hope it was managed quite well. So Dr. Sipsankar Pradhan, Dr. Saida, Dr. Osit, Dr. Swamprabha, and Dr. Lakshmi. So thanks to them, during my difficult time, they managed it very well. And I'm so happy that I am there when we started this, that we will have a PG convention at Goa. but due to this COVID pandemic situation, we ended in the virtual platform. But it is, I think it can be a better than the physical convention, though we missed the banquet. So I'd like to thank all the organizing committee members, particularly Dr. Ashish Jain sir, Dr. Dani sir, Dr. Anil Milat sir, and Dr. Abhay Kolte sir, and all the ISP head office president and secretary, and all the executive members, all the chairpersons. I think in hall C and D we have around 70 chairpersons. So all were in time. And so big thanks from my bottom of heart for this successful event of virtual PG convention. Thank you. Thank you so much.
Thank you, Dr. Subhash sir, and we are all with you. In your difficult times, feel free to call us anytime you want. Now, as my dear friend Ashish has said, that I must say the last few words. He knows me, I like to have the last word in every meeting, in every discussion, in every argument. Well, this journey of the 19th ISP-PG convention started way back when in the year 2019, I think. There weren't any bids and the head office decided that we should do the convention, and which better place where everybody of us likes to go is Goa. And like Anil said, everything was in place in March to 2020. In fact, we liked the year also, 2020. But then misfortune came upon us. We thought, even like all of us thought, that this virus will go away in a couple of months. The physical convention got postponed to September, but where the virus is still very much here. So we took the decision to cancel the physical mode, and we thank the ISP head office led by Dr. Pandit Nimfia Madam and Dr. H.S. Grover sir, who reposed their faith in the COC of the Goa conference and asked us to go ahead with the virtual conference. At the outset, I was a little skeptical because not being in teaching, not being on any Zoom platform, not being doing anything, whether it would happen. But it has happened, and it has happened flawlessly with surgical precision, exactly bang on time. And most of the credit goes to the three people at the top: Dr. Ashish Jain, the chairperson, Dr. Anil Melat, the secretary, and especially Dr. Abhay, the scientific program. They kept talking about their team, but I will just give you some numbers of their team. These three people, supported by myself and Subhash and Sibi, 16 speakers, 32 chairpersons, 240 judges or more than that in the session, so and 30 volunteers. So about a team of more than 300 people interacting continuously, not only in the last 3 days, but over last so many days. And not to forget the people from Vama, Neetu, Avni, Sejal, and the rest of the tech team. They all made it possible. They all made it possible for us to come together, to see each other, to actually feel that we are there in the convention. And the best part was that it went on too well. Wonderfully planned by Ashish. When he said, how did he think of putting me in the main hall? That is because being almost the senior most person in the ISP, except for many others, of course, there I'm not that old, but I could use my clout and bully all you people, chairpersons and speakers, to be on time, because we just wanted everything to flow well in time. I raise my hat off to the international faculty, Dr. Alian Ramanos and Dr. Amit Mohindra, especially because on a weekend at 4 a.m. in the morning giving a presentation, I mean, the dedication is really wonderful. I'm sure all of you also enjoyed moving around on the platform. So 3 cheers for that. Like a typical delegate in a conference, I would get out of the Zoom meeting, go back to the platform, go to hall A, go to hall B, go to the exhibitors. I went all over the place. I used all the facilities. I chatted, video chatted with my friends. That facility was also there. So in all, like Anil said, except for the banquet, we got a perfect feel of everything. And it is really very difficult to imagine that from tomorrow we'll not be seeing each other, but definitely we will meet. And before I wind up, I just want to tell everybody who is listening in that this WAMA website is going to be live for another 2 to 3 days. All the programs that are conducted have been recorded and archived. So you just visit any hall you want. On the right hand side is the agenda tab. You just click it and you find your program that you missed and you can view it. Such a wonderful system has been created. And I'm sure you can download your certificates. Also, if you cannot do it today or tomorrow or day after, you can do it till the website is live. And once again, I take this opportunity to thank everyone, the 800-900 delegates who presented the papers, the 300-400 people who worked from front end, back end, and everybody who attended for making it a wonderful show. From my side, Fir Milenge, and this time it will be in person. Thank you all so much.
जरूर मिलेंगे सर ब्रेक
Yes,
के बाद.
and now we will play the national anthem, and that will end the ceremony.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे तव शुभ आशीष मांगे. गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
So फिर मिलेंगे.
Yeah. Goodbye. Take care.
Goodbye everyone.
Bye. Take care.
Bye.
Bye.